SSBMT conference. As usual, the second day will be the hematopathology overview. And hopefully we will have an excellent and successful event similar to what happened yesterday. First, I would like to thank the SSBMT for their excellent and great arrangement. And special thanks to the chair, Professor Ahmed Al-Askar. Today we will have a theme in regard to lymph node pathology, mainly lymphoma, and also we will discuss issues of non-neoplastic lymphoid proliferation. We have 3 sessions today, inshallah. Yesterday we started around 9 a.m. So people again today they think that we will start 9. So hopefully we will get more people with time. With no further ado, I would like to invite our chair for today's first session. I would like to call Dr. Rima Rabih. She's consultant hematopathologist from King Fahd Specialist Hospital, Dammam, and Dr. Fatima Algo Ahmed. She's also consultant hematopathologist from King Fahd Medical City.
موجود نبدا ايش احس مكتوب الساعه 9. لا للاسف الناس السلام عليكم صباح الخير. It is my pleasure to introduce Dr. Saeed Al-Shayban. He's a consultant anatomic pathologist and hematopathologist from King Abdulaziz Medical City National Guard Affairs in Riyadh, Saudi Arabia, an assistant professor of pathology, King Saud bin Abdulaziz University for Health Sciences in Saudi Arabia. He obtained his MBBS from the College of Medicine, King Saud, in 1996 and joined King Saud University Fellowship Program in 2011 and completed his residency in 2016. He also obtained a fellowship in hematopathology from Hammersmith Hospital, Imperial College of London on 2011. He has more than 15 years of experience in hematopathology with a main interest in lymph node pathology. He has more than 37 abstracts and publications in peer-reviewed journals.
Assalamu alaikum and good morning again. Thank you, Dr. Rima, for your kind introduction. Today I will talk about a very important topic that we usually practice, but we don't really went through the biology and the usefulness of this practice, which is the use of CD30 in hematolymphoid malignancies. So there are a lot of things we need to discuss about CD30 and how to read it and how to apply it in our lab. So my aim today is to make on this important topic. So we know that CD30 had been first described in 1982 by using the Key1 antibody, and at that time they called it actually Key1, and even CD30 positive lymphomas at that time they called them Key1 lymphomas. And the aim at that time, it was discovered on Reed-Steinberg cells as a tool of diagnosis of Hodgkin lymphoma. Then in 1985, it also had been observed that it is strongly and diffusely positive and in anaplastic large cell lymphoma. And since that time, it started to be used as such. So what is CD30? CD30 is a member of the tumor necrosis factor receptor superfamily. And we know that tumor necrosis factor superfamily is when they get activated, they promote proliferation and survival of the cells. So CD30 actually is a tool to help the cell to survive more. So when we look to CD30 action, CD30 usually is very close to the tumor necrosis factor, especially R1. They usually work together. So once the substrate for tumor necrosis factor R1, which is TRAD, gets linked and adjunct to TRAF2, which is the substrate of CD30 receptor, both they cause an activation signal to NFB kappa B pathway, and this will aid to cell survival and help the cell to survive more. But what happens when we do or use CD30 anti-CD30 antibody? This will degrade TRAF2, and there is no junction between TRAD and TRAF2. And this, instead of get activation for NFB kappa B, it will cause failure of activation. And NFB kappa B have an alternative pathway. When it gets this disruption, instead of cell survival, it will activate the apoptotic pathway. And this will help in asking the cell to die. And this is how actually anti-CD30 idea arose. So CD30, as we know, it is very, very helpful marker in a lot of daily work. So it can be expressed in neoplastic cells, mainly hematolymphoid in general, like Hodgkin lymphoma, anaplastic large cell lymphoma, and other non-Hodgkin lymphomas also can be expressed. We will see in a minute. Another non-lymphoid neoplasms like systemic mastocytosis also can express CD30, and some even non-hematolymphoid neoplasm like embryonal carcinoma and some mesenchymal cell tumors can also express CD30. Not only that, CD30 can express by activated normal cells, activated lymphoid cells, especially in autoimmune diseases and also in viral infected situation. And also in the resting or non-tumor cells, that is, circulating there and there, like some lymphoid cells, and also can be seen in decidua and endometrial cells, some pancreatic endocrine cells or exocrine cells, but these are actually very limited expression. When we look to hematolymphoid or lymphoma expression for CD30, you can see it is very variable and heterogeneous. Some of the lymphomas have 100% expression for CD30. And actually, it is a must to have CD30 positivity for these to be called as such. Like anaplastic large cell lymphoma, lymphomas actually, whether systemic or cutaneous, and also in Hodgkin lymphoma. However, other lymphomas, mainly T-cell lymphomas and B-cell lymphomas, they can express CD30 in very variable way, and this will help sometimes in diagnosis and also in prognosis and treatment. So, how CD30 used in lymphoma pathology? As you can see here, I divide it into categories. CD30 expression is a must and required to be there in these types of lymphoma. The classic Hodgkin lymphoma and subtypes, and also in different types of anaplastic large cell lymphoma, whether systemic or cutaneous, whether ALK positive or ALK negative. So it is a must. And also lymphomatoid papulosis, another cutaneous lymphoproliferative disorder or lymphoma, where CD30 expression is a must to call it as such. CD30 expression is useful, but it is not a must, but it is very useful when you are dealing with these cases. The primary mediastinal large cell lymphoma, gray zone mediastinal B-cell lymphomas, EBV positive diffuse large B-cell lymphoma, different types of post-transplant or peripheral, or post-transplant lymphoproliferative disorder and other immunodeficiency associated proliferations, lymphomatoid granulomatosis, EBV positive mucocutaneous ulcer, and some types of angioimmunoblastic T-cell lymphomas. And there is also a lesser expression, less frequent expression in these entities. In peripheral T-cell lymphoma, NOS, but this is actually very variable, we will see in a while. Enteropathy-associated T-cell lymphoma, primary cutaneous T-cell lymphomas, mainly MF and MF transformation, diffuse large B-cell lymphoma, NOS, and small B-cell lymphomas even, like follicular lymphoma, marginal zone lymphoma, and CLL. They can also express CD30, however, in a lesser amount. T and natural killer cell lymphomas, large B-cell lymphomas with plasmablastic phenotype, and also sometimes can be also, which is confusing, expressed in low frequency in nodular lymphocyte predominant Hodgkin lymphoma. When we look to how people read CD30 and how they explain or diagnose certain types of lymphoma based on CD30 expression, it is also variable. And as you can see here, there is some sort of discordant between experts on this entity, and it is varied between 67% until up to 95% concordance rate. And we know there are a lot of aids or helpful tools to help to solve these issues based if CD30 actually is not interpreted very well. When we look to different types again of T-cell lymphomas, we can see that 100% of cases of anaplastic large cell lymphoma, and also so whether systemic or cutaneous, whether ALK positive or ALK negative, and also lymphomatoid papulosis are 100% expressing CD30, while the rest of T-cell lymphomas have very variable expression, sometimes from totally negative up to more than like 70% expression. So how to use CD30 in our practice? CD30 is very helpful in these situations, can be used as diagnostic marker, as prognostic marker, and also for the treatment options. In diagnosis, we know that it is essential to have CD30 expression in classical Hodgkin lymphoma to differentiate it from mimickers like nodular lymphocyte predominant Hodgkin, and also in anaplastic large cell lymphoma. And CD30 should be considered the standard care in the diagnosis algorithm for peripheral T-cell lymphomas, because this is very helpful for the diagnostic issue and also for the treatment options. And also we can see an example here, like how CD30 can be helpful to distinguish different types of T-cell lymphomas. If you look to the expression of CD30 in anaplastic large cell lymphoma, which is very strong, uniform, and almost in all cells, all neoplastic cells, how it is differ from CD30 expression sometimes in peripheral T-cell lymphoma, where it will be variable, weak, and also focal expression. I will show you some examples of or cases. This is a case of classic Hodgkin lymphoma. As you can see here, it is very beautiful sclerosis with nodularity. And if you go high power, you can see the atypical or RS cells, which are very unique or uniform, expressing CD30 in almost all the cells. And also we can have some help from CD15 and also the way how BAX5 is expressed to give this diagnosis. In contrast to its mimicker or great, cousin, which is the nodular lymphocyte predominant Hodgkin lymphoma, where you have the same cells, the same RS-like cells. They are the L and H cells, which most of the time they are CD30 negative. And this is how CD30 help to distinguish between the two, with the help of other tools like CD20 expression, strong OCT2, and also the presence of helper T cells around the tumor cells by using, for example, PD-1. This is an example of ALK positive anaplastic large cell lymphoma in this lymph node, as it has its classic infiltration by the sinusoidal or subcapsular pattern. You can see here those large cells are filling the sinuses. They are very strongly and uniformly expressing CD30. And here we can get the use of ALK to have the the definite ALK positive diagnosis. In contrast to another case which shows sheets of large atypical cells, and some of them they show this kidney shape or hallmark cells, what we call. And CD30 is really very helpful in these cases to say this is most likely anaplastic large cell lymphoma because it is strong and diffuse. Like in this example, you can use the ALK negativity to say ALK negative, and most of the time in these lymphomas, EMA can be negative also because usually it is positive with ALK positive, but also it can be positive in ALK negative. Like in this example, you can see weak expression of EMA. Cutaneous anaplastic large cell lymphoma is the same, but only the location is differ. So we have sheets of tumor cells showing Reed-Steinberg-like cells, and again, the tool is CD30 way of expression in these examples. So when we have a known tumor, or if you receive in your biopsy what looks like lymphoma, large cell lymphoma with Reed-Steinberg-like cells, we call them, of course, the differential diagnosis at the beginning, maybe it is carcinoma or melanoma or large cell lymphoma. So we usually did this panel. This is a short panel that just to help you to understand how to make these algorithms. So usually we use keratins, and also we use CD45 or at the beginning, and S100. So if S100 is negative and keratin is negative, so most likely we are dealing with lymphoma, even if CD45 is negative. And we need to do CD30 within a panel. So the panel is different types of panels you can choose. But for example, in this case, if we have CD30 positivity and we have CD20 negativity, CD3 negativity, so most likely we are dealing with a CD30 positive hematolymphoid malignancy, and most likely it is whether Hodgkin lymphoma or anaplastic large cell lymphoma, because other CD30 positive B cell lymphomas usually expressing CD20 and other B cell markers, and other T cell lymphomas express CD3. But in this example, if 20 and 3 is negative, that means we have only classic Hodgkin lymphoma and anaplastic large cell lymphoma. So we will do CD30, and CD30 positivity with negative EMA, ALK, and positive CD15. So most likely we are diagnosing classic Hodgkin lymphoma. If CD30 again is positive, this is means positivity with negative B cell markers and negative CD15, and EBV is also negative. ALK is positive, so this is ALK positive anaplastic large cell lymphoma. If ALK is negative, so most likely we are dealing with an ALK negative anaplastic large cell lymphoma. So this is just an example of how we use CD30 in our practice. So in prognosis, again, CD30 is very helpful in prognosis. For example, in diffuse large B-cell lymphoma, if diffuse large B-cell lymphoma express CD30, it show a better or favorable prognosis. But if CD30 positivity accompanied by EBV expression, this indicate poor prognosis. So you see how variable the prognosis based on CD30 and other tools. In peripheral T-cell lymphomas, CD30 expression usually associated with adverse reaction. However, if you go to the researches in this, you see different cutoff expression. In some, like here in this example, this research, they mentioned that the cutoff is 30%. If it is more than 30% or less than 30%. In another reference, they make 80% is the cutoff. So the baseline is CD30 may show adverse reaction in peripheral T-cell lymphoma. However, in mycosis fungoides, again, it is variable. If mycosis fungoides show CD30 positivity without transformation, this indicates worse prognosis. But if there is a transformation from mycosis fungoides, and it is CD30, of course, positive, this is favorable, actually show favorable prognosis. So you see how it is variable in this setting. In treatment, of course, now we have the anti-CD30 drug, which is really very helpful in treating CD30 positive lymphomas. So what is the anti-CD30 antibody? We call it, brentuximab vedotin, and actually it had been, first, described or taken from this gentleman, the marine mollusk. They use a substance that is, inhibit proliferation of cells and activate apoptosis. So what they did, actually, they took the chemical protein, which is the anti-CD30, and link it to an antibody by using a peptide linker. And they call this protein as DE, sorry. And how it works, when it's linked to CD30 receptor, it is immediately internalized inside the cytoplasm and travel to the lysosome. And in the lysosome, as you know, we have the peptidases, actually, and it's start with dissolving the linker. So what happened during this? The MMAE is released from the antibody and linked to the tubulin in the DNA, or that is used for DNA duplications, and it disrupts this tubulin and cause failure of division of the cell, and it make arrest at G2 and M phases of the cell cycle. Once this failure happened, it activates, actually, the cell has no way except to die. So apoptosis will be activated. So how to test for CD30? Actually, when you look to different examples of lymphomas, you can see these results. You can see totally negative CD30 expression. You can see a very diffuse and strong expression of CD30 within tumor cells. You can see very variable expression in tumor cells, from moderate to weak and focal. And sometimes, or even you can see expression in non-tumor cells in the environment of the tumor. So all these have meaning. And you know that labs are differ in their protocols, differ in their threshold, differ in their reading. That's why CD30, actually, when it's moved from one lab to another lab, you will have different results. Some people will call it focal positive. Some people will call it, no, I will say this is negative because it is focal, not diffuse. This variation actually causes the problem of heterogeneity in these explanations. That's why this group of from North America, actually, they are from 14 different hospitals. They are 14 hematopathologists and 2 clinical hematologists. They sit together and they work very hard to make a very simple and helpful consensus on how to test CD30 and how to read it and make it universal. And actually, they did a very great job. So as a summary of this publication, I will give you the most important hints. Immunohistochemistry testing is the preferred method because there are other methods in immunohistochemistry to identify CD30. And they use tonsil as their recommended protocol control tissue, not anaplastic large cell lymphoma, not a case of Hodgkin lymphoma, and we will see why. And this is actually recommended by the Nordi QC, which is the North Scandinavia quality control assurance program, which is widely used worldwide to help on mastering immunohistochemistry. So they use the Nordi QC recommendation. So tonsil is the preferred control. What are the other methods can detect CD30? They can use multispectral imaging or computer-assisted evaluation, gene expression profiling. Actually, those 2 methods, they detect CD30 in almost all cases of T-cell lymphomas that is examined by these tools. And actually, this when you compare immunohistochemistry, many cases are CD30 negative by immunohistochemistry, but positive by these tools. So that means there is no, actually, it is not really very helpful. And in addition, these tools are not widely used, and actually no protocol on how to use it yet, no consensus. That's why they don't recommend using these methods as a detector for CD30. Also, flow cytometry can detect CD30, but the problem, and it's very sensitive, but not all the time. Once the cell gets larger, it is difficult to be, move through the tube system within the flow cytometry. And sometimes it can also fail to detect cases where there are rare CD30 positive cells. So the current recommendation for different phases of CD30 immunohistochemistry assay that the steps must be optimized and consistently implemented in all phases that we use in the lab, starting from pre-analytical to analytical and post-analytical phases. So tissue in the pre-analytical, it is recommended that it as usual, as we know, it should be fixed in 10% buffered formalin, and up to from 8 to 72 hours, not less than 8, and preferred not more than 24 hours. So you can use a tissue fixed for up to 24 hours. Fast fixation is not helpful, which lasts less than 8 hours. It is not recommended to use that. And in analytical, the protocols and control tissue should follow the Nordic QC protocols, and they are all available in this website. And in the analytical phase is our read, when we read our report CD30. In post-analytical, how our colleagues in clinical hematology use CD30 results that we put in the report to help in managing their cases. So this is the summary of the recommendations about CD30 testing and how to read it. I will explain it in this slide. So, of course, you will receive the tissue, whether needle core biopsy or excisional biopsy or incisional biopsy. So first recommendation is that you just evaluate the tissue. Is there any harm to the tissue or artifact that make your judgment on the reporting affected? So like if there's any crush artifact or necrosis or rare tumor cells, you need to report it first when you report CD30. Then you can read the expression of CD30 on tumor cells. So you need to give exact percentage. If the percentage is between 0 and 10%, 0 for negative, you can say negative 0%. If it is 1%, you say 1%. If it is 5%, you say 5%, until 10%. Anything beyond 10%, you can, report them in intervals. So you can say 10%, then 20%, 30%, and etc. This will make it easy for you. Then you need to report the CD30 expression in non-tumor cells. Why is that? Because the trials that used anti-CD30, they found that even in CD30 negative tumor cells, if the tumor have CD30 positive in the environment, they found that some cases are responding to anti-CD30 even if the tumor cells are CD30 negative. So also you need to make that in your report. So these are just an examples here on how you reflect this in your report. For example, in first case, you can say CD30 negative in tumor cells, and you put percentage 0%, and positive in in tumor cells, and positive in non-tumor cells, and you can say what is the percentage. If you can. If you don't, you just describe it. In some, in more, or in numerous. However, that is in non-tumor cells, not in the tumor cells. They don't recommend to make numeric or counting the tumor cells in your report, just the percentage. The second example, for example, this case has a necrosis on it. So you just say there is a necrosis which may hamper the result. necrosis present, for example, 30%, then CD30 is positive in tumor cells 2% and negative in non-tumor cells, and that's it. So what is the moral here is that although there are 2% tumor cell positivity, however, this is maybe because of a lot of necrosis is there. So this will give the physician a chance to even use this low number and treat the patient if they need to treat. So this is how the recommendation tell us about CD30. This is the control that is recommended to use. This is the tonsil and have different expressions. It is recommended that the tonsil used should have a large or expanded germinal center, because this is the area where you will find heterogeneous expression of CD30. As you can see in this example, some of the cells are strongly positive, some of them are moderately, and some of them are weakly positive. This will help you to compare your results with this control, because all type of staining are acceptable: weak, moderate, and strong. And even the expression, it should be membranous or cytoplasmic or Golgi or the combination of the three, but not nuclear. Nuclear staining is a false positive staining. It shouldn't be used as positive. This is another area where you have germinal center which is small, not expanded. Look at the CD30 within the germinal center. It is not like the expanded one. So expanded germinal center is an excellent. These are different variations seen in different tonsils. That's why tonsils are better to use, because here you can see the expression in the interfollicular area. And here you can see weak expression, again, not in the germinal center because of the size is small. Sometimes even you can use the endothelial cells, because endothelial cells can express CD30 as also helpful. I mean, any type of staining appear in a tonsil is acceptable. So in summary, different types of lymphomas can express CD30. Some of them, they can reach 100%, like Hodgkin lymphoma, and different types of anaplastic large cell lymphoma, lymphomatoid papulosis, and other can have variable expression of CD30. There are some difficulties in recognition of some entities because they overlap between the morphology and even by immunohistochemistry, like in Hodgkin lymphoma, where we can see in angioimmunoblastic T-cell lymphoma, some of cases they have large number of RS-like cells, and this will confuse us and think this is a Hodgkin lymphoma, not angioimmunoblastic. And we saw some examples, cases called as angioimmunoblastic or peripheral T-cell lymphomas with Reed-Steinberg-like cells. They call them as Hodgkin lymphoma, but they are not. And diffuse large B-cell lymphoma, EBV positive, because they can have a large number of CD30 positive cells. And anaplastic large cell lymphoma, the great mimickers are Hodgkin lymphoma and also metastatic melanoma by morphology, but we can, by immunohistochemistry, solve this issue. CD30 expression is the rule in Hodgkin lymphoma and anaplastic large cell lymphoma, as we know that it is a must. It should be. It is essential. And it can also be expressed in other lymphomas or malignancies and even non-neoplastic cells. We also know that CD30 can be target for the therapy, anti-CD30, in Hodgkin lymphoma and anaplastic large cell lymphoma, in peripheral T-cell lymphoma expressing CD30 positivity, and also in CD30 positive diffuse large B-cell lymphoma. And techniques for measuring CD30 expression is in general reliable, and techniques threshold for predictive sensitivity to CD30 target therapy are also under research. That's why we need to give this percentage, because different hospitals, they treat differently. Some people, they accept only more than 10% CD30 positive to give anti-CD30. Some hospitals, they still use lesser. So you need to just give the percentage and leave the decision for them. Because again, it is under research, not yet there is an agreed percentage. And there might be a mistake rate or a discordant rate in the diagnosis of CD30 positive lesions, and we can solve this issue by improving the quality controls, the teaching experts, consolidating reference centers, and by providing second opinion diagnosis for difficult cases. And thank you very much.
Thank you, Dr. Said. We'll leave the questions at the end, or okay. We have time for questions. Any questions, please?
Yes, yes.
Dr. Bakhshi.
Assalamu alaikum. Thank you very much, Saeed. Yeah, I just want to comment on this, the Nordic quality control that we actually performed in our hospital. There's actually a program, it's called Nordic Upliftment, CD30 Upliftment Program. That is really good, revise the other labs. And what we did is we actually changed a lot of our settings for CD30 immunostaining, especially using the detection technique, which is we have both, ultra view and the OptiView. So we are very happy with OptiView. If anybody is interested to go and visit that website, also participate in the program. They send you slides, and then you stain, and they tell you what's wrong with your slide, what's wrong with your staining, and what you can do to improve. So actually, I would say definitely recommend it for the labs who haven't done this. Nordic QC.
Any other question? Thank you, Dr. Nasser.
Assalamu alaikum. يعطيك العافية Dr. Saeed for this very amazing topic presentation. My question is, we start to receive CD30 as sort of like proficiency with the CAP, ارسلوا لنا. So the latest one that we received, I believe that most of it was negative or very weak. And one of the questions that they mentioned, is it positive or negative, and the intensity. So my question is how to assess the intensity for CD30 in the reporting.
That's why when you use proper control, you can just identify the intensity. That's why using tonsil is very helpful, because it usually they have in tonsil very strong, moderate, weak, so all in one control. And you can just compare your result with the control, and you can make the interpretation, whether it is moderate, weak, moderate, or strong expression.
So in the beginning, we just adjust our eyes to the control intensity, and then we assess the intensity في التيوبر tissue اللي عندنا.
Thank you. Any other question? Okay. Then we'll move to our next distinguished speaker. It's my honor to present Dr. Nasser Bakhshi. Since 2008, he has been serving as a consultant in hematopathology and anatomic pathology in King Faisal Specialist Hospital and Research Center in Riyadh. In 2022, he took the role of program director for the hematopathology residency training at the Saudi Commission of Health Specialties. More recently, in 2023, he was appointed as a director of the fellowship program in hematopathology and blood transfusion at King Saud University and King Faisal Specialist Hospital as well. You can go ahead. Thank you.
Bismillah wa salatu wa salam Rasulullah. Thank you very much, Saeed, for inviting me and organizing this event. So my topic, as you can see there, is very focused on certain molecule. So it's going to be heavy, but I'll try to simplify as much as I can. I apologize, I don't have a disclosure statement, but I disclose that I don't have any conflict of interest, okay? No financial interest too. So we have the agenda for today regarding the CMIC. We will cover a lot of things, including some basic science regarding CMIC. Again, I will try to make it simple. Then we'll go over some of the lymphomas that are associated with c-Myc dysregulation, and the techniques, how we detect in clinical practice, some idea about the difference between outcomes, the c-Myc positive and c-Myc negative tumors, and then some learning points in the end. Okay. Everybody knows what a pro-oncogene is, or before that, about the definition and utilization of the correct terminology. So we all know that c-Myc, is it c-Myc or is it Myc? So it's used interchangeably. So honestly, the correct word is Myc, because that's what it has been. Am I too loud? That's what it has been designated in the human genome nomenclature. So Myc is the actual name, but it's been utilized over ages as c-Myc, so it's fine. So in my presentation, you will see both used, c-Myc, Myc, so just bear with me with that. So you know what proto-oncogene is. So proto-oncogenes are basically like not oncogenes, but at the basis of like their action is that when they get wrong, they become an oncogene that basically get crazy after a certain, dysregulation or mutation or something that happens to that gene. So examples, c-Myc, obviously, Myc is one. Then we have KRAS. Then we have BRAF, JUN, many false. There are many oncogenes that we know that have a proto-oncogene existence, and they can transfer into oncogenes. So c-Myc is one of those. So it was identified back in 1978. And also, very interestingly, the first discovery of a translocation, actually, in lymphomas was in 1982 with the discovery of c-Myc and Ig G translocation with 814 being characteristically described in Burkitt lymphoma back then. So that's the discovery. But about the two other types of c-Myc that we also need to know, there will also, we'll mention them in our presentation. One of them is N-Myc, and another is L-Myc or Myc-N or Myc-L, either way. So these are paralogs. Paralogs means they have very similar genes. Something very similar to hemoglobin A, A2, which just have the similar sort of gene, but a little bit difference in the protein structure. So, and it's very frequently involved in a lot of human cancers. More than 50% of human cancers, maybe 75%, some people claim, have c-Myc dysregulation. Okay, so that's a little bit introduction about c-Myc. So we'll go a little bit about, so as you mentioned in this figure, we have the prevalence of lots of human cancers showing the amplification of c-Myc, and you can see initially N-Myc and L-Myc was considered to be very specific for certain tumors like lung cancer or neuroblastoma, but over the years it's now been proven that they can be involved in other cancers as well. So just keep that in mind. Okay, so a little bit of basic pathology. So you understand that it's basically located in the chromosome 8 in the long arm. It has 3 exons and 4 promoters. And the interesting part is that one axon, exon 1, where the promoter 1 is located, is a non-coding. Exon 2 and 3 are the coding exons. And the part of we need to know is some of the promoters, especially promoter 2, are basically under the influence of a lot of other things. And when it happens that they translocate mostly and amplify, it is the promoter 2 that becomes basically out of control, or it gets basically excessively active to cause the proliferation or increased activity of Myc gene. So at the bottom, you have the structure of the protein, and it's 439 amino acids, but a little bit different for N-Myc and L-Myc. So one important thing you need to remember is that c-Myc has a very short half-life. Messenger RNA has a very short half-life, even the protein, because it's tightly controlled in the body. So once it's released to do its job, after that it kind of finishes its activity and goes back silent or is inactivated. So this is because it has so much role in proliferation and apoptosis and other things. We'll talk about it. So it has to be tightly regulated. So that's why it's a very short half-life normally. And as I said, these are the sort of the other protein structures, very similar to the c-MYC, as the N-MYC and this L-MYC, they are very similar protein structures. So one of the things also need to identify is that there is another protein or another factor called MAX, which stands for the MYC-associated X factor, which is always needed for c-MYC to act. So it forms a dimer with the MAX, so MYC, MAX mix together and form a dimer, and that acts on the DNA to cause proliferation or whatever activity is needed. So this is how it is known to work. And there are many signals that would affect how c-MYC works. So these signals have been listed. I mean, we're going to go into details, but a lot of them are very important. And so it can be, so Wnt, or, you know, even the other receptors that are activated can help, you know, get this c-MYC active. We'll talk about it as we get very clear in the other slides. We'll talk about the lymphoma pathogenesis. Okay, so what is the effect of c-MYC? What normally it has a lot of functions. Some people use the word super transcription factor for it. So it orchestrates so many important functions in the body. That's very difficult to actually know how much role it actually plays in the reason is that because you can see some of the activities listed here, including immune surveillance, cell cycle, metabolism, DNA repair, everything seems to be affected by c-MYC. So this is one of the reasons that c-MYC has been sometimes, you know, not being able to target for pharmaceuticals, because some people describe it as an undruggable molecule. So because it's so difficult to have a hold on this, because it has so much activity, and it can be activated by many things, so both ways. So it also needs very tight regulation. So as I mentioned, if this tight regulation goes off balance, so c-MYC turns and works as the oncogene and results in cancer. Or in cancer, it can be lymphoma and anything else. Okay, so now we come to the other part of the c-MYC. When does it go wrong? What happens that causes the c-MYC to be overactive, dysregulated, out of control? So the mechanisms that lead to it are shown in this picture. How can you use the diagram? Okay. So the common ones are translocation, gene amplification, and this is the one which we're more interested in here. Then there are other with increasing signaling. This is not common for c-MYC to get dysregulated, but it sometimes these two go together. Whereas this is another mechanism where actually just a change in the phosphorylation of one of the residues or motifs of the c-MYC can result in c-MYC being stable. As I told you, it's tightly controlled. mRNA, messenger RNA, is immediately inactivated. And so is the protein. It doesn't last long, but that is because there is phosphorylation. It's acted upon by enzymes, which degrade it. But if there is a change in phosphorylation that happens in certain pathways, then it can be stabilized. That means it can be there for a longer time. The longer it stays, the more effective it will be in causing cancer. Okay, so so these are the list of, I already showed you the picture, but I just wanted to emphasize that in humans, the cancers that are caused by c-MYC are not due to mutations. So it's one of the genes which is not affected by mutations. So it's not a mutation of c-MYC. You haven't heard of like mutation of c-MYC commonly, like we have mutations for, say, FLT3. So this is not like that. So here it's the overaction or the activity of c-MYC is due to the increased amplification of c-MYC as well as the translocations. We'll talk about it in the lymphoma pathogenesis. So in this picture, I mean, I just wanted to bring to notice to you guys that there is a lot of things that we know about different cancers regarding c-MYC, but as you can see in this picture, the amplification is the primary mechanism for the c-MYC to be overactive or dysregulated. Whereas mutations is very rare, very rare. In very few number of cancers have mutations, a very small number. Okay. So I'm sure everybody knows how B cells develop, and this is a sort of a very simplified version. And it's called, is key to understand how c-Myc causes lymphoma pathogenesis, because so we know that B cells are derived from the bone marrow, and they are naive before they enter in the germinal center. In the germinal center, they undergo the process of blast transformation, and then the somatic hypermutation, and then there is a selection, affinity-based selection of in the light zone, and then some of them go back to the dark zone, what we call dark zone, or the active part, the blast formation, go back, and then formally some of them mature, some of them get selected out, some of them get apoptotic. So this is kind of simplified process that we know about what happens in the germinal center and the proliferation and the B cell development. So it's very clear that the role of c-Myc that we know is that it is restricted. The role of c-Myc normally is restricted to the light zone. It does not have any role in the dark zone, because there it is actually switched off. So it is needed. So what is the role of c-Myc actually in the germinal center? I mean, I told you about its role in the body, in apoptosis and other things, but in the germinal center, actually the real role of c-Myc is it that the cells which are circulating between the dark zone and light zone, it is needed for these cells which are in the light zone. That means the cells which are in the light zone, which are not selected out, to go back. So it is go back to the dark zone to undergo further divisions. This is the key role of the c-Myc. And once this is dysregulated, or it's not controlled, or it's gone out of whack, then you can basically expect the c-Myc continuously send cells back in the dark zone. That's where the proliferation happens. That's where all the activity happens, and that's where actually the lymphomas of the dark zone we know of come, like Burkitt lymphoma, high-grade B-cell lymphomas, and double-hit lymphomas. I just try to make it very simple. So I maybe in this diagram to be a little bit clearer. So this is the dark zone with black here colored, and this light zone. This is just schematic. Doesn't mean actually it happens like this, but this is the blast transformation, and then they go to the light zone, and where there is selection, affinity-based selection, with the help of T cells and FTCs, and then some of the cells transfer back into the dark zone to go further divisions, and this process continues, and some die, are left out, and some progress and get mature and become plasma cells and mature B cells and the memory cells. Okay, so far, how are we doing at the time? So I'm just covered with the basics. I hope it wasn't either oversimplified or wasn't too complicated, because I don't know what's the fine line. But anyway, so I'll try to make it sort of more appealing to the audience. But there's a lot of details I haven't really gone into, so I skipped a lot of things here. So now we go to the clinical part of the c-Myc application, the first part, which Said nicely showed in his CD30 lecture, that how we should be correctly applying quality control and the testing strategies correctly in clinical practice to get the best out of the test and also help our clinical colleagues. So for c-Myc, the testing, the way we test c-Myc, where we need to test c-Myc and how we test is very important. So there are various techniques, how we are utilizing. So as I told in the beginning, there is no mutation. It's very rare to use a c-Myc for mutational analysis. So it's not to be utilized like in that way. So there are other means that we can find how c-Myc can be dysregulated or overactive or wrong in the body or for a certain cancer. So one of them is doing karyotype. Karyotype is very simple, easy, and it checks out a lot of things for us. Excuse me, sorry, let's go back. Sorry. So this has a lot of advantages. Obviously, it's slow, it takes time. It has this biggest disadvantage is obviously that you have to have fresh specimens, so it's not always possible in clinical practice. Whereas FISH is easy, faster, can be automated, but again, you're targeting only one molecule or DNA piece of DNA, so you will be missing some other things. CGH and SNP arrays are very similar. They are faster, but they can be also utilized on fixed tissue. Fish, as I said, fixed, whether you are sending a fixed tissue or formalin, fixed formalin embedded fixed tissue, or you are sending fresh tissue. Fish can be used, so can be CGH and SNP arrays, but these are a little less common in clinical practice. PCR NGS, and there are some sequence like fusion plex and some other targeted panels that can assess for these mutations. Again, PCR is very hard because there are many breakpoints in the c-MYC region, so it's not going to be easy to develop an assay for that. But some labs or some centers may actually do it just for confirmation of the fish. So just to show you that, we said that it can be done on fresh tissues. This is a bone marrow. It shows nice Burkitt cells. And then you have the fish positivity. We'll talk about the break apart and the other probes. So, and then the fish, the karyotype, which is really nice to know because one important information you get from karyotype is which you could be quite helpful in doing the sort of analysis of a certain tumor, is whether the karyotype is simple or is complex. So what does that mean? Simple means that is only one rearrangement. That means 814 or any other rearrangement. You can also check for rearrangement with other non-IGH sites. Also, if it's complex, you can also find other deletions, abnormalities, and other losses. So that will be also helpful, because if it's complex, it connotes something different. If it's simple, it's almost always Burkitt only, like it's a Burkitt lymphoma. It's considered a simple karyotype. Okay, so the thing that we have to do as a pathologist, I mean, I'm not a cytogeneticist, but we do come across a lot of cases of lymphoma. So almost invariably now, almost all large cell lymphomas get tested for our c-MYC as well as BCL2 and other things. So our main job is to identify the area of interest. So this is a very important job we have to do and identify. If you send garbage to the lab, so they're going to get bad results. So you have to be very sure that what you're sending, you will never send a necrotic material, you will never send a crushed area, you will never send something which is not clear, or you never send something which is normal-ish or normal-like. So you will send only the tumor, and you will send a viable tumor. In this case, and you have to circle it. And again, labs are not happy in sending huge chunks of specimen to them or areas, so you will have to select the best area, okay? So you have to work closely with the fish lab in order to get the tests right. And so here it's like how the signals are. As you can see, fish signals of the other case I showed you, the first one, bone marrow, is very clear, right? It's because cells are separate and there is no overlapping, whereas now you go to the sections and the paraffin, there's a lot of overlap. It's not so easy to interpret, plus the paraffin embedding, the presence of formalin fixation that causes sometimes problems, although it's been optimized, but it's still not easy to read. So we talk about two types of probes that are used in fish. One is a break-apart probe, one is the dual fusion probes. These are kind of complementary. So ideally, both of them should be used, but some people just use break-apart. At our lab right now, we just have the other probe, but we don't use it as frequently as we should. So what is a break-apart probe? Break-apart probe is, okay, I think I'm going a little bit faster. Yeah, break-apart probe is more or less a probe where you are basically finding the gene by flanking the sides of the 5' and 3' areas. And then so you would like to see both the gene, for the gene to be intact, you have to have both the signals there, right? This is the first one. If it's not intact, the break-aparts, you have two signals, and that's your wrong result, or that's your positive result, sorry. So then in the dual fusion, so you're basically probing both the genes of interest where there is fusion expected to be. So you have a gene 1 and a gene 2 here, in this case like MYC and IGH. So in this, normal signal would be each will be separate. So since we have two pairs, two chromosomes, so it will be two signals for each. So anytime there is fusion, you will find this type of signal. So this is the opposite of the break apart. So that's a little bit more I will talk about in the Burkitt lymphoma. I'm going to just our next topic, which is the immunohistochemistry of IHCH for the MYC, which is a very controversial topic. Everybody wants to know more about it, how to utilize it. It's so easy, but it has a lot of problems. So what are we doing now in MCH, in the ICH for the MYC? So we have a lot of studies showing that it is good. Some studies showing it's not good. It's not really so particularly, I would say, reliable. But there are some things you could utilize it for. It's definitely not the best way to utilize it for screening the cases you would like to send for FISH, because it's not concordant with the FISH results. So that's one. And then you have also to see the signal intensity, which could help you to identify the cases if you don't, for example, have FISH, which would definitely be positive. So that would be another thing you can utilize it. You will have a signal like this. Like this is the most common one. And then with the weak signals are to be counted or not, this is another problem. If you have this beautiful nice signals, then there's no problem. Well, this happens. I've seen these type of signals in Burkitt lymphoma, very clear-cut or double-hit high-grade lymphomas, but not common in other types of DLBC also. So you're always left with counting the cells. So typically 40% is considered a cutoff, but again, it's a very arbitrary, and people use different cutoffs in different centers. So what happens? How and why FISH, the cases which are FISH positive, why are not they having IHC positive? It's a very good question. Always like to see. So obviously we assume that there is antigenicity loss, which is one of the things, or the protein is not expressed properly, or the immunohistochemistry markers that we are using are not good, or there is some problem with the the detection kit. So many things can happen, which we know are true. But there is another problem, which I found this very interesting paper with the German group. They actually found that a lot of cases who were c-MYC positive by FISH, actually were c-MYC positive Burkitt lymphomas, actually did not have the MYC by IHC, but they actually had N-MYC. So there was some sort of transformation, modification, or some sort of different pathway. They actually produced N-MYC, and they showed it by elegant studies. So I'm not going to detail, but just one of the interesting things is that it's not necessary that what we are seeing is the whole thing. So there is transformation or shifting of the MYC mechanisms from c-MYC to N-MYC. So in these cases, they found that 6 of the cases, I think maybe 24 cases, turned out to be having N-MYC expression. And this was clearly shown in this picture. This is N-MYC positive in the case that you are c-MYC negative. And this is RNA-scope, which is a really good technique, which confirms, and these are the controls. So, which is really something of interest. We go to the different type of lymphoma. So this covers the basics. So we'll go to the lymphomas very quickly because we know now what we are dealing with. So Burkitt lymphoma is the top, obviously. Then high-grade B-cell lymphoma, the needed, and some different. So there is a role of c-MYC lymphomas or low-grade B-cell lymphomas is needed, but in transformation it could be helpful. And the last point we'll call BAL with MYC, which has been included in the new WHO, so we'll talk a little bit about that. T-cell lymphomas, it's not common. It's very few cases have been described, and those two are with N-MYC, not with c-MYC. Again, MYC, c-MYC, I'm trying to use the same term. For the Burkitt lymphoma, we know the hallmark translocation protein, and sometimes it's the light chain, it's the immunoglobulin, but not the heavy chain. It could be light chain like kappa and lambda, but sometimes non-immunoglobulin. Okay, so it's something we have to keep in mind. There is a difference with how some of the lymphomas behave regarding the different light chains. We're not going into details, but you should know that there are studies which show that even if the different type of partner gene has an effect on the outcome. So those controversial, we're not going to talk about them now. So I think we talked about this interplay of, so it's very clear that it's not MYC alone, which is involved in Burkitt lymphoma. Now with the beauty of the NGS, so when it started analyzing all these Burkitt lymphomas as well as gene expression profiling, it was like clear that there are many other genes, many other proteins which are involved in the Burkitt lymphoma. ID, which is the the inhibitor of the DNA. ID3 is very characteristic. So if you don't have a ID3 expression or overexpression, it's unlikely that it's Burkitt lymphoma. So this is very characteristic of Burkitt lymphoma. We'll skip a lot of the details here. So I mentioned about the breakpoints. So MYC has different breakpoints. It's not points. So these breakpoints are like variable from 30%, 35%, and that caused the problem with PCR, using the PCR to detect this. So it's not going to be definitive. So you would like to see a more wider, broader test. So, and also you have to make sure that the probes, many companies that we are using, for example, using the Abbott YSIS probes, there are other cytocell, few other companies, they have different probes. Not necessarily they cover the same areas of the MYC. So you have to make sure whether they cover your breakpoints or not. That's very important. Typically they are designed for those, but sometimes you might like to use both probes from one company and which is covered one breakpoint in the company which is better for the breakpoints. So I'm skipping a lot of details because it's in short time. So mention about break-apart. So when should we use break-apart probes for Burkitt lymphoma or just fusion probes or both, and how do we? So the studies out there very clear that you have to use both, and this is my recommendation. I'm telling every day. However, it's a lot of work, but it is definitely better. Why? Because if you do only break-apart, you're going to miss a lot of cases. You'll not miss up to 15% of cases, up to 20% of cases you can miss. Okay, very elegant studies from German group. Rainer Seibert mentioned this. He's a big expert on this area. So he has shown that if you use only one probe, you're going to miss a lot, because he has, gene expression profiling, a nanostring to confirm that these are Burkitt lymphoma, and then also did probes. So there is still a set of cases which are cryptic. You cannot detect either way. So those are very few. And then the gene expression profiling will be quite useful in those. Okay, so what about negative? So one of the things we have faced in our lab quite commonly, Shamail knows a lot, that we have probably maybe 30% negativity rate of fish of a very clear-cut lymphomas which look Burkitt, so we still get negative results. Why? Because one I mentioned not doing the right job of taking the tumor. Number 2 is necrosis. Number 3 is technique, processing, interpretation, many things, as I showed you the overlapping. So we have this issue. So there is no good way to get around it other than just first, most important, get the right specimen. Ask for a good specimen from the clinician. If you're not sure, and nowadays we're getting only needle course, small, tiny specimens. So getting a result on those is very hard. So I advise my clinical colleagues to, when you're talking about getting the results, especially reliable results, send a good specimen, good quality specimen. And that's why we keep nagging and asking them to get a better, bigger specimen. They always say, you are asking for too much. But then, we have difficulties here. So we could wrongly classify a disease for you if you don't send us the right specimen. Okay, so we go to DLBCL with c-MYC. It's also a very well-known relationship. So about maybe 10 to 15% of DLBCLs, not Burkitt, but DLBCL NOS, have MYC rearrangement. So these do poorly, and they have actually a similar poor outcome as the double-hit lymphomas. So you would like to know that. So, but when do we say it's Burkitt lymphoma with c-MYC versus DLBCLs? Obviously, the morphology is for you. So you will have to use your judgment. So everything starts with H&E. You will make the call on H&E first. You will not change the diagnosis of like this one. You will not call it Burkitt lymphoma because this is clearly a DLBCL. So you will have to use morphology, and then obviously the immunomarkers. So Burkitt has very characteristic immunophenotype and the morphology. So it is not to be confused. Okay, so another important thing is there is some correlation with some of the DLBCL types, especially immunoblastic, which has been shown to have higher preponderance of the MYC rearrangement. So immunoblast lymphoma, which always think of MYC to be present. Okay, so always do it if you haven't done it. Okay, so we come to the new updated classifications. A little bit confusing, but I just want to mention that high-grade B-cell lymphomas there has been a change in the classification in the WHO versus the ICC. ICC still keeps high-grade B-cell lymphoma, with MYC and BCL6 still intact, but still considers a provisional diagnosis. Still not very clear what happens in those cases, whereas the WHO actually removes it and puts it in the DLBCL category. So, which is quite strange. It's too early, I think. But what we now current classification, both of them agrees on using double-hit lymphoma for this high-grade B-cell lymphoma with MYC and BCL2 rearrangement. Okay, so again, this is a characteristic. What is the problem morphologically? What you need to know is that it's never going to be one type of morphology. It's never going to be look like, sometimes looks like Burkitt, sometimes like blastics, sometimes like DLBCL, sometimes look like something else. So you rely on morphology, you don't rely on Ki67 even. So essentially it's out there in the DLBCL group, NOS somewhere. So how many percent you don't know, but keep in mind, most of them definitely are high grade, like by morphology, they look like blasties, but then there are some subtypes, and we'll come across the gene expression profiling studies. They look like DLBCL, straightforward DLBCL, still are double hit. Okay, so these are the different types of double hit that is used in definition. BCL3 is so uncommon, but it has been reported in some of the DLBCLs. So, and then you know about what triple hit means. Again, it's considered for now about like 20 years, maybe not 20 years, a lot of time ago, so 10 years ago, so we found out that the number of cases who have DLBCL with the double hit are maybe around 10%, and they do extremely poor. So the survival rate is less than 30 if you use R-CHOP. So this is, I think we can skip that. Running out of time. So which cases of now we'll come to the same fish question, which is very relevant, or especially clinical audience. What cases would you fish? So this is a very institutional base, but as we go, more and more dig into it, we find that the correct consensus agreement is that you have to fish all DLBCLs, irrespective, because as I told you, morphologies can be deceiving, the immunos can be not reliable, and then that's why I listed that what is the problem if you use certain cutoffs, certain criteria, and different ways to figure out whether you can save money or save resources, but there is no short way, there's no way around it, you have to do it. As long as, you have, cases, and you would not like to miss a single case of DLBCL with CMYC, or you don't miss a double-hit lymphoma because the prognosis is so bad. So best is to fish all the cases, and ideally do both the probes. But best is in our setting we do MYC, start with the MYC as screening. If a MYC is positive, then you go ahead and do BCL2 and BCL6. If MYC is negative, you stop. So again, be aware of the false negative MYCs. So there are times when you get a result from the fish lab, and that says it's MYC positive, but BCL2 is not positive, it's amplified. What do? Do you call it double hit? Or you can say MYC is amplified, or other way around. So, or both of them amplified. So this result is also common. So in those cases, there has been some in groups we use this term atypical double hit. I don't think it's common terminology, but this is some people utilize this. Does it mean anything? Yes, some people say it's got similar outcome, poor outcome, but actually, if you look at the recent gene expression profiling and the double hit signature profiling, actually these patients actually don't do as bad. They have a similar outcome to the regular DLBCL, so they are not the worst actors. That's my point. So, but previous studies are showing that there may be something that these are doing a little bit worse than the others. But if you look at the actual gene expression profiling, which identifies these cases also in that group, they were not bad. So we come to now, so is fish so reliable that we can completely rely on fish? Say fish negative, yeah, it's not DLBCL with the MYC, or it's not double hit. So we have to really make a decision here. So it is quite reliable, done properly in good setting. Even then, even everything is done, still there are cases where there's cryptic translocation, which is not picked by fish. Oh, so how we find out? We do gene expression profiling. We do the by nanostring, which is one of the good techniques which you can utilize even on paraffin-embedded fixed tissues. So that is what they did in a lot of studies, and I'll show you a few here. So in this case, 6 cases which were basically negative by FISH were actually had a double hit signature, clearly were like double hit lymphomas. So that is one thing we need to keep in mind. So suppose a patient who is a DLBCL, or you call it DCBCL, you think, or it looks high grade, you say it's FISH negative by MIC. So it's sometimes, decision which could mislead, because then patient gets treated with R-CHOP, right? It's not good. So we had to be very precise. So we think it's high grade. So what has happened in our clinicals, like with our teams, that we see that patient, it looks high grade, it looks amazing, like a number of lymph nodes in the body, and it's so big presence in the lymph nodes, and so it looks like it's PET is positive, so high grade, and my pathology tells it's high grade, MIC is negative. So will you treat it? So you would not treat. You would give him clinical. So sometimes you have to take clinical, but actually, if you look hard, a lot of these cases are double hit, but they are missed by FISH for one reason or the other. Some of them are truly missed. Some of them are just false negatives. Okay. So this concept about the molecular signature. So molecular double hit signature is very important, because the new concept. It's not in clinical practice yet. Nobody is doing it in real practice, but the studies from North America, especially the British Columbia, the group in the Vancouver, they have clearly established that the double hit signature is very standardized, and you can actually figure out by using double hit signature which cases are truly double hit, which are not truly double hit, and you cannot take FISH as a guarantee for a case being double hit. So there is another part to it, which is basically, which I show you here next. So these 2 studies I was mentioned about, the one is, they're from the same group, by the way, but they have refined it over the years. From 2019, they published first double hit signature study, which showed that there were 27 cases. Oops. Okay, there were 27 cases which were double hit, basically out of all the DLBCLs, the de novo DLBCLs they are studied, and then out of this, half of them, they had double hit signature, half of them actually FISH negative. Okay, so they were not the double hit by FISH, but they were double hit by the double hit signature, but they were molecularly. So again, you're talking about now 27%, and some of them are double hits, but half of them are not double hits. So you would say up, so which means that around maybe 10 to 15% of cases will be missed easily if you're not doing the full workup like molecular technique to find out whether this is double hit. So this has raised a lot of questions about FISH reliability. The other thing is that they actually pushed the study a little bit further, and they went and added Burkitt lymphomas to this to see the signature, whether it's compatible. So it looks like the Burkitt lymphoma signature, which we all know comes from the dark zone. So that dark zone signature was considered as a archetypal or the gold standard signature. So using that, they found that a lot of these double hit lymphomas actually have the same signature as the Burkitt lymphoma. Okay, so Burkitt lymphoma, double hit lymphoma, similar signatures. And then there are other DLBCLs which were also had the same signature. So they were never DLBCL, they were never double hit by morphology or by phenotype or by FISH, okay? But just the DLBCL, but they had double hit. So they combined all of them. And they devised a new terminology called dark zone lymphomas, or a dark zone signature. Okay, so this is the one which is currently basically a big topic of interest, where now we know that this Burkitt lymphoma, the double hit lymphoma, as well as high-grade lymphomas, which look like DLBCL, but neither double hit or Burkitt, they are coming from this area. This is called a double hit or the dark zone signature. Okay, so we'll move quickly to other types. This importance in other subtypes is not great because it's known, so we shouldn't be surprised. It's because I told you MIC is involved in so many cancers. Even if it's a solid tumor, you start looking for MIC, you will find it. Okay, so it's not so its importance is more in the lymphomas I talked about. So in plasmablastic lymphomas, about 50% of plasmablastic lymphomas will have MYC. It's still a bad disease, poor outcome. It will not change the prognosis. So there are ways we can do the assessment. Just do immunohistochemistry. Most of the times it will be positive. And you can also do FISH, and most of them are positive in EBV positive plasmablastic lymphomas. Okay, there's a lot of data now saying that in mantle cell lymphomas, if you have MYC expression, it could actually basically add to the poor outcome, especially P53, whether it's there or not. So because P53 is commonly used as the poor outcome mantle cell lymphoma, but you can add MYC. Actually, last year there was a publication from from the Nordic group. Actually, they show that it has a sort of, if you look at this data, so all the MYC positive cases, this is by the way, by immunohistochemistry and confirmed by mRNA, that they actually fell in the high risk categories. So it means that c-MYC can be added, or a MYC can be added to the high risk group, and it is not a very high number, but small number, but still. And their cutoffs, by the way, were 20%. I told you the cutoffs for the IHCs are so variable. In low-grade lymphomas, it's not so must to do it, but again, when they transform to high-grade lymphomas, it is quite common to have a MYC overexpression and dysregulation. One thing you would like to know about is the follicular lymphomas. Where follicular lymphomas, 14, 18 translocation, very common. And when they're low grade, but a good number of them transform to high grade, okay? And some of them are double hit. Not all of them, a small percentage, maybe 15, 20%. So in those cases, you will call them double hit lymphoma. Whether it's transformed follicular, it doesn't matter, but double hit is a double hit. But the cases sometimes happens that follicular lymphomas itself, with its own translocation, 14 plus, sometimes has a MYC translocation. Looks low grade follicular lymphoma, don't call it double hit. So those should be not labeled as double hit. So a basic double hit, you're talking first of all aggressive high-grade lymphomas and transformed lymphomas. These are not transformed. So small percentage may have MYC. So the WHO recommendation, not to call them as double hits. Treat them as follicular lymphomas. 1 minute, we got 2 slides. So we're done. So we'll come to this new thing in WHO. They have the expansion of, look at this proliferation of the genes, the genetic translocations in the ALL category. So this is mind-boggling, like too much. So what we have is that there is this category of BALL with c-MYC. We knew that this was there, but they put it as a separate category. So how to diagnose, how to go around making this call is a little harder. But you have to make sure that you are not calling a double hit lymphoma or a high-grade B-cell lymphoma with TDT positive. Because this category needs to be made sure that you are leading with lymphomas. Sometimes high-grade lymphomas, double hit lymphomas especially, can show TDT expression. So just don't go by TDT saying that TDT is there, so class. It is ALL. So those are different diseases, okay? So that has been made very clear in the ICC, at least I can remember. I don't know about WHO. So actually this study is also very clear. This is recently published data. Emphasizes the same point. I'm not going to. So lastly, just over a couple of graphs. So very beautiful graphs are our clinical colleagues. So just to show you that the different types of things related to MYC, IGH, non-IGH translocations have outcomes variable, de novo versus transformed. So this is so important to know for our pathology colleagues, just to keep yourself updated. What is happening? If I'm diagnosing something, what is the impact? And the different therapies out there that have been utilized with MYC positive versus MYC negative. So it has a lot of impact on the outcomes, on the way I mentioned about if you miss cases of double hit, they get treated wrongly and the outcome is bad. So you need to keep in that in mind. And then the new studies that are there. What we know is happening is that there are now studies in trials, especially the utilization of polatuzumab and the R-CHOP, which is a combination. It's a very new regimen. It has shown really good results in both in ABC as well as double hit lymphoma, all the dark zone signature double hit lymphomas, and this could be the future of the management. Okay, so a few learning points. This is the last slide. So this is for our general pathology residents that lymphoma diagnosis requires utilization extensive diagnostic modalities. So you cannot just rely on one thing, immunohistochemistry or FISH. So you have to utilize everything. So you know your classification system, be updated. Morphology is still the main. You should start everything from a good morphology, good section. You can't just overlook or emphasize the importance of that. And then some variants, you have to be very aware which variants are a pitfall, you could go in the wrong direction. And then everything has some value. So whatever we say, it means something, right? And some of them actually have a lot of prognostic. As far as MYC goes, MYC is very common. Almost all cancers, as I say, more than 75% cancers have MYC dysregulation. And so if we understand how it works, what exactly the action is, so we could target it. But so far, it has been, as I said, undruggable. Best technique is to still fish, although I said a lot of things against it, but we still have nothing better in clinical use. MYC-IC, I think, is not reliable. We can all agree to that. Molecular studies are expanding. Now we're talking about double hit signatures or the dark zone signatures, which will be the future, how we assess these tumors. And then still, we haven't unified all the molecular studies that are out there to direct our therapies, but this is coming in next maybe 5 years. And that's it for me. Thank you for your attention. Sorry, it took a little bit longer.
Thank you, Dr. Bakhshi, for sharing your valuable insight. Our next speaker is Dr. Abdullah Swaidan, who has very impressive professional and educational background, which I had to shorten for the sake of time. Dr. Swaidan, he's the chairman of Clinical Genomics Department at King Faisal Specialist Hospital and Research Center in Riyadh. And he is a board certified by the American Board of Pathology in Anatomical Pathology, Clinical Pathology, Hematopathology, and Molecular Genetic Pathology. With advanced training from leading US institutions, he specializes in hereditary and cancer genetics, focusing on conditions such as breast cancer, leukemia, and lymphoma. Dr. Swaidan's work continues to drive advancement in genomics and pathology. Please welcome Dr. Swaidan to the stage.
Thank you so much, Dr. Fatima, Dr. Reem. Thank you all for attending. I would like to start by thanking the organizing committee and Dr. Saeed Al-Shayban for this invitation. Today, I will try to talk about the molecular diagnostic in lymphoma. So you are familiar with molecular and myeloid neoplasm. It has been very advanced to the degree that it's become part of the diagnosis and also part of the workup for every case, let's say, of leukemia or MDS. Now, there is advances in solid tumor, and lymphoma is also taking a large chance of new mutations, new genomic data that change the perspective of lymphoma. But again, all of these advances in molecular, it's only an ancillary. Still, we need the morphology. Still, we need a more comprehensive approach. So we need the clinical, we need the morphology, we need the IHC, we need the karyotype, cytogenetics. Everything is needed for the having more comprehensive information and to understand the biology of these tumors. Once we understand it, this can guide the therapy. You can get a better in terms of prognostic and also detecting the relapse. Now, when we do molecular testing, there are many targets for us. So when we say molecular, we mean DNA or RNA. DNA or RNA, this is what we are looking for. But sometimes we look at rearrangement, like physiologic rearrangement, similar to somatic hypermutation, for example, or when we do IGHV hypermutation. We see this as physiologic changes to increase the diversity of lymphocytes and can be pathogenic, like with MYC rearrangements and others. The same thing with mutation. It could be small deletion or insertion. It could be single nucleotide variants. It could be small deletion or silencing. It could be duplication, amplification. So all of these changes as a copy number, as a mutation, as insertion or deletion, all of that can be detected using different methods. Why we do molecular tests? We do molecular testing either for diagnosis, so it can help in lymphoma to differentiate reactive from neoplastic process. We do it for classification. There are some diseases that you need this mutation to document the diagnosis. many mutations has prognostic significance. It can be used for MRD and monitoring. So with time, even after therapy, we can detect these mutations before the patient develop relapse. Targeted therapy, which is also a new thing. So there are many medications now that target specific mutations within the lymphoma ward. And it can be helpful to detect cryptic abnormalities that can be missed with normal karyotype. Now, I decided to make this talk more to pathology rather than technical. So I will not go deep into the technology, how we do the FISH or karyotype or chromosomal microarray, but these are the list of the molecular techniques that's available in my lab. So we can do all of these testing. We can do IGH, G rearrangement. We can do IGHV mutational analysis. We can do minimum residual disease testing, next generation sequencing with different targeted. We can do gene expression profiling. We can do epigenetics testing or cell-free tumor DNA. All of these are methods used in the lab to answer questions related to DNA or RNA abnormalities within the world of lymphoma. So from now then, the important thing here that every test answers different question. So we need all of these tests. No one can replace the other. And each test has its own limitations. So some abnormalities can be detected by NGS and missed by FISH. The reverse is true. You can detect clonality by NGS, and that's missed by fragment analysis. So BCR is different than NGS, different than Sanger. It's different technologies, but they work on the same target. Trust me, you will not get any technical beyond this. Now, we'll move to disease-based update in terms of genetics for this lymphoma. We'll start with the CLL, SLL. This is one of the commonest lymphoma. It can be tissue or can be liquid. And there are multiple cytogenetics abnormalities that have been described. So some of them has favorable and very common, like 13q deletion, trisomy 12, intermediate, associated with bright CD20, 11q, 17b deletion with TB53, that's very significant. MYC mutation is very rare in CLL. And there are other cytogenetics abnormalities that's not that common. Also, complex karyotype can be seen. The most important thing for us is to do IGHV mutation and status. It's now part of management for every patient with CLL, SLL. It's recommended. And the mutated CLL associated with indolent behavior. With mutated, we mean that the score is 97 and below. So if the score is 98 and above, this is unmutated CLL and likely associated with bad prognosis, and it will change the therapy. So the management for unmutated CLL is different than mutated CLL. Cases with borderline, anything between 98 to 97 is considered as unmutated, so similar to bad prognosis. Now, in terms of therapy, TB53 is very critical and CLL, and as you can see, there are 3 FDA-approved medication. Sorry. There are 3 FDA-approved medication to use in patients with TB53 mutation or deletion in TB53. Also, if you have loss of heterozygosity, so sometimes the FISH is negative, so there is no deletion in TB53. There is no mutation in TB53. If there is loss of heterozygosity, still it will be considered similar to TB53 mutation or deletion. Again, you know, TB53 is important in most lymphoma. It's always associated with wars, so we see it even in solid tumors. It's part of the cell cycle. The critical here is there are many other mutations described in CLL. So you have Notch1, SF3B1, ATM, and others. There is BTK. So BTK may, and BLCG2 and CARD11, all of this predict resistance to BTK inhibitor. So if you have a patient with TP53 mutation, you offer them BTK inhibitor. If they have another mutation in BTK, then they will not respond to BTK inhibitor. And this is why we don't offer only one test. You should not do only TP53. You should do a comprehensive panel, all genes together, because some other gene may indicate resistance. The same thing if you have BCL2 mutation, then this patient will resist the BCL2 inhibitors. There are some genes associated with rectal transformation, like unmutated CLL, Notch1, TP53 mutation, or deletion, and deletion 11q. The next is LBL, Waldenström macroglobulinemia, and this is one of the diseases that also gets a little bit changes with WHO5. We know about MYD88. So MYD88 is common, seen in many cases of LBL, but it's not specific. So you can see it in other type of lymphoma. It's totally not specific. The importance of MYD88, it can work through BTK. So BTK inhibitor may work if the patient has this mutation. CXCR4 mutation present in some of these patients, but if there is CXCR mutation, then the patient will resist BTK inhibitor. So this is why it's important to do both mutation. If you do only one, you say MYD88, okay, I will give the patient BTK inhibitor. Maybe the patient has co-occurrence of CXCR4, and most patient has both mutation. So most patient has MYD88 and CXCR mutation together. If you have both, then this is very specific for LBL. If you have both, it's very specific. If you have only one of them, then you need strong morphologic evidence to support the diagnosis of LBL, because MYD88 alone is not specific. There are other mutations described in LBL, like mutation in BTJ1 and BRDM2, present in many cases. 6q deletion is present, and also other mutation described in LBL disease. Now, marginal zone lymphoma is one of the diseases that has 3 types. It's a more indolent type, so we know the splenic marginal zone, the nodal marginal zone, and the extra and the mucosa associated. So even though the nodal and splenic marginal zone, they are in different locations, but you can see they share a lot of mutational profiles in terms of genomics. So they are KLF2 and Notch2 present in both. Trisomy 3 and 18 is common in both. And there are some other mutations. Neither of these are specific nor sensitive. But you can see if you have NGS panel and you find this mutation, it can support the diagnosis if the morphology is not strong. In terms of extranodal or mucosa-associated marginal zone lymphoma, again, we know about all of these translocation, 1118, 1418, different location for all of these, and BCL10 and FOXB1 rearrangement in few cases. Again, the changes here is very specific for stomach, parotid, and thyroid, and areas where you see the mucosa-associated lymphoid disease. Next is follicular lymphoma. So now we are talking about classic follicular lymphoma. We move away from the gradings to classic follicular lymphoma and diffuse follicular lymphoma, pediatric follicular lymphoma, and GI follicular lymphoma. So with classic type, you see 1418 in most of the cases, but not all cases. So not all cases will have this translocation. Sometimes there is translocation, but the IHC is negative, and this is well known because of point mutation that change the epitope, so your antibodies will not work in these cases. Follicular lymphoma is very unique in terms, it has high rate of mutation in the chromatin modifying genes. So many genes is mutated. All of these genes fall into the histone and chromatin modification agent, either histone methyltransferase or histone acetylase, very common, especially EZH2 and KMT2D. And there are other cytogenetics abnormalities, 6q and 17b, like TP53 is associated with worse prognosis. The other type of follicular lymphoma, diffuse follicular lymphoma, where you have diffuse growth of follicular lymphoma, usually lack 1418, and there is a mutation common, especially the STAT6. It can have also EZH2, it can be targeted, so we have a therapy for EZH2 now. Pediatric follicular lymphoma has also 80% of these follicular lymphoma has mutation in one of these genes. Duodenal lymphoma also have mutation in EZH2, CREPPP, and TNF-RS14. And you can see it shares between these. So TNF-RS14, you can see it's common in all of these. And for classic follicular lymphoma, if you find any of these genes, then it's associated with high rate of transformation to DLBCL, especially if there is MEK, BCL6 rearrangement, CDKN2A, B, TB53, and others. All of these associated with worse prognosis. So again, if you do more comprehensive genomic profiling and you find these, then you can have a better idea, because follicular lymphoma usually, again, indolent disease in some way. But if you find some mutation that associated with the progression to DLBCL, this may help the patient. Mantle cell lymphoma is well known for translocation 1114 with cyclin D1, but 10% will be cyclin D1 negative. This associated with cyclin D2 or D3 rearrangement. So if you do molecular testing, you can detect these. There are many cytogenetics abnormalities, blastoid variant and pleomorphic variant associated with TB53 and 9q deletion. If you find TB53 deletion or mutation, notch 1 or 2, ATM or KMT2D is associated with poor prognosis, short time to progression, especially with NSD2. NSD2 is recently described as one of the, it's not specific for mantle, but in mantle cell lymphoma, it's associated with progression and ibrutinib resistance. So this is a summary of what I described. And this is the maturation of B cells through the germinal center. So the unmutated CLL, it's like the most naive to all mature LBL, like memory cells. You can see many mutations happened in each disease. So with CLL, we have a list of mutation. With mantle cell, we have cyclin D1 and TB53. Burkitt lymphoma, I did not describe Burkitt lymphoma because Dr. Nasser already described the MEK and ID3, TCF3 mutation. Hodgkin is difficult because Hodgkin lymphoma, by definition, you have few cells among many reactive small cells. So if you do NGS, difficult to detect mutation. There is abnormalities in Hodgkin lymphoma, but it's still in research, mainly single cell sequencing than real practical approach. Follicular lymphoma, we described the mutation in follicular lymphoma, all of this, especially EZH2 and many chromatin modifying agent, a marginal zone with KLF2 and Notch1, TB53. Mutated CLL is enriched with MYD88. So this is why MYD88 is not specific. It can be seen also in LBL, MYD88 and CXCR in Waldenstrom macroglobulinemia. So this is merely the mature B cell. Now let's move to the diffuse large B cell. Diffuse large B cell is by definition a heterogeneous group. So the definition, you have diffuse, you have large cell stained positive with B cell marker. So anything that fits with that will be under diffuse large B cell. And we have been trying to differentiate this for a long time. So we start first with the morphology, differentiating the centroplastic from immunoblastic, from anaplastic, and the morphology does not always correlate with prognosis, even though some of the morphology is worse. Then we start with the cell of origin classification, the CGB versus non-CGB, ABC subtypes. It work well with R-sharp treatment, but still it's not the best. There are many cases unclassifiable in between. And right now, many mutation has been described in diffuse large B-cell lymphoma. Many of them has really prognostic significant. Still, they are in treatment-wise not really used a lot, but prognostically it has significant. Most of these genes under either BCR signaling pathway or toll-like receptor signaling, lymphocyte differentiation. Some of these genes work as DNA repair or cell cycle. Some of these genes important for lymphocyte activation, some of them in chromatin modification, and some of these genes very critical for immune surveillance. I will not touch in high-grade B-cell lymphoma because Dr. Nasser gave us excellent overview about high-grade and make rearrangement. But let's see how we can classify the diffuse large B-cell morphology. So this is a study from Dana-Farber. They tried to do whole exome sequencing in 300 DLBCL cases. They found 158 driver mutation, almost 17 mutation for every case, and they divide them into 5 clusters. So you can see C1, C2, C3, C4, C5, all of these clusters here, different signature for each group, and they correlate this with the outcome. Then there is another group from the NIH. They also have 574 DLBCL. They did whole exome sequencing, gene expression profiling, copy number changes, and also they add targeted panels. So they focus on 372 genes in addition to whole exome sequencing. And they divide them into 4 groups. EZB, where you have EZ2 and BCL2 rearrangement, and this is the best group. Then B2, BCL6 with Notch2, MCD, MYD88, and CD79A, and Notch1 group, which do the worst. So you can see the survival difference. This is the worst group, and EZB is the best group, and in between. So this has clear prognostic significance in DLBCL. Then there is another group from UK. They have 928 DLBCL patients. They do targeted NGS, including 293 genes, and they divide it into 6 subgroups. And these are also different subgroup with Notch2, BCL2, MYD88, and others. And there is a group where not otherwise specified or not otherwise classified, where it doesn't fit with any cluster here. So this is a little bit confusing, but right now we know that we can put these 3 group or these 3 classification into one group that fits both, according to the NIH, and UK and the Dana-Farber classification. They fit with almost these 6 groups. So the first group is EZB, which has BCL2 and EZH2 and others. Then STC2, where you have SOX1 and TIT2. Then the TB53 group. Then the Notch1 group. Then the BN2, Notch2, and BCL6 rearrangement. Then the MYCD, MYD88, and CD79B. These had bad prognosis, some intermediate prognosis, and this has good prognosis if no MYC rearrangement. Again, this associated with GCB morphology, and this one with ABC morphology, or self origin. So this is the DLBCL classification. This is the best way to handle all of the subgroups. This has prognostic significance, as you can see, and also has some therapeutic. So we have EZH2 inhibitor, we have BCL2 inhibitor, and we have many inhibitors that work in big 3 pathway and BCR pathway and other JAK-STAT pathway. So if you find the mutation, all of these treatment options the patient can get, maybe not so all of these patients, all of these classification they receive are sharp, most of them. But if the patient failed the first line therapy, maybe they will benefit from this targeted therapy. So this is the diffuse large B, and we finished small and large B cell. Let's move to T-cell lymphoma. Some update about the molecular abnormalities within the T-cell lymphoma world. Now we have the nodal follicular Hilbert T-cell. It has 3 subtypes. The angioimmunoblastic, it used to be the angioimmunoblastic T-cell lymphoma. Now it's a subtype. Then follicular subtype and NOS. They share the same molecular and abnormalities, even though they have different morphology. It seems that this disease is a progression. So all of the follicular Hilbert T cell, they have cytogenetics abnormality. They have many other clonal abnormalities. Some of them, around 10% to 25%, lack T-cell gene rearrangement. So if you don't have T-cell gene rearrangement, it does not rule out this diagnosis. Interestingly, 40% of them have IGH gene rearrangement. So you can find IGH gene rearrangement and you can miss the T-cell receptor rearrangement within this because of the abnormal B cell in the background that can stain with ABV. Now, the mutation common here is TET2, DNMT3A, all of these are CHIP mutation. IDH2 is very enriched in this group, and ROA is also very enriched. Most of these cases, almost 90% of this diagnosis will have mutation, at least of one of these. So if you are in doubt, you can do NGS and you will detect one of these mutations in these cases. It can help if the diagnosis is challenging. Next is ALCL. Again, this is well known for all of us. It's the CD30 positive with hallmark cells. The ALK positive group, the fusion with the MBM1 Barton 2 5 fusions is well characterized for ALK positive. You can call it ALCL, ALK positive or ALK positive ALCL, depending on which classification you choose. But this group is enriched with Notch1 mutation, and Notch1 can serve as a target for these patients. In terms of ALK negative group, this is a heterogeneous group. We used to call them as DUSP22, TB63, and triple negative. Now, we know that it's beyond that. So many mutations can happen even within the DUSP22 and TB63. It seems that DUSP22 and TB63 is mutually exclusive, so you cannot get both. TB63 usually associated with worse prognosis, but many other mutations can happen in ALK negative. And this is why this entity, I think, will get more attention in the next WHO as better classification and better characterization, especially that other fusion has been described in ALK negative, like RAS1 fusion, similar, let's say, to lung carcinoma, where you have RAS1 and ALK1, TYK2 and TFR fusions, all described in ALK negative ALCL. I'm sorry. Okay. Next is peripheral T-cell lymphoma. So peripheral T-cell lymphoma, you are aware of this gene expression profiling, where you can differentiate peripheral T-cell lymphoma. It's a group of diseases, very heterogeneous, that does not fit with any other. So if it does not fit with AITL, does not fit with ALCL, then we describe it in anaplastic large, describe it in BTCL. Based on gene expression profiling, we found two markers, the TBX21 and GATA3 gene expression. That's totally different. GATA3 is associated with worse prognosis compared to TBX21. And now there are multiple, or there is a recommended immunostains that you can do algorithm similar to Hans algorithm, where you can do to classify T-cell lymphoma either as GATA3 signature or TBX21 signature. The mutation profile is different. So TBX21 associated with TIT1, TIT3, and DNMT3A. On the other hand, GATA3 is associated with TB53 and B10 loss and CDKN2A, 1B loss, RB1 mutation of deletion, gain of MYC. So all of this is bad. So this is why you get GATA3 has a worse prognosis for this regard. Primary nodal EBV positive NK cell lymphoma. This is a new provisional entity in both ICC and WHO5, usually in elderly, poor prognosis. And there are many mutations described here, including STAT3, TET2. All of them is a potential target. Still, this area needs more attention because this disease is very aggressive. So this is a summary of the nodal T NK cell lymphoma. We described the T follicular helper cells with specific mutation IDH2 ROA and TIT2 DNMT3A. Then we describe ALCL, we describe the BTCL with some mutations, and we describe the primary nodal EBV positive T-NK cell lymphoma. There are extranodal T-cell lymphoma. I will not go deep into this because there is another talk about about cutaneous T-cell lymphoma. But with cutaneous T-cell lymphoma, we have a good mutation, BLCG1. This is the next target. So this will be a very critical mutation. And breast implant-associated ALCL, even though the name is ALCL, it's totally different than ALCL. So it doesn't have DUSP22, doesn't have TB63, doesn't have ALK. It has a STAT3 mutation, and STAT3 mutation, it's not specific, but very common in ALCL, breast implant associated. Hepatosplenic T-cell lymphoma associated with several mutations, intestinal T-cell lymphoma, either enteropathic or monomorphic. Epitheliotropic T-cell lymphoma is associated with this mutation. Then we have the extranodal NKT cell lymphoma nasal type associated with DDX3 mutation and TB53 as worse prognosis for this patient. So just for the sake of the time, these are the selected type of lymphoma that we see. I will talk you through what we do at King Faisal in my lab for lymphoma. So we have this lymphoma NGS panel. Still, it's under validation, but in the final stages, we expect to go live in January 2025. So these are around 70 genes commonly mutated in lymphoma, and this panel is DNA only. So we only do DNA, not including any fusions. There are other tests in the market where you can do DNA and fusions, but we focused here on DNA, and you can see most of these genes are critical for prognostic significant, and some of them even therapeutic, like EZH2 and BRAF, for example, for hairy cell or something like that, if it's seen. Now, there are other tests like clonality testing. We used to do it by fragment analysis to see if there is a clonal B cell or T cell, but now there is NGS-based clonality testing that can be done, especially for MRD and BALL and multiple myeloma and CLL. There is some FDA-approved one for diffuse large B cell lymphoma, like clonoSEQ and LymphoTrack, all of them available in the market. Very sensitive, good for B cell lymphoma as a clonality testing or for follow-up. And we like to do it as informed clonality testing, which means we do the testing at time of diagnosis. We know exactly what's the clone present, what's the rearrangement in this patient. Then we can follow them and we can detect up to 0.01% if there is residual disease. Cell-free DNA is also critical, and it's coming to the market. Even in Hodgkin lymphoma, there are many cell-free tumor DNA, and especially with lymphoma, I think it will work the best. We started the first with the NIPT testing for fetal DNA with the pregnant mother. Then we found the tumor DNA. So if these lymphocytes are circulating in the blood, definitely you will find the mutation in cell-free DNA. So we are also planning to have this maybe in 2025 or 2026 at our hospital to offer cell-free DNA to follow up these patients, especially if biopsy is difficult. And many times after chemo, difficult to find a biopsy. If you find AVG, avid lymph node, you don't know if it's a relapse or not. So cell-free DNA will be very helpful in these cases. So to sum up, this is the take-home message. I think my presentation has a lot of genes. If you don't remember all of them, that's fine, but at least this is the critical part here. The significance is here. So lymphoma is a heterogeneous disease. DLBCL is very heterogeneous. So we have many mutations. None of them is specific, but they affect the patient in terms of prognostic and may have also may have therapeutic implication. Morphology is very critical, so we will not move away from morphology. Molecular is already supporting the morphology. Lymphoma NGS becoming a standard of care now. Lymphoid neoplasm patients should offer lymphoid NGS panel. It can give therapeutic, prognostic, and predictive information. Whole exome sequencing or whole genome sequencing is good if you are suspecting germline, because some people, they have multiple family members with the lymphoma. So if you think they are at higher risk of lymphoma from the germline perspective, then whole exome sequencing will be very helpful. Morphology, similar to morphology, NGS molecular test will depend on the quality of the sample. So if you have bad sample, it will be difficult to get a good molecular result. Standardization, availability of these tests is a challenge. So not every hospital have NGS lab or able to have the lymphoma NGS. The panels are different, so every hospital have different methodology, different genes. The ability of the panel to detect copy number changing structural variants is also different. So you may see lymphoma panels in different labs, but they perform differently because they are designed differently. Excisional biopsy is very critical. So if you are talking about molecular, we need tissue for not just for diagnosis, not just for IHC, not just for flow. Now we need tissue for the NGS test. So we are always like to have excisional biopsy, if not at least a good core needle biopsy. FNA will work for molecular tests, but it's not enough for diagnosis because we need to see the architecture. Clonality testing is critical and is coming to the market. MRD testing and cell-free DNA is approved in DLBCL. Most genomic alteration are not integrated in the first-line therapy, and this is also very critical. So most of these mutations are important in terms of prognosis or therapeutic, true, but not at time of diagnosis. So most of these patients will receive the standard of care therapy. If they relapse, if they progress on therapy, then you may think about this mutation. And this is why the turnaround time for this test is not critical. So you can do the lymphoma NGS and receive the result after 1 month. That's fine. This is different than leukemia, where they need the result urgently because some of the mutation integrated in the first-line therapy. Finally, knowledge of the biological information of the lymphoma allow earlier diagnosis, can also help in screening and better therapy and better understanding of this lymphoma so we can serve our patients better. And thank you so much.
Thank you, Dr. Swaydan, for the excellent presentation. Just a quick reminder for the audience to prepare your questions for the Q&A segment at the end of the session. Our next speaker is, last but not least, certainly, Dr. Khalid Al-Aid. He is a distinguished consultant in hematopathology and flow cytometry at King Saud University Medical City in Riyadh, with advanced training in flow cytometry from Case Western Reserve University and in lymphoma and hematopathology from MD Anderson Cancer Center. Dr. Al-Aid brings exceptional expertise to his role. He also serves as training supervisor for the Royal College of Pathologists of Australia and is a member of the National Stem Cell Committee for the Saudi Health Council. Dr. Al-Aid is deeply committed to advancing hematopathology and flow cytometry practices in Saudi Arabia and beyond. Today, he will be presenting on bone marrow evaluation in lymphoma. So let's give Dr. Al-Aid a warm welcome.
Bismillah ar-Rahman ar-Rahim wa salatu wassalamu ala Rasulillah. Thank you very much for the introduction, and thank you, Dr. Saeed Al-Shayban, and the organizing committee for inviting me for this meeting. So, bone marrow evaluation in lymphoma. Bone marrow infiltration is frequent in lymphoproliferative disorders. Therefore, before starting treatment, patients are staged with the Ann Arbor staging system for prognosis and treatment planning. In addition, bone marrow can be the primary site of the disease, and the entities such as bone marrow, liver, and spleen, BLS type of large B-cell lymphoma, and primary lymphoma of bone marrow have been implemented. And the reason why bone marrow examination is important in lymphomas is because it will advance the case to stage 4 when bone marrow involvement is detected. In the current medical practice, bone marrow involvement is assessed by either pathological and or radiological evaluation. Bone marrow biopsy is the most direct method of detecting lymphoma infiltration, but it is an invasive procedure which is accompanied by several complications such as pain and hemorrhage. On the other hand, PET scans is a non-invasive examination that can comprehensively evaluate the state of bone marrow with extremely bone marrow biopsy is the most direct method of detecting lymphoma infiltration, but it is an invasive procedure which is accompanied by several complications such as pain and hemorrhage. On the other hand, PET-CT is non-invasive examination that can comprehensively evaluate the state of bone marrow with extremely high sensitivity in detecting bone marrow infiltration of lymphoma. Therefore, many clinical institutions put forward the idea of replacing bone marrow biopsy with PET scans as the first choice in the diagnosis of lymphoma involvement of the bone marrow. Okay. However, many other practitioners and researchers share different opinions. Relevant research indicates that PET scans cannot replace bone marrow biopsy in the diagnosis of bone marrow involvement by diffuse large B-cell lymphoma or follicular lymphoma, and the accuracy of PET scans in detecting bone marrow infiltration is unsatisfactory. And the bone marrow evaluation remains the standard of method in bone marrow evaluation for lymphoma. Here are two studies to compare PET scan evaluation with bone marrow pathological assessment. The first one included 153 cases using FDG uptakes, and it showed an average sensitivity, meaning missing almost half of the cases with good specificity. The second cohort included 80 cases using fluorine-18 radioisotope FDG uptakes. It demonstrates excellent sensitivity, but this in trade-off the specificity, as many negative cases labeled falsely as positive. Now moving to the bone marrow sample. So the bone marrow procedure is unique as it is of two steps or sampling procedure. The bone marrow aspirate, which collects the liquid component of the bone marrow, and the core biopsy, which collected the tissue component. And each one is utilized thoroughly and differently. The bone marrow aspirate is the source for bone marrow smears, bone marrow clot section after left until the aspirate got clotted, for flow cytometry analysis and karyotyping, FISH, and molecular testing. While the bone marrow trephine biopsy is the source for H&E histological section, where immunohistochemistry staining can be performed, and touch imprint, and the touch imprints. The trephine biopsy can be utilized also for FISH and molecular testing if needed. Here are the bone marrow slides that you received for evaluation. The assessment of cytological details can be carried out using films of the aspirates or the imprints from the trephine biopsy. Please remember, peripheral blood smears are very valuable for cytology assessment as well. Histologic section features histological features can be assessed using sections of either the trephine biopsy specimen or the aspirate clot. The pattern of infiltration can be only fully assessed using section from the trephine biopsy specimen. This is a nice diagrammatic scheme of what is the best source for assessment. For example, architecture can be best assessed from the core biopsies followed by clot section. IHC only can be assessed by clots and core biopsies. Morphology assessment is best assessed by aspiration and touch imprints, and flow cytometry only by bone marrow aspirate sample. For bone marrow evaluation, it can follow either one of two ways. Either a lymphoma diagnosis is already made and the bone marrow is performed for staging. You can call this the guided route. Here you can look for the specific features and phenotype from the diagnostic site and base your evaluation on that. The other path is when the bone marrow is the primary site of the disease or lymph node sampling is not accessible. Bone marrow infiltration by malignant lymphoma is not a random process, but is influenced by characteristics of the neoplastic cells as well as the microenvironmental features, leading to a characteristic pattern of marrow involvement for many lymphoma subtypes. And here's a summary of what you can do to analyze bone marrow, and I will suggest like an algorithmic approach or what I do routinely in my cases. So I start first with the cytology features of the lymphoid cells, looking for the size, whether the cells are small, medium, or large, then going from inside outwards, what is the nucleus shape? Is it round, cleaved, cerebriform, flower-like, or irregular? Is the chromatin clumped or open? Is there prominent nucleolus, or whether one or multiple, or there is no? How about the cytoplasm? Is it scant or abundant? Is there granules or vacuoles in the cytoplasm? Is the cytoplasm showing projections, and whether these are circumferential or polar? Finally, assessing the sample quality. Is it particulated or non-particulated? That may indicate a dry tab. In some cases, there will be no abnormal lymphoid cells present, and this will require the bone marrow biopsy for evaluation, and it will be the major source for your assessment. Next is the bone marrow tree-fine biopsy, starting with the patterns. 6 major patterns can be seen in lymphoma involvement in the bone marrow, either alone or in combination. The first one is interstitial infiltration. That indicates the presence of individual neoplastic cells interspersed between hematopoietic and fat cells. Bone marrow architecture will not be effaced or distorted. The second one is nodular pattern, which indicate the presence of non-paratrabecular, round or oval aggregates of lymphoid cells with well-defined borders. They sometimes form or colonize lymphoid follicles. The paratrabecular pattern indicates that neoplastic cells are immediately adjacent to the bone trabeculae. The fourth one, random or focal involvement, indicates irregular distributed foci of neoplastic cells separated by residual hematopoietic marrow cells. The aggregates of neoplastic cells have no particular relationship to bony trabeculae and have irregular margins. Intrasinusoidal infiltration indicate the presence of neoplastic cells within sinusoid, either alone, which is very rare, or in association with other pattern. And this is usually very hard to detect unless very pronounced without IHC testing. Last pattern is the diffuse, or sometimes called packed, indicates extensive replacement of normal marrow elements, both the hematopoietic cells and fat cells, and indicating severe effacement of the bone marrow architecture. Next is the composition of these infiltrates, whether it is lymphocytic or mixed infiltrates that composed of histiocytes, eosinophils, plasma cells, and lymphocytes. Similar to the bone marrow aspirate assessment of the cytology feature, you can assess the cells. The cell size, the nuclear shape, chromatin, nucleoli, cytoplasmic features, as well can be seen here in the tree-fine biopsy. Bone marrow fibrosis can be detected, and it is usually reticuline fibrosis. Collagen fibrosis is not common in lymphoma involvement. After morphology assessment, immunophenotypic analysis of the lymphoma cells by flow cytometry. Starting with lineage identification. So am I dealing with B or T using CD3 and CD19? Then checking the clonality by kappa lambda light chain restriction in B cells, or CD4, CD8 ratio skewness in T cells. Based on that, you can extend your panels. And B cells, I suggest you start with the top line. Then if CD5 is positive, I use panel in the second line. If CD10 is positive, or both CD5 and CD10 are negative, I analyze with the third line. In some cases, you may need to analyze the cells with the fourth line of antibodies. Similarly, for T cells, I usually analyze the top panel, the second panel when granular lymphocytes are seen or suspected, the third and fourth line are add-ons for a couple cases as well. Lymphoma cells phenotype can additionally be assessed by immunohistochemistry. Similarly, B cells and T cells panel are very important, and some lymphoma subtype can only be determined by IHC testing, as you can see here in the suggested panels. When Hodgkin lymphoma is suspected, these are the markers that are useful for identification and assessment, hopefully leading to the determination of the diagnosis. Next are the genetic and FISH studies. They are very important in assessing bone marrow involvement by lymphoma. I strongly advise to do karyotype in all cases, especially B and T cell lymphomas. For FISH, as Dr. Sweden just mentioned and discussed, CLL cases have a specific panels. And similarly for B cell and T cell lymphomas, they have long list of probes. But sometimes one diagnosis is determined or very suspected, so requesting the confirmatory probe rather than doing the full panel is recommended. For molecular and NGS, Dr. Sweden has covered that very well. I wanted to highlight a point that with the progression in the molecular testing and the new reports that revealing defining abnormalities, so it is better to include molecular testing and NGS for your assessment. Now I want to share with you some facts on the bone marrow evaluation in lymphoma. Overall, infiltration is probably more common in B-cell lymphomas than in T-cell lymphomas. And among B-cell lymphomas, bone marrow infiltration is more common in low-grade than in high-grade lymphomas. Focal infiltration is more common than diffuse. On the other hand, diffuse infiltration is relatively more common in T-cell lymphomas than in B-cell lymphomas. Trifine biopsies are generally more successful at detecting marrow infiltration by lymphoma than bone marrow aspiration. Focar et al. Studies 93 lymphoma cases and showed trifine sections and aspirate films were both positive in 79% of the cases. Trifine biopsies only were positive in 18% of the cases. Films only were positive in 3%. In another study with 102 non-Hodgkin lymphoma cases with bone marrow involvement, trifine biopsy sections were positive in 94% of the cases, marrow clot section in 65, and marrow aspirate films in 46. And among these, only 6% of cases, they are showing positive films alone. In addition, bone marrow infiltration may be concordant, meaning the same histologic type and grade as seen in the lymph node or elsewhere, or can be discordant and showing a different histologic type or grade. The frequency of discordance has varied between 16 and reaching up to 40%. I will mention here some points to keep it in mind. To avoid false negative results, the performance of a unilateral or bilateral bone marrow trephine sample of adequate size with a minimal length of 1.5 centimeter is regarded mandatory for initial or response evaluation. Keep in your mind also variants, whether morphology variants, as you can see in mantle cell lymphoma, follicular lymphoma with plasmacytic differentiation, small cell variant and number of T-cell lymphoma subtypes, such as ALCL, peripheral T-cell lymphoma, and TPLL. In addition, immunophenotypic variants are also important to keep in mind, such as CD4 positive T large granular lymphocytic leukemia, CD10 positive hairy cell leukemia. Also, lymphoma cases can be double positive for light chain. Remember, hematogones are also negative for light chains. Also, double negative CD4 and CD8 T cells are seen in autoimmune lymphoproliferative syndrome. So keep these variants in mind always when you assess bone marrow for lymphomas. Always remember, necrosis is a bad finding, and HLH can be the major presentation or pathological finding in some lymphoma subtypes. Also, you should always keep up with the new updates in the field, like the new classification from WHO and ICC classification are essential. Also, the development and advances in flow cytometry markers that like newly reported or published. Also, molecular advances as well. I will talk briefly about some advances in flow cytometry. Flow cytometric assessment of CMYC is an assay that we developed and published in our laboratory at Case Western Reserve University. It is a very powerful assay for accurate quantification of CMYC in lymphoma cells. This is an 87-year-old man with Burkitt lymphoma with circulating lymphoma cells. The top plot is based on CD19 positive gating, and it revealed 82% of the cells are positive for CMYC. While when we gate based on CD19 positive, CD10 positive gating, the middle plots, 100% of lymphoma cells are positive for CMYC, and almost negligible percentage is positive in the CD19 positive, CD10 positive, CD10 negative cells. The bottom plot is for CD19 negative cells, indicating T cells, and show no reactivity for CMYC. And you can compare it with the CMYC expression by IHC, which was estimated to be 95%. This is another case, 42-year-old man with follicular lymphoma. The top plot is based on CD19 positive gating, and it revealed 8% of the cells are positive for CMYC. While when we gate based on CD19 positive, CD10 positive gating, the third plot, 14% of the lymphoma cells are positive for CMYC, and 0% is positive for the CD19 positive, CD10 negative cells. CMYC expression was estimated 5% by HC manual count. So it is a very powerful and accurate assay, and we have shown that it correlates better than the IHC when you compare it to the FISH results for CMYC rearrangement, whether break apart or fusion abnormality. Next, for the TRBC1, this is during the TCR gene rearrangement, a mutual exclusive selection of two cell receptor constant beta chain occurs. This allows for the flow cytometric assessment of constant beta chain monotibia as a surrogate of clonality. And this is the principle behind this flow cytometric antibody. If, like, to simplify it, it is like similar to kappa lambda in B cells. These are examples of cases with large tumor clones, and they show clearly a monotypic T cell receptor beta chain constant region expression. A and B plots are two cases of Sézary syndrome, gated based on CD3 and CD4. The first case is monotypically positive for TRBC1, 99% of the clone, while the other one is completely negative. The C and D figures are two cases of TLGL leukemia. Similarly, the first one is monotypically positive, and the other one is negative. Not even in cases with large clone, even in cases with small clones, this marker is very useful. The A and B figures is cases of peripheral T-cell lymphoma NOS. And the first one you can see gated based on CD4 positive and CD8 dim, the blue population, is clearly monotypic for TRBC1. For C and D figures is for a Sézary syndrome case that failed to reveal the subpopulation with restricted TRBC1 expression in the C plot. And this is because it was gated only on CD3 and CD4. But as you can see in the D figure, when gated by CD7 negativity with CD3 and CD4 gating, aberrant absence of expression of TRBC1 was detected. I will conclude my talk with 4 interesting cases that can show how to apply like an algorithmic approach to assess bone marrow evaluation for lymphoma. Case 1 is a 70-year-old female with left axillary swelling, presented with, as you can see, leukocytosis, anemia, and thrombocytopenia. Lymphocytes in the bone marrow aspirate are small with scant cytoplasm and clearly cleaved nuclei. Even a complete crack making it bilobed cells are seen. In the tissue, a nodular infiltrate is detected with major paratrabecular involvement. And cells in the trifine are also small in size with very scant cytoplasm. The flow cytometric analysis revealed all B lymphocytes are kappa-restricted cells and appear mainly negative for CD10 with a small bulge highlighted in green color, indicate a subset of lymphoma cells are CD10 positive. Similarly, by IHC, the lymphoma cells are CD20 positive, BCL2 positive, and PAX5 positive, highlighting the nodular and paratrabecular infiltrates. With very small proportion of lymphoma cells are positive for BCL2, BCL6, and CD10. FISH was done and showing positive for rearrangement of IGH BCL2 fusion. And the case was diagnosed as follicular lymphoma low grade. And the lesson to remember from this case is that it has been published that downregulation of CD10 is seen in leukemic phase of follicular lymphoma and also in GI follicular lymphomas. Case 2, 70-year-old male patient with lymphadenopathy. CBC showed leukocytosis due to lymphocytosis and anemia. The cells are predominantly large in size with clearly prominent nucleoli. You can see it here in the aspirate smears. The trifine biopsy showed diffuse infiltration of bone marrow spaces. The flow cytometric analysis revealed all B cells are CD5 positive and lambda restricted with strong CD20 and almost negative CD200 reactivity. You may notice from the CD45 side scatter plot, the top left plot, that these lymphoma cells are higher in the side scatter compared to the background T cells, confirming their larger size. This is maybe determined more precisely if we plot it forward scatter versus the side plotting. IHC confirmed the diffuse infiltration by CD5 positive B cells with positivity for cyclin D1. FISH was positive for IGH cyclin D1 fusion, and the case was diagnosed as mantle cell lymphoma pleomorphic variant. Case 3, this is a 29-year-old male, known case of bronchial asthma, presented with epigastric pain associated with vomiting and diarrhea for 1 week, positive history of subjective fever, weight loss, and night sweating with progressive abdominal distension. His CBC findings show leukopenia, anemia, and thrombocytopenia. No abnormal lymphoid cells are seen in the peripheral blood or bone marrow aspirate. Also, flow cytometric analysis was negative for any abnormal lymphoid population, so they are not helpful in this case. In addition, the lymph node core biopsy result was suspicious for lymphoproliferative disorder. Excisional biopsy was recommended, but the patient's situation wasn't fit to do an excisional biopsy. So the main focus was to be done on the bone marrow core biopsy. So this is the trifine biopsy. You can see multiple medium-sized nodular infiltrates are present, some with central necrosis. Higher magnification show that these infiltrates are composed of large and very pleomorphic cells, and many show multilobulated nucleoli with prominent nucleoli mimicking anaplastic look. Some RS-like cells are also noted. Also, if you can see, these infiltrates shows a rich surrounding of reactive cells, including lymphocytes, eosinophils, plasma cells, and histiocytes. CD20 appear variable and partial, but in some spots it showed very strong positivity. Similarly, staining pattern seen by PAX5. It is variable, ranging from weak to very strong positivity in these infiltrates. While CD30 is very strong and uniform, and even with accentuation and Golgi, the staining is noticed. These tumor cells are negative for CD15 and positive for CD45, and appear positive for c-MYC with variable proliferation index ranging from 30% and reach up to 80%, as you can see in this spot. And strongly positive for EBER, matching the CD30 staining, and estimated to be in 80 or more of the malignant cells. Karyotyping showed normal diploid karyotype, and FISH analysis for B-cell lymphoma panel was negative. Virology testing have shown that EBV PCR testing was very positive and show a very high viral load. So the case was diagnosed as EBV positive diffuse large B-cell lymphoma NOS, polymorphic pattern, and I believe we will have in the afternoon a session about EBV lymphoma, and this should be covered there. The last case is a 70-year-old male referred to hematology for anemia and lymphocytosis, suspecting CLL. His neutrophil absolute count was within normal limits, and platelets are also within normal count. Peripheral blood showed lymphocytosis, with lymphocytes displaying small, mature lymphocytes with slightly abundant cytoplasm and very granular. Moving right away to flow of cytometric analysis. So 70% of the T lymphocytes are found positive for CD8, CD7, and CD16, and negative for CD56. And positive for CD2, CD11C, and CD57, and negative for CD5, the most important aberrancy in this case, and negative for CD26. This phenotype is very specific for TLGL leukemia. The case was positive for TCR beta and TCR gamma gene rearrangement, although karyotype wasn't that showing a good number of metafaces, but one cell show normal diploid karyotype. FISH analysis for T-cell lymphoma panel was negative. The trifine biopsy showing similar results, so the case was diagnosed as TLGL leukemia. And by this, I conclude my presentation and acknowledgement for the people who helped for this presentation, and thank you very much.
Thank you, Dr. Light, and to all our speakers for sharing, for the depth of knowledge they have shared with us this morning. Shortly, we're going to open the floor for questions, so please prepare your questions.
I have two questions maybe for Dr. Abdullah. I'm Dr. Shukri, Assistant Consultant Hematology in King Faisal, Riyadh. First question, as you know now, there is huge progress in artificial intelligence. And for example, in King Faisal, we're using, some applications. Sometimes we have like lymphoma associated with background of immunodeficiency. And maybe by the photo of the patient, we can expect which immunodeficiency we have. You have any plan to try to invent or innovate some prediction, a protocol to start from clinical, then correlation with morphology, then immunohistochemistry, until we reach the genetics as prediction model. Second question, as you know, the population in Saudi Arabia is not the same as the West, as US or as Europe. We have our background of disease and we have our characteristics which are specific, for example, in lymphoma or leukemia. Do we have any plan for a national plan to try to study this background? Thank you very much.
Excellent, thank you so much. I will answer the first one and I will leave the second question to Dr. Nasser. So you are right, and we have this model even in solid tumors where we start something similar to tumor board, but AI-based, where you have the clinical presentation, you have the pathology slides, you have genomics data, you have cytogenetics, all integrated within one software. And many companies in the market, they are offering this. So I think having something for lymphoma will be very helpful, not just for the patient, but also to build the data in future, you can use it for research purposes. So you have all of the DLBCL, clinical, morphologic, pathology, radiology, all together to predict the outcome. I'm not aware if something exists right now, but there is many commercial software for that. The issue with that is the privacy and security of the data, and all of this may be prevented from being used, but I think something in the future will happen.
The second question is a general question, right? It's about, everybody is going to express their opinion. But I would say that there are some countries in the world, I believe Germany, France, where everything is centralized, especially pathology, especially lymphoma pathology. I know they centralize everything. They don't really, especially the smaller centers, they maybe regionalize it, or maybe then even the national level. But majority of the country, it's not the concept like everybody has to send the cases to a central laboratory and get the experts to make the diagnosis or call the diagnosis. It needs a lot of coordination. It needs a centralized system. It needs IT. It needs basically a lot of resources. And I think it has to be pushed by the health system. I don't think individually we can make the decision is to centralize everything, even if you want to. It's not up to us.
Yeah, I totally agree with Dr. Nasser. I think we have a problem of networking. Things should, the proper way is to have a network in each cancer diagnosis, not only for lymphoma. But as you know, that the health providers here are different major entities. Of course, it's led by the MOH, but still each entity has their own guidelines and protocols. And there is really difficulty to, make things in an individual, manner. It should go from, as a national decision. Probably, inshallah, we will have that. So the only way is to have a well-established networking in lymphoma, for example, because what we are talking about lymphoma in its diagnosis and workup.
Just about your first question, since Roche is one of our sponsors, I think it's okay to mention that Roche has a software AI-based for this called Navify. So this software is integrating the pathology, the radiology, the genomics, all, and it helps in decision making. It also gives you the most updated publication about this patient. So it's connected with all guidelines publication within one software. So this is something that Navify, the software from Roche. I think since they are one of the sponsors, it's okay to mention it.
Assalamu alaikum. General question. In your practice, do you request bilateral bone marrow biopsy to rule out bone marrow involvement by lymphomas? And the second question, what is the percentage of discordant cases in real practice in KSA? Thank you.
It is advised to do bilateral, but a well-sized unilateral specimen could do the job. The discordant between what? Again, the question?
Lymph node and bone marrow trophine.
Between
Lymph node and bone marrow trophine. Sorry.
We did see discordant, but it's not very common. I would say around 10%. 10%. Okay. Like low grade in the bone marrow, higher grade in the lymph node, and opposite. We had cases clearly high grade in the bone marrow. The lymph node show totally low grade.
Okay, so regarding the bilateral biopsy, you don't request it if you have enough tissue from unilateral biopsy?
definitely better. If the patient and the clinical side is willing to do bilateral, it is better.
Thank you. Thank you.
And also, this is why usually bone marrow results for lymphoma, usually they make this comment that the correlation with lymph node or tissue sampling is advised because of this discordance.
Thank
Assalamu alaikum. For Dr. Al-Ayed, regarding molecular and cytogenetic and fish and these, for discordance between this method of assessing the patient, concordance and discordance and lymphoma for the current practice.
So it depends on what you want to answer. Fish is very helpful. It's a little bit expensive, but it's very specific. So to give you answer about specific location, depending how you design the probe, you can detect if there is a fusion or rearrangement, different type of probe, as Dr. Nasser mentioned in his lecture. On the other hand, NGS and molecular technique can answer different questions. So these are two different methods. NGS, let's say, they are more comprehensive, including many genes, but it depends on how you design it. So NGS can detect structural abnormalities, can detect fusions, and also design for mutation. So this, if you see this concordance, it's expected, because these are two different results. If you want fish to be exactly as NGS, then we don't need two tests. Just order one of them and delete the other one or remove it. They are two different tests. They answer two different questions, and we will continue to need fish, karyotype, NGS, and others. And there will be new technologies coming, high resolution fish, but still we will continue using these technologies.
I have a question for each speaker. Sorry, you want to comment?
I want to clarify, especially so many clinical colleagues here, and Dr. asked a question about discordance. So I think this made it very clear that we do not classify tumors on bone marrows. Lymphomas for bone marrow is staging procedure, okay? It's very rare that only lymphoma involves bone marrow, there's nothing else. So the classification of the lymphoma is from the excision biopsy or the needle bore, if it's a good one. So that discordance question doesn't really come. So the only thing that discordant is the degrading. We mentioned about, Khalid mentioned about degrading discordance, I think it's about 10 to 15%. Other than that, we don't say that, okay, is it same disease? Obviously, it's going to be the same disease. We're not going to question the classification. We don't actually classify lymphoma on the bone marrow because it's not the site, right? That's the main issue here. I think the doctor also asked a similar question. So using fish or molecular to identify the same disease doesn't really arise.
Maybe I have a question related to that. The rule of thumb is not to classify lymphomas on the bone marrow, but in real life and practice, sometimes, especially with sick pediatric patients, you might get pushed by the clinicians to give an answer where they don't want to do tissue biopsy or they don't have easily accessible lymph node. How far do you go in these cases?
My rule of thumb, not to classify in bone marrow. It's not the site because there is a lot of limitation. First of all, you're talking about a specimen that is decaled, and the involvement could be very minimal. I mean, it could be marred by a lot of things with processing. So I don't think this is considered really safe to classify. When you are pushed, you can give a broad category like large cell, high grade, something like that. I mean, classifying among one of those 100 types is not possible. You guys agree with that?
Yeah, sometimes you try your best, like not classifying deeply to the end of the entities, but like major things, like for example, classical Hodgkin lymphoma. If it's clear and like the phenotype supporting the morphology, you say classical Hodgkin lymphoma. Subtype is definitely from the lymph node. T-cell lymphoma, okay, you can give the diagnosis of T-cell lymphoma, B-cell lymphoma, but like deep and very down in the classification, subtyping, you save it and reserve it for the lymph node biopsy.
Okay, I have a question for each speaker. So I'll start with Dr. Abdullah because he's the closest. You talked about validation of the lymphoid NGS. Are you going to have a testing algorithm, or is it open for all lymphomas? That will cost a lot if you open it for all lymphomas.
So at the end, it depends on the clinical decision, because there is no point of doing the test, finding the mutation. Then if it's not going to change the patient management, then there is no point of wasting. So for us, we are developing this test as amplicon-based test for cases who mainly fail the first-line therapy. Now, there is two schools. One school is to start testing everyone, just in case they fail therapy, you have the results ready, so you can immediately start the targeted therapy. And the other opinion is to wait until the patient relapsed or progress on chemotherapy, then you start to test. So these two ways of doing it, and we leave this to the clinical decision. If they are planning to change the therapy, they are looking for targeted therapy, then definitely NGS will be very helpful for them.
For Dr. Nasser, you concluded from your very interesting talk that we should do FISH on all the LBCLs. But if you are resource challenged, is it safe to say to only do FISH on the LBCLs with germinal center phenotype?
That would be a right conclusion if you have limited resources, because maybe 98% of DLBCLs, double hit lymphomas or GC type. So that would make a lot of sense. But again, the problem is that the GCB, to classify it as something as GCB, sometimes has its own problems, right?
Yes.
If you look at GCB type that came using the Hans algorithm, and compared it with what was the gene expression profiling categorization of GCB versus A, B, C, and versus other types, 80% concordance, right? There's still missing cases, right? We're already, kind of on the sort of losing some percent of cases because they are not really truly GCB even by doing the analysis of the immunohistochemistry. So this is why it's also inbuilt problems with it. But I would say in resource-strapped places, or I think it would be or less, technicians or people who can do the FISH for you. This may be the best option right now.
Okay.
So just if you do FISH only on GCB type, how many cases of double hit you are going to miss?
I think that I put in the data, if I remember, it was around 10% or so. Yeah, 10%.
I have to add on that, since we
not like universally done, but some of the centers have done this.
I have to add another tip. Since we were very resource challenged until recently, I started asking the clinician, are you going to go aggressive with therapy, or are you going to go with R-CHOP? If they say R-CHOP, I will not do the testing. So this goes by age and clinical status and all of that. So when you have a diagnosis of double hit or aggressive B-cell lymphoma, if they're not going to treat it any differently, why would I waste the money?
Yeah, I mean, in elderly patients where you will not expose them to very aggressive therapy, maybe that's correct approach. But I mean, I have to say that the oncologist or hematologist depends on the pathologist. So you have to guide him, you have to tell him, if this is high grade or not. I mean, if the patient turns out to be high grade and you don't offer him correct therapy at the beginning, he's relapsing back very soon and his outcomes are even worse.
Yes.
So you might be better off, especially if it's CNS directed therapy, which is very important, assessing the CSF. So these things come into place only when you direct the clinician, guide them that this is a high grade, so you need to approach as a high grade lymphoma. So this is coming very soon. I mean, a lot of our clinicians already know this, but I think some of the people just think that, let's try R-CHOP, it doesn't work.
Yes.
I don't think that's correct.
And for the FISH testing, we start with MYC and then we do BCL2 if MYC is rearranged. Okay.
Yeah, that's the way we do it.
Yeah. So to conserve more of the resources.
Yeah, I think that's easy because you have MYC negative, again, with the caveat that if you have false negatives, if you have MYC negative, then you can skip everything else, the stop FISH testing, and then classify based on what you have on morphology, immunophenotype.
Dr. Saeed, thank you for your excellent talk about CD30. We know about the importance of CD30 in the diagnostics of lymphomas. What about the prognostication? when you have clearly a high level of CD30 expression. I used to add it to the diagnostic line, especially in DLBCL and NOS, but some of the physicians were confused about the significance of CD30 in the diagnostic line. What would you do in these cases?
Well, usually when we have, like, for example, B-cell lymphoma, which is expressing CD30, I put CD30 in the diagnostic part, not only in the comment or in the descriptive, so that to give them a chance that this lymphoma has CD30, and this may help them in thinking of therapy. In addition to prognosis, especially if it is CD30 positive, EBV negative, or EBV positive, because if it is EBV negative, that is a good prognosis. If it is EBV positive, it will be worse prognosis, even with the CD30 expression. So we don't stop on CD30. If you have B-cell lymphoma, it is advised to put CD30 and EBV, EBR testing. So this will help in the prognosis, pathway in B-cell lymphomas. In T-cell lymphomas, it is something, again, variable between different types of T-cell lymphomas. If it is cutaneous, like mycosis fungoides, if it is transforming already, so it has better prognosis if it is CD30 positive. If it is not non-transforming mycosis fungoides, even if the CD30 positivity indicate poor prognosis. So it is variable even within the same disease according to which stage of progression that disease is.
So we conclude it's better to put it in the diagnostic line if it's clearly expressed.
So that it will be clear for them to read it, because sometimes they only read the diagnosis without going into details in the comment or the microscope. So I think important features that help in the prognosis or treatment should be put in the diagnostic part.
Okay, thank you.
You mentioned that the expression of CD30 in EBV positive is worse prognosis. Is that compared to, like, what are you comparing it to? Is it compared to the EBV positive without CD30 or the CD30 without EBV? Like, what's your comparison?
Yeah, in diffuse large B-cell lymphoma, EBV is the key for worse prognosis if it is associated with EBV. They compare now, if it is EBV with CD30 or without CD30, they conclude that even CD30 positivity cannot convert it into good prognosis. That's why CD30 is good to be seen in diffuse large B-cell lymphoma, except if it is EBV positive.
Bit on that, because EBV positive large B-cell lymphomas, there was actually a good report from Jaffe's group maybe a few years ago that actually divided them into the EBV in the early age group up to 30, and those actually didn't do bad. The outcome was pretty good. It is the older age group, which used to be the senile EBV or whatever, the elderly, those were bad. The younger age group, the EBV positive, are not poor outcome. Yes.
Dr. Khalid, I really liked your paper about the MYC clone or the MYC antigen that you used, but it does not differentiate if it's rearranged or amplified or there's a specific translocation. So it might be positive in a lot of B-cell lymphomas. So how is this MYC? How do I convince our hospital to buy this MYC antigen?
It's like as IHC, assessment. It's only for the protein. It can be driven by either a fusion or amplification. So we developed and make this assay just as a replacement or like a comparative tool with the IHC testing, because you saw sometimes a lot of background, or when the tumor is like limited and not very big in the tissue, so quantification will be very subjective. So that was the idea behind it, is to like report or like develop a reliable, very accurate quantification tool. It correlates slightly better than the IHC. We have shown that number of cases that is high in protein expression that is negative for FISH rearrangement are less in the flow cytometry than in the IHC testing. It has its, pros and cons, but like to correlate exactly and replace fish assessment, it's still as what is the, acceptance and belief in the IHC staining.
Before I proceed with my questions, I might give the audience a chance if anyone has a question.
Thanks for the great talks. Just got a few comments and questions. So the bone marrow indication in lymphoma, as Dr. Aid perfectly mentioned, it's either like staging and or to diagnose. For the staging, we moved away from doing the bone marrow. It's invasive unless it's going to change the management plan, the treatment plan. And this is only few indications. So if you have a low-grade lymphoma, only localized, and you are going to treat with radiation, you need to make sure it is localized. So we do a PET scan first. If it is negative, we go and do the bone marrow just to confirm there is no bone marrow involvement, so you can treat with radiation. But if it's not going to change the management, we are not going to do it. If you have stage 3 or stage 4, it doesn't make a difference. So the treatment is the same. So we only do it for certain indication. If you have cytopenias, there might be a concurrent, like another diagnosis like MDS, or the other indication, if it's the primary, sometimes you can have diffuse large B-cell lymphoma, mainly involving the bone marrow. This one is, we should do the bone marrow. The other comment is regarding the NGS and the FISH, the molecular test in lymphoma. I think it's very important. At least we should do the FISH for all our patients. It gives a lot of information. And there was a recent very big trial, remodel trial in the UK. It was comparing R-CHOP and R-CHOP with bortezomib in ABC, large B-cell lymphoma. And initially this study was negative, there is no benefit of adding bortezomib. When they looked back and checked the subclassification of the high-grade lymphoma, it was positive in 13 abnormalities. So it's very important. I think we are moving towards the molecular guided treatment in the diffuse large B-cell lymphoma. My question is regarding the CLL, the TB53 mutated. Again, in the CLL, we need to know if it is TB53 and IGHV mutated or not. So the TB53, I think there's a difference between TB53 and deletion 17. So do we do both, or we only do one of them would be enough?
Yeah, so definitely you need to do both. So you need to do the deletion, 17B deletion by FISH. Then you need to do a mutational analysis for TB53 to detect any mutation. Then also you need to do allelic imbalance, so to detect any loss of heterozygosity in TB53. So allelic imbalance means that there is a deletion and duplication at the same time. So if you do FISH, it will be intact. You get 2 copies, but they are 2 copies of the same gene. So this is also causing loss of function in TB53. So all of them is a mechanism that leads to abnormal TB53 protein function, and all of them you should do the testing for all, and all of them will change the therapy as you mentioned.
Also, the last thing I'll say that if you just do FISH, you're going to miss 15 to 20% of P53 mutated. So it's definitely a must. I don't know what Abdullah can enlighten us if P53 VAF has any value in CLL, like fraction, how much VAF is how much cut off, anything like that?
I'm not aware of any.
It's probably not, because in the AMLs and stuff like that, it's not important. Okay.
Any other question? I have a question for Dr. Bakhshi. You mentioned in your presentation about c-MYC rearrangement in a small proportion of T-cell lymphomas. Can you shed more light on that? Do we know the partner, and do we have evidence of if that rearrangement is the underlying or the driving genetic abnormalities that is driving this T-cell lymphoma, or it's not related to the lymphoma?
It's very uncommon. I think the only publication I was reviewing through, and I saw one in Blood, maybe last year. It was about PTCL. They did some mouse models, and they were interested in analyzing different gene mutations, especially high-grade mutations. They found NMIC, not CMIC, by the way. I mentioned it in my presentation. It was NMIC. Maybe 14, 15%, was a small number. But they think because we know so little about PTCL, so it may be helpful. There is not really much published. I looked at data in T cells. I don't know if you know anything which is very, like, any is very helpful in data about PTCL or T cell lymphomas. I don't know much about MYC involving the PTCL or T cell lymphomas. Do you know anything which is? So I think it's very, very uncommon. For some reasons, it's more, I mean, especially in a common and readily used marker for B cell lymphomas. For T, I haven't really had a chance to look into it.
Thank you very much. My other question is to Dr. Swaydan. For mid-88, it's a very common question. I think it's always asked, and I always ask it. Mid-88 is very sensitive in terms of for LPL, but it's not specific, we know that, but then there are reports of LPL that are negative for mid-88. What do you think of those cases? Do you think they're truly mid-88 negative LPLs, or they're misdiagnosed or mislabeled cases that there are other B-cell lymphomas with plasmacytoid or plasmacytic differentiation?
Yeah, so as you mentioned, MYD88 and CXCL4 are common in LBL. Now, the new WHO, they divided the LBL Waldenstrom into IgM and non-IgM. And the non-IgM is rare, that's why I ignore it, but most of them are negative for MYD88, so, or at least less common in that group. And they have more CXR4 mutations. So these cases, if it's IgM missing MYD88, it's still a challenge. If you find the other mutations, CXR4, still support LBL. If it's missing all of these mutation, then you go back to the morphology, try to confirm the morphology. The morphology of LBL is, as you mentioned, it's not straightforward, it's not diagnostic, it can mimic others. The stains are not that specific. So it's helpful when we have the mutation. When we miss the mutation, it could be.
Also, I mean, there is also possibility that we could be having other than the 256. You know, that's wild type, but there are other mutations that we also described in MYD gene, so it's not necessarily only one. So that's, I think, maybe 90%, but there are diseases, including Waldenstrom's, that could have mutations other than that, yeah.
Perfect, thank you very much. And then another question for Dr. Swaydan. You mentioned about when you talked about the T-cell lymphomas with TFH immunophenotype, you mentioned that there was a proportion, I don't remember the exact percentage, where the T-cell clonality was negative.
Yeah. Excellent. Excellent. So this is the challenge with TFH immunophenotype. It's the follicular helper T-cell lymphoma. It's a spectrum of disease. And early stage is very difficult to diagnose because the background has many reactive T cells, has many B cells that's positive for EBV. So in these cases, you get false negative clonality results because the background has many non cells. Yeah, so the background non-neoplastic, and when we do the molecular testing, we amplify the region of T cell from all cells present within the tissue. So most of them are non-neoplastic, so this is what gives you a false negative result of T cell gene rearrangement.
I just wanted to comment that you have to have a very high pre-test probability. So molecular and cytogenetics are supportive, they're not diagnostic by themselves. So you have to have all the, workup done before you go and ask for cytogenetics and molecular.
If you hear about the AITL in the old age, the patient used to present with end stage disease everywhere and symptomatic with fever. And now we are detecting these cases early. Once there is slight lymphadenopathy, we biopsy. So we don't see the full picture of AITL. We see it in early stages. If you wait, it will become positive for T-cell gene rearrangement.
I also read somewhere that MYD88 can be also positive in marginal zone lymphoma.
Yeah.
So that's the main differential. So if you don't know what you're looking for in the beginning, MYD88 will be very confusing.
True.
Okay. Can I conclude? Okay, thank you very much. Thank you very much, Dr. Rima and Dr. Fatma, for your chairing this session, and also for my dear colleagues, Dr. Abdullah Swaidan, Dr. Nasser Bakhshi, and Dr. Khalid Al-Aid. We finished the first session, and now we will have, inshallah, the coffee break and lunch with each other, so that we will have long break to give a chance to people who want to go to Al-Haram for Dhuhr prayer and come back for lunch. We will see you, inshallah, sharply at 1 p.m. in the afternoon. Thank you very much for your attendance and for your patience.
the interesting talk in cutaneous lymphoma by Dr. Tariq Zaid. Dr. Tariq is a highly respected consultant anatomic pathologist specializing in dermatopathology and bone soft tissue pathology at the Department of Pathology and Laboratory Medicine in King Faisal Specialist Hospital and Research Center in Riyadh. He has been serving in this role since July 2012. Dr. Zaid holds several prestigious certifications, including the American Board of Dermatopathology 2012 and the American Board of Anatomic Pathology 2010. He completed his fellowship in dermatopathology and soft tissue pathology at the University of Texas MD Anderson Cancer Center in Houston, Texas. Dr. Zaid's extensive postgraduate training also includes anatomic pathology residencies at Tufts Medical Center in Boston and King Faisal Specialist Hospital and Research Center in Riyadh. He earned his Bachelor of Medicine and Bachelor of Surgery from King Saud University in Riyadh 2003. Dr. Zaid is dedicated to advancing the field of pathology through his clinical expertise and commitment to patient care. Welcome, Dr. Tariq, and the floor is yours.
Assalamu alaikum. I would like to thank the organizing committee for the invitation and for preparing this conference. And thank you very much for the nice introduction. I'm going to talk about cutaneous lymphoma, primarily T-cell lymphoma, which represents the largest group of lymphomas involving the skin. We'll start with, let's see. Okay. We'll start with 3 cases, then we will go over them again during the presentation. The first case is a 27-year-old lady presented with chronic generalized scaly plaques on trunk and extremities, and skin biopsy was taken. Here, skin punch biopsy, as you can see, with superficial dermal lymphoid infiltrate, as you see here. On higher power view, these infiltrate in papillary dermis with infiltration of the epidermis as a group of cells here. Higher power view that represent that these lymphocytes are large in size with mild hyperchromasia, irregular nuclear contour, and there's some papillary dermal fibrosis here. Differential diagnosis, mycose fungoides, then other mimickers, Pityriasis lichenosus chronica, or peripheral T-cell lymphoma NOS, or lichen planus. We'll go along these things in the presentation. Just to give you an overview. This particular patient was treated for mycose fungoides, and 10 years later, she presented with an elevated nodular skin lesion on the left thigh, and skin biopsy was taken. As you can see here, there is a dense dermal lymphoid infiltrates in superficial and deep dermis. On higher power view, you see these lymphocytes are large with focal infiltration of the epidermis or epidermotropism, and the size of these lymphocytes are larger than the previous biopsy. Here is higher power view, hyperchromasia, mitosis, large size. And this is the immunophenotype of the infiltrate. So it's CD3 positive, 4 positive. See the contrast between 4 and 8. They are 8 negative with loss of CD7 expression, and they are CD30 negative. Differential diagnoses include here mycose fungoides with large cell transformation, which is the diagnosis, or anaplastic large cell lymphoma, which is CD30 positive lymphoproliferative disorder. Then others, gamma delta T-cell lymphoma, NK T-cell lymphoma, lymphomatoid papillosis. But here with the clinical history, is helping us more toward the diagnosis of mycose fungoides with large cell transformation. Case number 2 is a 2-year-old boy presented with 3-month history of fever, skin rash on examination, erythematous woody indurated plaques over lower limbs and forehead and right wrist. He had hepatosplenomegaly, And this is a skin punch biopsy from the patient. As you see, there is inflammatory infiltrate lobular in the subcutis. This is higher power view, so the infiltrate is primarily in lobular pattern in subcutaneous fat. There is no significant involvement of epidermis or dermis, so it is restricted to subcutis. This is a higher power view, the atypical lymphoid infiltrate rimming the adipocytes. As you can see, this is a higher power view, again the same. This is another one with the rimming, atypical large lymphocytes. So this is the immunophenotype. So they are primarily CD3 positive T cells that express CD8. And if we compare CD8 to CD4, CD4 is negative. This is a higher power view for the same immunostain. CD3, CD8 mirroring each other. We have high Ki67 proliferation index rimming the adipocytes, and there is negative staining for CD4. There is a mild decreased expression of CD7, CD20 is negative, 56 negative, and TDT is negative, and EBV and cytohybridization is negative. This is smear from the bone marrow. So as you see, this is hemophagocytosis. This is the histology from bone marrow highlighting the hemophagocytosis, and this is CD68 highlighting that. So patient was sick. So differential diagnosis, subcutaneous polyclast like T-cell lymphoma, primary cutaneous gamma delta T-cell lymphoma, extranodal NK T-cell lymphoma, nasal type, aggressive epidermotropic CD8 positive CTCL. So we'll go along along these things in the presentation. So this group of diseases, they involve the subcutis in prominent fashion. Case number 3. This is a 45-year-old lady presented with 1-year history of asymptomatic skin lesions that are hypopigmented. And the clinical differential diagnosis was psoriasis and mycosis fungoides. So as you see, the punch biopsy, inflammatory infiltrating superficial dermis, they are tagging dermo-epidermal junction in with prominent pattern of tagging, and there is papillary dermal fibrosis. They are going along the eccrine ducts. Here they are a little bit large in size, mild hypochromasia and papillary dermal fibrosis. And this is the immunoprofile. So they are CD3 positive, CD8 positive. They are similar to each other. CD4 is negative. This is CD3, CD8 higher power view, and CD4 is negative in the cells tagging dermo-epidermal junction. And they are positive in dendritic cells and in epidermis and macrophages in the dermis. So the T cells are negative. Here the cells, they are negative for CD7. So differential diagnosis, mycosis fungoides, CD8 positive, mycosis fungoides, inflammatory vitiligo, lymphomatoid drug eruption, aggressive epidermotropic, CD8 positive, CTCL. So these are all, they are CD8, they can present with CD8 positive epidermotropic atypical lymphocytic infiltrates. So we'll go through that in the presentation. So cutaneous T-cell lymphoma is a big group of disorders. The largest group include mycosis fungoides and Sézary syndrome, and this represents 65% of CTCL, followed by CD30 positive lymphoproliferative disorder, including LYP and ALCL, representing 25%. Then there are a rare group of diseases representing all of them 10% of the CTCL cases. Some of these forms are aggressive, such as aggressive epidermotropic CD8 positive CTCL, and some of them are indolent, like primary cutaneous acral CD8 positive T-cell lymphoproliferative disorder. So we'll go through some of them. So in evaluating biopsy from patients with possible or clinical impression of cutaneous T-cell lymphoma, along other diseases in pathology in general, we have to put the clinical and histopathology together, including morphology, immunostains, and possibly molecular to reach a definitive diagnosis. In cases where CTCL is suspected, We look at the age. For example, mycosis fungoides is common in older patients. We look at the morphology. Is there patch, plaque, tumors, chronic illness that's seen in mycosis fungoides? Is the disease is aggressive with prominent ulceration? That is seen, for example, in aggressive epidermotropic CTCL. Is there hypopigmentation, papules in LYP, single lesion, multiple lesions? If there is history of systemic lymphoma with secondary skin involvement, and the immunostatus for the patient, if the patient is immunosuppressed post-transplant, such as EBV, positive lymphoproliferative disorder. So we look at all these parameters and we match them. We try to match them with the histology, immuno, and molecular. So in evaluating skin biopsy, we look at the structures available, the structures of the skin. So the skin, as you know, composed of epidermis, dermis, adnexal structures, subcutaneous. So we look at epidermis. If there is atypical infiltrate in the epidermis, that's epidermotropism. The dermis as well. So epidermotropism is seen in mycosis fungoides. We look at the follicles, like folliculotropic mycosis fungoides. We look at eccrine glands, syringotropic mycosis fungoides. So for example, folliculotropic mycosis fungoides is more aggressive than the conventional mycosis fungoides. So we look at the structures of the skin. Then we look at if there is green zone, if the infiltrate primarily in the dermis. Then we look at the distribution of the infiltrate. If it is wedge-shaped like this, which would be corresponding to papular lesion, classically seen in lymphomatous papillosis. Then, as mentioned, we look at subcutaneous. Is there subcutaneous involvement? Is the subcutaneous involvement exclusively subcutaneous, or there is dermis and epidermal involvement? If it's exclusive, it's like panniculus like T-cell lymphoma, like our child. Gamma delta involve all. NKT cell lymphoma involve all. This is example of subcutaneous panniculus like T-cell lymphoma. Well, there is mainly subcutaneous involvement. We look at the vessels. If there is intravascular lymphoma, like B-cell lymphoma or NKT cell lymphoma, these are rare diseases, but you never know. If you look at them, if you don't look for them, you may miss them. And then we look at the infiltrate and the relationship of the infiltrate to the vessels, for example. Is there angiodestruction? Is there necrosis? And that's seen, for example, in NKT cell lymphoma, can be seen gamma delta T cell lymphoma, EBV, positive lymphoproliferative disorder do that. So we look at the vessels and how they are affected. We look at ulceration. So ulceration is uncommon, can happen with mycosis fungoides, but is not uncommon. It's more common with cutaneous T-cell lymphoma, CD8 positive cytotoxic markers. They induce necrosis more than mycosis fungoides. So necrosis, ulceration is another thing. We look at the morphology of the inflammatory infiltrate, the size, are they monotonous, polymorphous population of cells. And then we keep in our mind benign mimickers, especially in mycosis fungoides, early stages of mycosis fungoides. So there is a long list of mimickers. These are just examples. Pityriasis lichenoides, lichen sclerosis, lymphomatoid drug. There are many causes. Here's some of them. For example, Pityriasis lichenoides chronica. They may have similar appearance to mycosis fungoides, but they have interface changes, dyskeratosis, RBC extravasation. They present with maculopapules with scales that fade with minor hypopigmentation or hyperpigmentation. And as mentioned, the lichenoid infiltrate, which is uncommon in mycosis fungoides. As mentioned before, here's another mimicker, pigmented perberic dermatosis. They can mimic mycosis fungoides histologically, but if we look at the distribution of the lesion, this entity usually in the lower legs, but mycosis fungoides exclusively involving the lower leg is uncommon. and these are associated with RBC extravasation, hemosiderin, which is uncommon in mycosis fungoides. So distribution of the lesion is helpful as in this entity. Then another one here, chronic actinic dermatitis. This one of the entities that can be mistaken as mycosis fungoides, but the clinical is helpful because these, from the name, they are usually at sun-exposed areas, while mycosis fungoides is generally in sun-protected areas. So if we keep this in mind, that will help us in navigating through the differential diagnosis of atypical lymphoid infiltrate in the skin. So as mentioned, chronic actinic dermatitis, sun-exposed area, mycosis fungoides, sun-protected areas. This entity is usually CD8 positive. Mycosis fungoides is commonly CD4 positive, but it can be 8 also. So lichen sclerosis is another thing, especially the early stage, can present with lichenoid inflammatory infiltrate that can mimic mycosis fungoides, but in advanced lesion, there is hyalinization, edema in superficial dermis, which will make the diagnosis more easy. And for the location, usually they are exclusively in the genital area, but they can happen at other sites, but usually in the genital area. While mycosis fungoides exclusive in genital area is uncommon. So again, distribution of the lesion is helpful. Now, lymphomatoid drug eruption, and this can mimic mycosis fungoides. There are medications that can cause inflammatory infiltrate in the skin that can look like MF, but they are not. They are usually CD8 positive. An example of that is anti-epileptic medication. And what makes things more difficult, for example, this medication, the mogamulizumab, used in treating mycosis fungoides. So it is known to cause drug rash overlapping with mycosis fungoides. So here are the patterns of side effect of this medication: spongitic dermatitis, lichenoid inflammatory infiltrate, granulomatous reaction pattern, and granulomatous reaction can happen with mycosis fungoides as well. But how can we navigate through this? We look at, again, at the clinical, again, histology and other parameters. So lymphomatoid drug for this disease, for this medication, there is predilection in the head and neck area. While mycosis fungoides is usually in other sites. It presents with morbidly-formed dermatitis presentation. It has photo-accentuated pattern, unlike mycosis fungoides. This is uncommon in mycosis fungoides, usually in sun-protected area, as mentioned. And they are usually CD8 positive, while mycosis fungoides is CD4 positive, usually. Here is an example of a case that we published. We published a lymphomatoid drug eruption. It's called keratodermal-like T-cell dyscrasia. This patient was presented to the dermatology clinic with a keratodermal-like picture. There's redness in the palms and soles with itchiness and scales, and biopsy was taken. And as you can see here, there's superficial dermal lymphoid infiltrate. The lymphocytes are a bit large, they are a bit hyperchromatic, irregular nuclear contour, they infiltrate the epidermis. But at that time, we felt that this is not enough for mycosis fungoides. It's just falls short. It doesn't show enough features to call mycosis fungoides with confidence. So we said this is likely T-cell, unevolving T-cell dyscrasia. Then the patient, then the clinician, she looked back into the medication, and she found that patient is taking statin, one of the statins, which is reported to cause keratodermal-like T-cell dyscrasia. So before that, before the biopsy, they were treating the patient with steroid. It's not responding to steroid. So after the biopsy and suspecting that the statin was the inducing drug, they gave steroid and stopped the medication. And this is 6 months after stopping medication, lesion resolved. So that's another thing. The other scenario, this can be called as mycosis fungoides, and patient will continue to keep taking medication and receiving treatment for mycosis fungoides. So there is a big difference. Here is the other entities that overlap with mycosis fungoides. Mycosis fungoides this represents the pathogenesis of mycosis fungoides. They have the T lymphocytes. They have multiple receptors, and they infiltrate the epidermis through specific surface molecules, and then they infiltrate the epidermis. They tag the dermo-epidermal junction, and they go around the Langerhans cells. So that's why we see Poitier microabscesses, because these atypical lymphocytes, they go around Langerhans cells and they form these Poitier microabscesses. And the other thing, another soft criteria that, or morphologic key that I use when the mycosis fungoides is clonal, are clonal T cells. They are clone. So likely they are related to each other. So when they infiltrate the epidermis, they infiltrate it in a systemic way, organized way. They tag the dermo-epidermal junction. They go into the epidermis, forming Poitier microabscesses. While reactive conditions, they are different population of T cells. So they infiltrate the epidermis in haphazard way, like air blowing the T lymphocytes within the epidermis. So they don't have the organized pattern seen in mycosis fungoides. This is one of the features that is observed with the way that the atypical lymphoid infiltrates present in the epidermis for mycosis fungoides cases. So this is represents the evolution of the lesions. So at the beginning, there is the red are neoplastic and the blue are reactive T cells. So in the early stage, there are reactive cells. So as the lesion progress, there are more neoplastic cells. Then in the Caesarea phase, the cells become less in the skin. They go into the circulation. If you do biopsy of Caesarea patient, you may not see much. So as the lesion progresses, more neoplastic cells, it's more easy to appreciate the morphology, more easy to read the immunohistochemistry, and the yield for molecular will be higher because we have more cells. Here is the patch, plaque, tumor. Again, we talked about that, the follicular tropism. This is a variant of mycosis fungoides with multinucleated giant cells eating elastic fibers, causing redundant skin in a background of neoplastic T cells, granulomatous-like skin. Pagetoid reticulosis is a variant, single lesion, prominent epidermotropism, CD8 positive T cell infiltrate. Immunophenotype, commonly CD4 positive, can be CD8 positive, rarely double positive, rarely double negative. Then we use T cell gene rearrangement in difficult cases or early stages of mycosis fungoides. So we try to use T cell gene rearrangement in cases where we have difficulty in making diagnosis. So basically, the regions in the T cells, we have gamma delta gene rearrangement, which happened before the alpha beta. So we have alpha beta gene rearrangement and gamma delta. The gamma delta happened before, and it can revert, go back. So this can happen in reactive conditions, while alpha beta is seen in neoplastic conditions in T cell lymphomas. So this is more specific for malignancy, less sensitive. And this is more sensitive but less specific for malignancy. So we look at the clone. It has to be single clone, good amplitude of the clone. If we have multiple clones like this is pseudoclonality. So PCR sensitivity in early stage of mycosis fungoides. So sensitivity 50% for patch, then increase the yield as the lesion progress. Specificity for gamma delta is poor, is not that specific. So this is another way of technique using the TCR. So we do two tests. If we have gamma delta, for example, PCR, we do two tests from two different sites. preferably 2 different times. So if we have same clone, 2 different sites, different times, exactly same clone, so this is neoplastic. This would suggest that this is neoplastic process. This is more of mycosis fungoides. While if there are different clones, the clone disappeared, this is more of reactive condition. NGS is said to be has higher sensitivity than PCR, and also higher specificity. It discriminates neoplastic or mycosis fungoides more than the reactive conditions in a better way than the PCR. But again, it is not fully specific. So we have again to put everything together. Other application of NGS, discrimination between disease recurrence and other inflammatory conditions like the drug rash that we talked about due to medication used for treatment, assist disease recurrence, follow-up for response. Again here, we have to put, just to emphasize that we have again put everything together. Then we have to weigh things, the cost effectiveness. Is it really cost effective to do these expensive molecular tests or take additional biopsies, do immunostains, and follow up the patient? So we put things together according to our setup. So this is the case I talked about before. This is the mycosis fungoides, and this is large cell transformation. So differential diagnosis, ALCL, but this is CD30 negative. You can include LYP as CD30 lymphoproliferative disorder. This is the guy who described LYP. It was, I think, 1968. That this disease looks ugly, but it is under microscope looks ugly, but clinically it is more indolent. And this is one of his patients. With shape, large cells, typical. They are CD30 positive, and they present as a group of papules that come and go, leaving scars. Differential diagnosis: anaplastic large cell lymphoma, usually single lesion, large in size, more than 2 centimeters, according to some authorities. So that's the. So there are different types, long list of types of LYP. These are in the WHO. So we have A, B, C, they are 4 positive. Then D, E, LYP with DUSP, they are CD8 positive. And the differential diagnosis here, LYP type A, ALCL, MF. So they overlap. The significance is that this group, specifically, we'll talk about that. D and E overlap with aggressive T-cell lymphomas. Here the type A with shape, scattered atypical cells. This is very few large cells similar to MF, and this reminiscent to ALCL. There are more larger cells. D, it is CD8 positive. The others are CD4 positive. So this one is CD8 positive. It overlaps with this aggressive entity, but the clinical will be helpful. It presents as papules, epidermotropism, as you can see. So if you don't know what's the history, it's very difficult. This is type E. Look like NKT cell lymphoma nasal type. It looks very aggressive under microscope, but it is clinically papules, come and go, leaving scar. Here there's ulceration, black discoloration, because it involves vessels, causing necrosis. This is type E. So clinically, they are the same, but it's good. It's important to know because they overlap with other things. LYP with DUSP22, this overlap with large cell transformation and mycosis fungoides. Then other types, folliculotropic, MF, LYP, syringotropic. Then I have seen a case of this LYP with CD1A dendritic cell hyperplasia. mimicking Langerhans histiocytosis. So clinically, it looks like LYP, but under microscope, you see a lot of dendritic cells. And initially, you may think that this is Langerhans histiocytosis, but again, the atypical lymphocytes, the presentation is different, and they have seen one case similar to this, pseudocarcinomatous change in LYP. So there is LYP. On top of that, there is pseudocarcinomatous hyperplasia. And that case, the initial biopsy was superficial shave biopsy. So you mainly see pseudoepithelial hyperplasia. You may think this is squamous cell carcinoma. Then a few atypical lymphocytes in the dermis. Then with the excision, you see the whole thing. This is then there are the gamma delta LYP, oral involvement, and this as persistent ignition of LYP. I have seen one case like this. So the patient here, they present with patch or plaque of mycosis fungoides. Then on top of that, there are LYP that they come and go. They appear as papules, then they ulcerate on top of plaque. So our patient, he presented with classic picture of mycosis fungoides. Then he presented to the dermatologist at a stage of healing LYP. So he presented with the patch of MF. Then in the center, there is punched ulcer. They thought this is pyoderma gangrenosum within the mycosis fungoides. But this is a rare variant of MF with LYP. So the patient later in follow-up appointment, he brought pictures with different stages of the lesion that ulcerate on top of the plaque lesion of mycosis fungoides. That was very, very interesting case. This is the one that we saw before, the epidermotropic. So for this one, we go, this is MF, CD8 positive MF, hypopigmented. So for this one, we go along the differential diagnosis of CD8 positive epidermotropic infiltrate differential diagnosis. So this include LYP type D, pagetoid reticulosis, and MF CD8 positive. This group is indolent, generally. Even CD8 positive MF, it is indolent disease, which is compared to this one, which is very aggressive disease. But the clinical will be helpful. This is the aggressive epidermotropic. So it's bad, aggressive, fast clinical course, ulceration. They may involve subcutaneous, not common, and they are CD30 negative, 56 negative, EBV negative, TCR gamma negative, overlap with gamma delta, so it should be negative. And here is the differential diagnosis. These are lymphomas that involve subcutaneous. So we talked about that, pannucleus like T-cell lymphoma, exclusive subcutaneous, gamma delta, and NKT cell lymphoma. So for this one, again, they are 8 positive, beta F1 positive, and the gamma delta here,
5 minutes.
TCR gamma delta.
5 minutes.
Okay. TCR gamma delta here is positive, and the NKT cell lymphoma, EBV positive, 56 positive. So, and as you see, prognosis is bad. As you move, prognosis is bad. This is the gamma delta. We talked about that. There is angiocentricity, involve all the structures of the skin. They are gamma delta positive. So they are gamma delta positive and overlap with the other ones. LYP, aggressive, but they are gamma delta positive. The other ones are not. This is superficial variant. Look like mycosis fungoides, behave worse than mycosis fungoides, and better than the classic variant. And they are gamma delta positive by immunostain. We talked about pannucleus like T-cell lymphoma. This is our kid, the NKT cell lymphoma. So the important thing is EBV positive. And I will stop here. This is when do we check for ABV? Presence of angiocentricity or angiodestruction, mucocutaneous ulcer, cytotoxic immunophenotype, prominent 56 expression, B cells express CD30, presence of both skin and lung, lymphomatic granulomatosis, young patient with facial edema, hydrovacciniform-like. This is usually children, elderly patients, immunodeficiency. So we check for ABV in these situations. So with that, I conclude.
Thank you so much, Dr. Tariq, for this excellent talk. It's supposed that we have the questions at the end of the session, but because Dr. Tariq wants to catch a flight, so if you have questions, we can have it now, please. Yes, please.
Thank you, Dr. Tariq, for this amazing talk. But I have a question regarding skin biopsies. As a lymphoma pathologist, I end up getting a lot of skin biopsies with a lot of lymphocytes that are not a lymphoma. So a lot of them, they have no changes in the epidermis, no epidermotropism, no atypical lymphocytes. And then you see the CD4 to CD8 ratio, it is slightly high, mostly perivascular, and with a minimal loss of CD7. It's not MF, so I just call it a perivascular dermatitis.
Yeah.
But they don't like that, so they want more like definitive diagnosis. Do you send these cases to PCR always? And what differential should you give the clinician?
Yeah, so basically, we look. I look at the clinical history. So is it chronic disease? Is it short history? And what is their clinical impression? So if they are suspecting mycosis fungoides in early stage mycosis fungoides, this can be problematic due to the minimal amount of the infiltrates. The yield is not that high, so it depends on the presentation. So if the presentation is chronic, they are really suspecting cutaneous T-cell lymphoma. There is no eczematous dermatitis features because it overlap with that. Like chronic eczematous dermatitis, no features of psoriasis because it overlap with mycosis fungoides, and no features of interface changes. So we look at the benign mimickers from what they say, and we try to exclude the benign mimickers that can be chronic. If there are no features of that, and we see inflammatory infiltrate, element of atypia, minimal exocytosis, we tell them that there is, they know that there's few inflammatory infiltrate in dermis. It could be mycosis fungoides. We cannot make the diagnosis now. You may need to do the clinical follow-up and repeat biopsy of different lesion. And if we have enough inflammatory infiltrate, at least the immunophenotype is going to be also problematic. So if you didn't have morphologic features convincing for MF, it's difficult to make it. When I have enough inflammatory infiltrate in dermis, sometimes they send for TCR to have it as a base. So when they repeat the biopsy later, I will know that we had previous biopsy, there is clonality there. So we keep this in consideration in evaluating a new biopsy. So even if the biopsy is negative, we cannot make a diagnosis, we still can use it to build up a case. So TCR, if there is good result for TCR, at least we have in file previous biopsy, we compare with the, so MF early stage is always, I think it's always better for early stage patch, mycosis fungoides. It's better to delay diagnosis until it become more evident than labeling patient with no mycosis fungoides, labeling him with mycosis fungoides. Example of that, the case that I presented, the drug rash. So again, it depends on the expertise. How much do you see? The clinician, how much do they see? So it's all parameters just add on top of each others. It's always difficult. It's all, the simple answer is it's always difficult. Yeah.
Any further questions? So I have a question, Dr. Tariq.
Yes.
You mentioned the NGS, utilizing NGS in the clonality of T-cell lymphoma, but still not specific. So how do you utilize it? I mean, do you do it routinely for all cases, or
not yet. Now we don't in our place we don't use it yet for evaluating these patients, but probably in the future. So yeah, for now, yeah.
Yeah. Any other questions? So by this, thank you, Dr. Tariq, and we'll move to the next talk. Thank you so much. So our next talk in the agenda will be presented by Dr. Lina Tahir. Dr. Lina is consultant lymphoma pathologist in King Abdulaziz Medical City, Riyadh. Postgraduate education started with the training pathology program in Riyadh, graduated in 2013, and joined King Abdulaziz Medical City National Guard 2014 as associate consultant. Lymphoma and spleen fellowship in 2017 in the Royal Marsden Hospital in London, UK, and member of the Royal College of Pathologists. The talk will be about gastrointestinal lymphoma. Welcome, Dr. Lina, and the floor is yours.
Thank you so much for the introduction and the invitation. My talk today is about GIT lymphomas. GIT or the GI tract is the most common extranodal site involved by lymphoma, and the majority are being non-Hodgkin lymphoma. The most frequent site for occurrence is the stomach, followed by the small intestine and ileocecal region. We can divide these lymphoma into primary or secondary. Secondary is the most common lymphoma. Regarding the primary, it's about 1 to 4% of all gastrointestinal malignancies. Historically, most of the primary gastrointestinal lymphoma are of B lineage. We can see a few cases of T-cell and very rare Hodgkin lymphomas. Diffuse large B-cell lymphoma is the most common pathological GI lymphoma. We can see other types in the GI tract, like EBV positive mucocutaneous ulcer as a disorder. We have multiple lymphoma, especially in stomach, mantle cell lymphoma in the small intestine and colon, ETL in the duodenum and duodenum, the metal also in the small intestine, and the follicular lymphoma of the duodenum. There are many causes implicated in the pathogenesis of intestinal lymphoma, including infections. We have the H. pylori, HIV, the Campylobacter jejuni infection, EBV, hepatitis B virus, the human T-cell lymphotropic virus, and other diseases like inflammatory bowel disease, celiac disease, and iatrogenic factors like immunosuppression. To call it primary lymphoma, we need to follow criteria, and we need to have absence of peripheral lymphadenopathy at time of presentation, lack of enlarged mediastinal lymph nodes, normal total and differential white blood cells, predominance of bowel lesion at time of the surgery, and there is no lymphoma involvement in the liver or spleen. A very simple diagram showing that GI tract starting from the mouth, ending up by rectum and anus. We're going to start from up, oropharyngeal lymphoma. It's around 2.5 of all malignant lymphomas originating in the oral cavity. Usually include adenoids, tonsils, the tongue, or oropharyngeal wall. Most important factor in this area is the ABV infection. There is a prediction for male, and usually the patient is older than 50 years age. The most common clinical presentation, it's airway obstruction, hearing pain, progressive enlarged painless local mass, dysphagia, sensation of a foreign body in the throat, which are all non-specific for any type of malignancy. One of the lesions that can occur in this area is the EBV positive mucocutaneous ulcer in immune-compromised patient. As we said, diffuse large B-cell lymphoma is the most common primary. And we can have other lymphomas like MALT, T-cell lymphoma, follicular, and maybe Hodgkin. EBV positive mucocutaneous ulcer is a lymphoproliferative disorder composed of polymorphous lymphoid infiltrate, has atypical large EBV positive B cells with RS-like cells. It's usually affecting the mucosal and cutaneous sites and come in a patient with immune deficiency or dysregulation. It's monoclonal B cells and may show TR gene rearrangement, so it's not helpful to differentiate this lesion from lymphomas. Majority of these cases regress spontaneously and respond very well to withdrawal of immune suppression. I put this lesion because there is a high incidence in our patient, and we have cases with multiple relapses. And personally, I have a case with mucocutaneous ulcer who developed splenic lesion. So the time will tell if these lesions are still disorder or they're full-blown lymphoma. This is a histological figure of the atypical proliferation with large cells positive for CD30 and EBV-ish. Extranodal NKT cell lymphoma, nasal type. I put this lymphoma here because it may involve the oropharynx. It's common in the Asian area, and it has a very strong relationship with the EBV. They have a recurrent mutation that include JAK-STAT pathway, also the epigenetic regulators, and in tumor suppressor genes and the RNA helicase. This is a figure showing that the most common mutation happened in the epigenetic modifiers and in the JAK-STAT pathway. Very characteristic under the microscope that we see coagulative necrosis in this lymphoma with angiodestructive features. It's positive for T-cell lineage with the CD56 positivity. CD30 is positive in half of the cases with EBV-ish and cytotoxic phenotype. Going to the esophagus, esophageal lymphoma, it's very rare to be a primary esophagus lymphoma. However, the involvement usually secondary due to metastasis from cervical, mediastinal lymph node, or an extension of gastric lymphoma. Majority of these cases are diffuse large B-cell lymphoma with few of MALT and mantle. The common symptoms is non-specific. It's symptoms of any kind of malignancy like dysphagia, odynophagia, weight loss, chest pain. Complication can happen as upper GI hemorrhage and obstruction or even perforation. This is a very unique case in 22 that reported a 60-year-old man presented with odynophagia, turned out to have a primary Hodgkin lymphoma in the esophagus. The classic Hodgkin lymphoma, as we know, it's derived from germinal center B cells. It's a disease of a lymph node, extranodal involvement, usually stage 4 disease. And it includes the lung, bone, liver, and bone. GI tract involvement is very rare. In this situation, we have to consider underlying immune deficiency. Classic case for Hodgkin lymphoma with RS cells, positive for CD30. Moving to stomach, gastric lymphoma. Stomach is the most common involved site by lymphomas, and H. pylori is the most important risk factor in developing MALT and diffuse large B-cell lymphoma. Some patients have positive hepatitis surface antigen, and they develop also B-cell type lymphoma. Primary gastric lymphoma of T-cell phenotype is very rare. Usually it's a part of adult T-cell leukemia, so it's secondary involvement. The age is over 50 with male predilection. The clinical symptoms, the same, it's non-specific gastric or abdominal symptoms, which can be shared with other malignancies. We have nausea, vomiting, epigastric pain. Also, the endoscopy is non-specific for gastric lymphoma. Lymphoma can be ulcerated, can show diffuse infiltrate, or even a polypoidal mass. The extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue, as we said, it's associated with underlying chronic inflammatory disorder, which is the H. pylori. The lymphoma cell growth clinically depends on the H. pylori-mediated T cells that activate the nuclear factor kappa B pathway. The translocation of 11-18 is seen more frequently in stomach. Characteristically, we can see that there is a diffuse infiltrate of B cells in the lamina propria with the lymphoepithelial lesion. Cells have monocytoid appearance. They are positive for B cell immunostains, negative for CD10, CD5, and cyclin D1. The large cell transformation of MALT should have large cell morphology, high Ki67, and loss of the follicular dendritic meshwork in the background. Next, we have the diffuse large B-cell lymphoma. I will talk about the NOS, which is a heterogeneous type, including many morphological variants like centroblastic, immunoblastic, anablastic, or cell origin like germinal center activated B-cell subtype. And recently we have the MEK and BCL6 rearrangement. These are all figures of diffuse large B-cell lymphoma. Here they are maybe more monotonous. Here we have some large and bigger cells with more apoptosis. Here they are bizarre, ugly looking, and with abnormal mitosis. The main etiology of diffuse large B-cell lymphoma is unknown, but risk factor can be due to viral immune dysregulation, environmental, or occupation exposure. They can arise de novo, but we also have to pay attention that it can be arising from indolent B-cell lymphoma. Isolated MEK rearrangement in diffuse large B-cell lymphoma reported, even the double, and all considered as diffuse large B-cell lymphoma NOS. So no more double hits between the BCL6 and MEK rearrangement. The cell of origin, as we know from many studies, that ABC diffuse large B-cell lymphoma has an inferior prognosis regarding the GCP. And cases with the most definite CEO cells by gene expression profiling are associated with the strongest survival differences. However, the CEO classification sometimes is disappointing because it's lacks the impact of predictive marker in targeted approach for in many clinical trials, especially when it's directed to the ABC type. Gene rearrangement, we have the effect of MYC rearrangement, and it has an inferior survival rate if it's arranged to the IgG partner. T53 also mutation has a poor outcome. In cases of MYC rearrangement, involvement of non-IgG genes also been documented, but it needs more investigation to know the outcome for these cases. BCL2 rearrangement in diffuse large B-cell lymphoma may indicate that this lymphoma has been transformed from follicular lymphoma. Increase the copy number of MYC may seen in 20% of cases with diffuse large B-cell lymphoma NOS. Still, there is no very clear impact on these cases, and it need more work out. Other protein expression that may have effect on the prognosis, like CD5, which link to an adverse prognosis. The dual expression of BCL2 and MYC in cases of diffuse large B-cell lymphoma without the rearrangement also has an adverse prognosis. Increased CD30 expression and strong B53 expression also may play a role in the outcome due to the targeted therapy. Moving to the small intestine lymphoma, it's a very rare malignancy, account for less than 2% of all gastrointestinal malignancy. The most common site is the ileum, followed by the jejunum, then the duodenum. Clinical presentation is not specific. Patient may have a colic pain, nausea, vomiting. Some patients reach the hospital due to perforation of the intestine. The small intestine lymphoma, it's heterogeneous than the other side of GI tract. They have T cell, B cell with different features. We have MALT-associated lymphoma due to the C. jejuni infection. We have mantle cell lymphoma as a part of multiple lymphomatous polyposis, and Burkitt lymphoma as a bulky mass in the lower quadrant in the ileocecal valve. Duodenal type follicular lymphoma, it's a specialized lymphoma in a special site, which is the second part of the duodenum. Patients are found incidentally while doing endoscopy. It may be harbor the 14, 18 translocation and the CREB-B like the systemic follicular lymphoma. The lymphoid infiltrate usually of follicular pattern. They have centrocytes, centroblast, similar to systemic follicular lymphoma. The tumor cells usually invade the villi, producing a feature called gloved balloons sign. The phenotype is similar as the systemic follicular lymphoma. But other characteristic feature that we can see a hollow meshwork of the FDCs that being pushed in the periphery of the follicles instead of the intact one in follicular lymphoma. The prognosis is very excellent for this patient, and the preferred approach is watch and wait. This is endoscopic pictures showing the tiny polyps or nodule in the duodenum, and there is a follicular infiltrate with the ballooning of villi, positive for CD20. Multiple lymphomatous polyposis is a part of mantle cell lymphoma that appear in the gastrointestinal tract. Some reported mentioned that follicular lymphoma and MALT can have the same presentation. Mantle cell lymphoma, as we know, it's a mature B-cell lymphoma derived from the mantle zone. has a CD5, SOX11, and cycling D1 positivity with rearrangement in cycling D1 or BCL1. Endoscopic features showing multiple polyps looks like familial polyposis syndrome or Potts-Jeker syndrome. Under the microscope, we see a very dense lymphoid infiltrate. The enteropathy-associated T-cell lymphoma, the ETL. This lymphoma, it's an aggressive primary intestinal T-cell lymphoma of the intraepithelial lymphocytes. Exhibit a very cellular polymorphism starting from small to medium to even bizarre-looking cells. Individuals are usually have celiac disease. This lymphoma can be disseminated into surrounding lymph nodes, and patient will have a feature of malabsorption, weight loss, and a lot of patients come to the ER due to perforation. Patients with celiac disease need to be assessed for refractory celiac disease. If the patient is following a gluten-free diet with a period of 6 to 12 months and there is no response, still have malabsorption symptoms and the villus atrophy with increased intraepithelial lymphocyte, we need to assess if the patient in category 1 or category 2 of refractory celiac disease. So in RCD1, the majority of intraepithelial lymphocytes, they have TCR alpha beta lineage and expression of the surface cyto CD3 and CD8, which is normal. And usually it is a polyclonal population. The development of ETL in these cases is very low, around 3 to 14%. In the type 2, the intraepithelial lymphocyte usually express the cytoplasmic CD3 and sometimes NK antigens, and they lack the surface CD3 and CD8. If you test for the TR gene rearrangement, it may be monoclonal. Patient may have increased morbidity and mortality rate during the 5 years of survival, and it has a high intensity to transform into ETL. As we mentioned, the morphology, it's usually polymorphic. They can be small, medium, or even very big, large cells. The most important feature for the immunophenotypic profile is the double negativity of CD4 and CD8 with a negativity of 56. Cytotoxic granules, they all expressed in this lymphoma with a high Ki67, around or more than 50%. The monomorphic epitheliotropic intestinal T-cell lymphoma, the METL, it's another aggressive form of primary intestinal T-cell lymphoma of intraepithelial T lymphocytes. It's a monomorphic in morphology with epitheliotropism, lacking association with the celiac disease. It can disseminate it to other sites like lymph node or lung, liver, brain, and skin. It can appear as a big, large ulcerated mass, but most of the patients, they come with perforation. The size of the cell is small to medium. And the characteristic feature here of immunophenotype is CD4 negative, CD8 positive, CD56 is positive. The same thing, Ki67 is very high in these cases. Sometimes if we have difficult cases to differentiate between METL and ETL, they said JAK3 and STAT5 is more mutated in ETL lymphomas. The indolent T-cell lymphoma of the gastrointestinal tract, this is a clonal T-cell proliferation characterized by infiltration of the lamina propria with lacking epitheliotropism. The same thing, we don't have any specific symptoms. Patient may have, the cells may have positive double CD4 and CD8 or negative double CD4, CD8. The characteristic feature here is that Ki67 is less than 10%. That's why we call it indolent. Detection of clonal TCR rearrangement can be done by the PCR and differentiated from the inflammatory bowel disease. This is a feature of the indolent T-cell lymphoma, and it's sparing the surface epithelium. In WHO 2022, they changed the name from indolent T-cell lymphoproliferative disorder to the lymphoma, because this lymphoma, although it's a low grade, they can disseminate. Intestinal T-cell lymphoma, this is our waste basket when we don't know where we're gonna put our lymphoma. Is it ethyl, methyl, or the indolent type? But usually they're aggressive T-cell lymphoma, but we don't really know where we're gonna put it, so you can use this waste basket. Moving to the colon, the colorectal lymphoma constitutes 6 to 12% of gastrointestinal lymphoma. Usually it's a secondary involvement. The same thing, the disease has non-specific features with the other cancers, and it has male predominant affection. I don't know why they like males. Burkitt lymphoma likes to present as a celiac mass. It's a mature aggressive B-cell lymphoma of medium-sized cells, germinal center origin, has translocation of 18 between the IG and MYC. There are 3 subtypes of Burkitt lymphoma: the endemic, non-endemic, and the immunodeficiency associated. Risk factor for endemic including the Plasmodium falciparum and the EBV infection. This is a very classical picture for Burkitt lymphoma with the star sky appearance. Usually it has more than 95% of Ki67. So in conclusion, it has been a tremendous leap in the pathological diagnosis, staging, and management of gastrointestinal lymphoma in the last 2 decades. It's better to have an insight of the etiology for these diseases, so we can get more benefit for the patient. Accurate diagnosis and staging of gastrointestinal lymphoma is very important because there are a heterogeneous group of malignancy. Thank you so much.
Thanks to you, Dr. Lena. A very informative presentation. Now we can have questions we can have 5 minutes question. If anyone has any comment or question, please.
At the end.
Yeah.
Assalamu alaikum. So it's very informative and updated information about the GI lymphoma. We appreciate that. So I have a question regarding mostly about the diagnosis line rather than about information for refractory celiac disease.
I cannot hear very well.
Oh, sorry.
Can you raise your voice a little bit?
So can you hear me right now?
Okay.
Okay. Sorry about that. So regarding the refractory celiac disease, how are you going to put it in the diagnosis line? Are you going to put it like in the diagnosis, or are you going to comment and give them all this information? And what the best way to phrase it in the diagnosis line? I would appreciate that.
Sorry.
Can you hear me right now? Can you hear me? Yes. So for cases with refractory celiac disease, so what the best way to put it in the diagnosis line? Are you going to mention the diagnosis line, or are you going to put it in the comment? And
For the refractory celiac disease, you can mention in the comment about the refractory celiac disease, but if you have a doubt of this one, I think it's better to send the case for TCR rearrangement just to have a monoclonal first infiltrate of T cells, then you can be definite. So you can call it in the diagnosis refractory celiac disease type 2, and you explain what it's done for this biopsy. But if you have the doubt and you don't have the facility to do it, just you have to mention in the comment, so the patient will be followed up closely. Because most of the patients, they end up by perforation. So we need to avoid this.
Any other questions or comments? So, Dr. Lina, regarding the molecular part of the diagnosis, how you find it, or if you want to give a comment about this, is it how the weight you give for this part in the diagnosis in your center?
For molecular part, usually, if we have a typical presentation for any type of lymphoma that I have been mentioned, so sometimes we don't go through molecular. But if you have a very rare cases like duodenal follicular lymphoma, so it's worth it to send it for molecular to prove that I really have rearrangement that is follicular and it's found only in or solely in the duodenum.
Nice, nice. So if no further questions or comments, we can proceed to the next session. And thank you so much, Dr. Lina. Thank you. So our next talk will be presented by Dr. Fadel Al-Ataibi. Dr. Fadel completed the Saudi Board of Anatomic Pathology in 2016. And in 2020, he did a one-year lymphoma pathology fellowship training in MD Anderson Cancer Center, Houston, Texas. And from 2021 to 2023, he worked as consultant lymphoma pathologist at Prince Sultan Military Medical City. He is currently working as consultant lymphoma pathologist at Security Forces Hospital program in Riyadh. Welcome, Dr. Fadel, and the floor is yours.
First of all, Assalamu alaikum. I would like to thank Dr. Saeed and the organizing committee for inviting me to present this talk. I hope it will be short and informative talk. Pediatric lymphomas, it's as we know, it's one of the most common types of lymphomas or tumors in the children. It is the third most common tumor after CNS tumors and after leukemias. And it represents around 15% of the pediatric tumors. In the United States, there is around 2,000 cases of kids that are diagnosed first time for lymphoma every year. And I consider lymphoma and leukemias are one of the biggest achievements in the cancer treatment in recent years. 4 or 5 decades ago, these neoplasms were fatal. Those kids will be, it's like a death certificate when you call patient or you diagnose a child with Burkitt lymphoma or classic Hodgkin lymphoma. Nowadays, most of these children are cured from their diseases. The cure rate reached now 85% in these cases. This graph shows you the incidence rate in relation to the age in the United States. And as you see, in the less than 5 years or less than 4 years of age, Burkitt lymphoma is the most common neoplasm in this age group. And generally, lymphomas in this age is not common in comparison to the slightly older kids. Between 5 and 19 years, the classic Hodgkin or Hodgkin lymphoma in general, they take the lead as the most common lymphomas on these ages. Usually, they are followed by diffuse large B-cell lymphoma and anaplastic large cell lymphoma. These Burkitt lymphoma, Hodgkin lymphoma, and anaplastic large B-cell lymphoma, they were already you already heard about them during this course. So I will talk about the rarer entities, these new entities who have been recently described in the WHO. These entities may present a diagnostic challenge for the pathologist, especially those who are not familiar with them. So I will provide a quick overview of these entities. I will rely mainly on the WHO 5th edition. As you know, there is two classifications now for lymphomas, the WHO classification and the international consensus classification. In lymphoid neoplasms, the difference, according to some studies, affect just less than 1% of the cases. So there is no need to confuse you about these two classification. I will adhere with the WHO, which is I used it daily in my daily practice. So the first entity, it is the pediatric follicular lymphoma. Pediatric follicular lymphoma is a localized mature B-cell lymphoma that occur primarily in pediatric age patients, usually from 8 to 36 years of age. The median age is 18 years. Some reports reported these cases in older age group. However, they are very rare in older age groups. It is characterized by the absence of the defining molecular features that we usually see them in the classic follicular lymphoma, which are the BCL2 and BCL6. Also, there are the other molecular signature, the IR4 gene rearrangement, which is defining another rare entity, which we will come to it later. These entities are absent in these groups. Almost all cases of pediatric lymphoma present as a limited stage peripheral disease, usually involving one lymph node or a single lymph node group. Mostly these lymph nodes are located in the head and neck region. There is case reports of inguinal, femoral, and axillary lymph nodes reported. There is no intra-abdominal lymph nodes so far being reported in the literature. Extranodal presentation is excluded by definition. You don't, if you have any extranodal case, according to the WHO criteria, you don't call it pediatric type follicular lymphoma, although some case reports in the literature have been describing pediatric T-cell lymphoma in extranodal sites. Generally, pediatric T-cell, pediatric type follicular lymphoma, usually they have excellent outcome. The survival rates almost reach 100%. And the usual treatment is conservative in those children. They just excise the enlarged lymph node, and they put the patient on a watch and a wait scheme of management. The histological presentation of the pediatric type follicular lymphoma, it usually comes as exclusively follicular pattern of growth. These follicles usually grow in serpingeous or floral enlarged back-to-back follicles, and they usually involve part of the lymph node. As we see here, this is normal lymph node. This is the neoplastic lymph node. This appearance has been described as node-in-node appearance. When we examine these cases on higher power, we see the germinal centers lack the normal zonation. We see it in the follicular hyperplasia. Usually they have monotonous proliferation.
And they usually have a lot of macrophages, tangible body macrophages giving the starry sky appearance, sometimes mimicking the Burkitt lymphoma, especially in true-cut biopsies. And the mantle zone area is usually attenuated or absent in these cases. On cytological level, usually the infiltrate contains composed of medium-sized blastoid-looking cells with no features of centrocytes or centroblastic morphology. In immunohistochemistry, these cases usually have BAM-B cell markers positive. I put here two micrographs, one for classic follicular lymphoma in the upper photos, and the lower photos are the pediatric type follicular lymphoma for comparison. So this is CD20 in the pediatric follicular lymphoma. It is positive. And the germinal center markers, the BCL6 and CD10 generally are strongly positive. This is the BCL6, sorry, this one. This is the follicular lymphoma, which is also positive, the classical one. The CD21 and CD23 usually highlights the follicular dendritic meshwork, which is preserved in these types of tumors. BCL2 is negative. This is one of the important immunophenotypical differences between pediatric type follicular lymphoma and classic follicular lymphoma. This is the BCL2. We see here it's negative within the germinal center. However, in the classic follicular lymphoma, the BCL2 is expressed in the germinal center. Another difference is the Ki67 proliferation index. We see here the classic follicular lymphoma, usually they have low Ki67 except for higher grades. However, in the pediatric type follicular lymphoma, Ki67 is very high. The IRF4 is typically negative. This is important as in the differential diagnosis. There is a new marker have been described in recent literature to differentiate between pediatric type follicular lymphoma and follicular hyperplasia. It is the FOXP1 immunostaining. This is usually nicely positive, show nice nuclear positivity in the pediatric type follicular lymphoma with complete negativity in the in the florid hyperplasia. The most important differential diagnosis for pediatric type follicular lymphoma is the florid reactive follicular hyperplasia. The most important differentiation relies in first the preservation of the architecture. You will find the preserved sinuses, preserved mantle zone, and the germinal center will show nice polarization. If you did molecular staining, you will see that the reactive follicular hyperplasia are polyclonal. However, the pediatric type follicular lymphoma is a monoclonal disease. The FOXP1, if you have it, is very helpful in this differential diagnosis. Follicular lymphoma is mostly older, comes in older age group. It's usually present with higher stage 3 or stage 4 multi-systemic disease. It's usually present with B symptoms, so clinically they are different in the clinical presentation. BCL2 is by default is positive, except in the higher grading follicular lymphoma. And the most important thing is the presence of the BCL2 and BCL6 G rearrangements in the follicular lymphomas. The other differential is large B-cell lymphoma. I will skip it until we will, until next slides. I will talk about this one in more details. The next in the differential diagnosis is the pediatric nodal marginal zone lymphoma. This is a new subtypes in the recent WHO classification, and probably it will not last till the next classification. Pediatric nodal marginal zone lymphoma is a primary nodal disease and usually presents in the head and neck region for mostly in adolescent boys. It has almost 20-to-1 male to female ratio. Although it shares some features with the nodal marginal zone lymphoma, it has different clinical and histomorphological features, which made the WHO team to put it in a different subtype. Pediatric nodal marginal zone lymphoma usually present as a stage 1 or stage 2 disease, mainly affecting the head and neck region. Splenic and extranodal zone lymphoma in children are rare, and when they have it, it is not within the, you shouldn't put them under the pediatric nodal marginal zone lymphoma group. And it's usually lack the multi-gene rearrangement, which commonly we see it in the extranodal marginal zone lymphomas. Most patients with pediatric nodal marginal zone lymphoma, they treated conservatively with excision of the enlarged lymph node and they put under watchful waiting for the and usually they don't recur after that. At low power, the pediatric nodal marginal zone lymphoma present with enlarged follicles, and these follicles usually have expanded marginal zone area, and this marginal zone area extend into the interfollicular area. This marginal zone we can recognize it from low power by being a pale area, as in this here it's usually in low power became like a pale area because it has abundant clear cytoplasm. There is also what we call it BTGC-like features as the mantle zones start infiltrating the germinal center. The sinuses are generally attenuated or obliterated. On high power, we can see the neoplasm is mostly composed of polymorphic medium to small lymphocytes with monocytoid appearance. We mean by monocytoid, it is the cells which have abundant clear cytoplasm and rounded nuclei. Generally, these neoplasm have a lot of blast cells, either centroblasts or plasmacytoid, plasmablastic looking cells. It's more frequent in the pediatric type more than the classic marginal zone lymphomas. In the immunophenotype, generally the tumor is positive for CD20 and other BAM-B cell markers. The BCL2 is positive and CD43 is expressed in most of the cases. This is a big difference between the pediatric type and the classic marginal zone lymphoma. You know, in classic marginal zone lymphoma, nodal marginal zone lymphoma, CD43 is generally expressed in few cases. This is the immunostaining for IgD. We can see the mantle zone cells start infiltrating the germinal center, mimicking the progressive transformation like pattern. However, these mantle zone areas are also obliterated and infiltrated by the marginal zone cells. And this is major difference from the BTGC, progressive transformation disorder. So the differential diagnosis mainly relies in these two entities. The first one is atypical marginal zone hyperplasia, which is a rare polyclonal expansion of the marginal zone. We see it usually in the extranodal sites, in the tonsils, in the GI, and usually doesn't involve the lymph node. However, rare cases of nodal involvement have been reported with Haemophilus influenzae infections. They usually CD43 positive, like the pediatric type marginal zone lymphoma. However, when you do a molecular study, you will see these cases are polyclonal. Pediatric type follicular lymphoma is the other differential diagnosis, especially in the pediatric age group. Usually comes as back-to-back follicles. And as we described, it's more monomorphic. However, the early cases of pediatric type follicular lymphoma, some of them show what they call it marginal zone differentiation. Recent studies try to assess the molecular signature of both pediatric type follicular lymphoma and pediatric nodal marginal zone lymphoma, and they found they have they share most of the molecular signatures. And the recent literature, and now they are talking about, they are two histological manifestations of same disease. The next topic I will talk about is this large B-cell lymphoma with IRF4 gene rearrangement. This one used to be in the WHO 16 as a subtype of follicular lymphoma. In the WHO 22, this one has been shifted from follicular lymphoma to large B-cell lymphoma. It is a rare de novo mature B-cell lymphoma with follicular, diffuse, or mixed growth pattern. And the defining molecular feature for this entity is the IRF4 gene rearrangement. This is the usually present in the translocated with IgG locus. Most cases reported in children and young adults with slight male predominance. Majority of the cases present within the head and neck and cervical lymph nodes. Some case reports has been reported in Bayer batches and in intestinal lymph nodes. Actually, recently I had one case for a 25 years old man who was presented with Bayer batch involvement by this entity. The overall outcome seems to be favorable. Those patients usually treated with the diffuse large B-cell lymphoma protocol, and they respond very well to that protocol. So in histologically, we can see follicular-like growth pattern with some areas of more diffuse architecture. Most of the cases present with combined follicular and diffuse growth pattern. Usually, the follicles are enlarged and rounded, and there is no zonation in the low power. If you go to high power, you will see sheets of centroblast-like cells with sometimes intermixed in some smaller plastic-looking cells. On the immunophenotype, the most important immunophenotype we will see is the strong positivity for MUM1 immunostaining and the strong positivity for BCL6. So if you have diffuse large B-cell lymphoma morphology in young patient, pediatric or young adult, and it shows a strong positivity for BCL6 and MUM1, think of large B-cell lymphoma with IRF gene rearrangement. It is also shows CD10 expression. Sometimes The CD5 is expressed in around 30% of the cases, and Ki67 usually is high in those patients. So the diagnostic molecular pathology for these cases is the presence of the IRF gene rearrangement, which usually with the IGH locus. However, it's be reported with the IG kappa and IG lambda. And BCL2 and MICG rearrangement usually doesn't appear in those patients. The main differential diagnosis is the pediatric type follicular lymphoma, and this is important differential because pediatric type follicular lymphoma is usually treated conservatively, not like the large B-cell lymphoma with IRF gene rearrangement. The most important thing is pediatric type follicular lymphoma is purely follicular pattern. It doesn't have any diffuse component. It's usually blastoid cells, not like the large B-cell lymphoma with IRF rearrangement, which have centroplastic looking cells, usually have status chi pattern. BCL2 is negative, and MOM1 is by default is negative. And if you did the molecular staining, molecular testing, you will see the IRF gene rearrangement is absent in the pediatric type follicular lymphoma. The other differential diagnosis is the diffuse large B-cell lymphoma. Those patients usually comes as in older age, advanced stage disease, and diffuse growth pattern. B-cell lymphoma, this is the new term for follicular grade 3B. This is in the most recent WHO. Also similar to the diffuse large B-cell lymphoma, usually it is a disease of elderly people, and usually they lost the BCL6 in the higher grade follicular lymphoma, and the BCL2 is a variable in those patients, but the IRF4 is negative. The next topic is the high-grade B-cell lymphoma with 11q operation. This one joined the WHO in 2016 as Burkitt-like lymphoma with 11q operation. In the recent WHO, it has been the Burkitt-like has been removed and replaced with high-grade B-cell lymphoma. It is rare, aggressive, mature B-cell neoplasm with Burkitt-like morphology and typical Burkitt-like immunophenotype. The defining genetic event in this tumor is the operation involving the long arm of the chromosome 11 in the absence of MEC translocation. Most cases have been reported so far in children and adolescents and mostly present as a nodal disease. Burkitt lymphoma usually extranodal disease, but this entity mostly comes as a nodal disease. There is some cases reported extranodally in the head and neck region and in the gastrointestinal tract. This is the histomorphology. It is exactly almost similar to the Burkitt lymphoma. Usually have sheets of intermediate blastoid-looking cells with starry sky appearance, mimicking Burkitt lymphoma. The cells usually have dense nuclear chromatin and multiple nucleoli. Compared to Burkitt lymphoma, the high-grade B-cell lymphoma with 11q operation shows more cellular polymorphism and variation in nuclear size. Sometimes they have enlarged nucleoli. The immune profile is exactly the same as Burkitt lymphoma. Usually they are CD10 positive, they are BCL2 negative, and they have almost 100% Ki67 proliferation. Sometimes they have MEC expression, but when it is there, it is variable. As we learned from Dr. Bakhshi this morning, MEC immunostaining doesn't correlate very well with the MEC rearrangement. Some cases they will have CD56 expression, and the EBAR is negative in these cases. And this is important differentiation. Sometimes by flow cytometry, the high-grade B-cell lymphoma with 11q operation, they have apparent phenotypes. Sometimes they present with CD16 or CD56 immunostaining. Sometimes they have expression of the CD8, which is a well-known T-cell marker in these cases. And they usually have the absence of the strong CD30. CD30 strong expression is a defining or a common finding in Burkitt lymphoma. So if you have a case which has Burkitt lymphoma like morphology, but it shows these apparent expression by flow cytometry, think of this entity. The defining molecular, as we mentioned, is complex operation involving the 11q chromosome, and this includes many changes. The best testing to detect these numerous operations is the next generation sequencing, because the commonly used FISH analysis cannot detect loss of heterozygosity in 11q gene. So this is the most important differential. Burkitt lymphoma, it is by default is the most important differential in this entity. Usually when you have a Burkitt-like tumor, but doesn't have the perfect immunostaining or perfect morphology, think of high-grade B-cell lymphoma with 11q operation. If you have more polymorphism, if you have weak MYC expression by immunostaining, or you have apparent flow cytometry, or you send it for MYC rearrangement and it came negative, then send it for 11q operations. The other differential is the high-grade B-cell lymphoma, either double hit or not otherwise specified. These entities are commonly present in older age groups. They have more polymorphism, and they have variable immunostaining. Sometimes it's difficult to differentiate them based on histology and histological and immunophenotypic features, and you need to send them for molecular gene rearrangement. Diffuse large B-cell lymphoma is by morphology, it has different centroplastic and polymorphic morphology. The immunophenotype sometimes can be overlapping. There is some cases of diffuse large B-cell lymphoma reported with the 11q operations. According to the WHO, it's considered this as unclear, but most recent literature describe these are just part of the diffuse large B-cell lymphoma and should not be included in the high-grade B-cell lymphoma with high-grade B-cell lymphoma with 11q operations. The last category which I will talk about it is the systemic EBV positive T-cell lymphoma of childhood. This is an extremely rare disease. It's put under the umbrella of EBV positive lymphoproliferative disorder of childhood. Most of the other entities present with cutaneous manifestation. However, this one can present with lymph node involvement. It is a rare disease reported mainly in Asia. The first description was in Japan, later on described in other Asian countries and Central America and South America. It is clonal proliferation of EBV infected T cells that usually infect immunocompetent children, and it has a rapidly fatal course. The systemic EBV T-cell lymphoma of childhood has two clinical presentations. The common clinical presentation is an active, severe active EBV infection that is transformed to lymphoma, usually previously healthy child with immunocompetent immune system, present with infectious mononucleosis like clinical presentation. Few weeks later on, the patient develop hepatosplenomegaly, liver failure, sometimes lymphadenopathy, skin rash. The the laboratory testing usually show pancytopenia, abnormal liver function test, high EBV viral loads, and importantly, they usually have low or absent anti-VCA IgM, which is a serological test for acute EBV infection. Although those patients usually present as acute presentation, they have absent IgM antibodies. And those patients usually complicated by HLH, coagulopathy, multi-organ failures, and eventually death within days or weeks. The other pathway, the uncommon pathway, is secondary progression of systemic chronic active EBV infection. When it's involved the lymph node, usually it's present as it's distort the architecture of the lymph nodes with pale areas of atypical T lymphocytes, usually have polymorphic morphology, and mainly expand the follicular area. The normal B cells usually are depleted in those patients. Sometimes you will have extensive sinus histiocytosis with erythrophagocytosis. This represents the HLH component in this disease. The liver and the spleen usually are involved in those patients. In the liver, you will have prominent portal and sinusoidal lymphoid infiltration. In the spleen, usually the neoplasm involve the sinuses, and you will see usually hypocellular infiltration involving the splenic sinuses with atrophy of the white pulp. Immunophenotypically, usually these cases present with T cell markers. The CD2 is usually positive and bright. CD3 is usually weak. In those cases, CD56 is negative. Other T cell markers usually show apparent loss, the most common being CD5 and CD7. The cytotoxic markers like the TIA usually positive. In the common clinical presentation, which present as acute primary EBV infection, the case is usually CD8 positive. However, if it is present as progression of systemic chronic active EBV infection, usually they are CD4 positive. Sometimes they have dual positivity for CD4 and CD8. EBER is always positive in these atypical T lymphocytes. The most important differential diagnosis for these cases is the systemic chronic active EBV infection. Those cases usually present as protracted disease with long duration of the symptoms. By definition is more than 3 months. You'll have the positive EBV infection as with the lymphoma. Most commonly, it involves the spleen, liver, and bone marrow. But it is the most important thing is the long protracted course and the lack of cytological atypia in those patients. The other important differential diagnosis is EBV positive HLH. This one is very difficult in the differential diagnosis to differentiate from systemic EBV positive lymphoma of childhood, especially in early presentation, as both they have similar morphology in early stages, but usually EBV HLH lack the monoclonality of TCRG rearrangement. Sometimes some cases reported to be monoclonal, and this is very difficult really. The new entity in the WHO, it's called EBV positive nodal T NK cell lymphoma. This is exclusively an adult disease. So if you have pediatric patient, you call it systemic EBV positive T cell lymphoma of childhood. If you have adult patient, you call it EBV positive nodal T cell lymphoma. And for the slide, I conclude my presentation. Do you have any questions?
Thank you so much, Dr. Fadil, for this informative talk and nice elaboration of the WHO updates. If anyone has any comments or questions, please. Yeah, so if no questions or comments, thank you so much. And we can move to the break for 15 minutes. We will, or 20 minutes. We will be back at 3:20 or 3:25, inshallah. Thank you so much.
السلام عليكم ورحمة الله.
وعليكم السلام.
بداية أشكر الأورجنايزنج كوميتي ممثلا بالدكتور سعيد شيبان، وكذلك جمعية SSMB تنظيم هذا المؤتمر المهم، وعلى رأسهم الدكتور أحمد العسكر. وحقيقة سعيدين نشوفكم في المدينة يعني، وهذه فرصة يعني نقدر الجمعية لتنظيمها في المدينة، فشكرا لكم وشكرا للحضور. طبعا this is the third session. It is the last but not the least important session. We'll have two lecture. We'll have two lecture. The first one is Epstein-Barr virus associated lymphoproliferative disease. Will be presented by Dr. Shamail. The next one will be presented by Dr. Ghalib Al-Yamani. It is about another lymphoproliferative disease, which is Castleman disorder. It's my honor and pleasure to introduce Dr. Shamail. حقيقة معروف لا يعرف. Dr. Shamail, consultant histopathology, head section of histopathology in King Faisal Specialist Hospital in Riyadh. She has a fellowship in lymphoma and lung pathology in Canada. Dr. Shamail, you can start, please.
Thank you very much for the introduction, and assalamu alaikum. Good afternoon, Medina. It's truly an honor and privilege to be here as we close this remarkable conference with the last session of the day. My dear colleague, Dr. Yamani, and I will be exploring with you the fascinating world of HHV8 and EBV, the most oncogenic viruses known to mankind. This topic is very near and dear to me. I dedicate it to one of my patients who I saw in the very early stages of my career, and I got to follow her disease evolution till the end. So as we begin, who recognizes these two gentlemen? You can shout out the names if you do. Anybody? Well, yes. So you probably know that the Epstein-Barr virus was named after Sir Anthony Epstein when he discovered the virus particles in the Burkitt lymphoma. However, have you ever wondered who is the Barr in the Epstein-Barr virus? Well, as legend has it that Dennis Burkitt was a British military surgeon and he was posted in Uganda. During his post in Uganda, he encountered Ugandan children with massively swollen jaws, a condition that will later on be called Burkitt lymphoma. He presented his findings in a conference in London, which would be attended by Sir Anthony Epstein by pure serendipity. Epstein's curiosity was piqued when with the geographic specificity of the disease, and he proposed that this might be due to a virus that is transmitted through mosquitoes. This set a stage for a collaboration where Dennis Burkitt will send biopsy specimens and send it all the way to Epstein's lab in London. So in London, now Epstein hired a research assistant who is an Irish scientist with a background in zoology. This research assistant was successful in cultivating tumor cells in cell cultures. And according to Epstein's notes that in a snowy day in February 1964, he was able to identify virus particles using an electron microscope that Barr had cultured. The Barr belongs to Yvonne Barr, the research assistant who retired as a school teacher after leaving the medical field due to gender discrimination. But she left behind her a legacy that is immortal, just as immortal her immortal cultured lymphoblasts. So why is EBV important and why should we care? EBV is one of the most growth transforming and the most widely distributed human pathogen in the world. 95% of us will be infected by it, and 95% of your patients will be infected by it. So to make the best of our session today, we are going to discuss these disease entities with the main goal being, I'll give you a background of virology of the EBV. Now that we have the schism in the classification of the WHO 5th edition and the ICC, we'll touch on the main updates and giving you some highlights in the biological insights to show you what are the new trends and where are we really heading. So the EBV belongs to a group of gamma herpes virus 4. It was one of the first viruses to be identified by the WHO to cause cancer and is considered as class 1 carcinogen. Most of the people infected by the virus will be asymptomatic and will be hosts or carriers for the virus for life. Depending on the time of infection, the severity of the reaction, the patient might develop a self-limited bout of infectious mononucleosis. The virus particle itself is a spherical particle with an envelope and glycoproteins on the surface. The nuclear genome is a double-stranded DNA enclosed in a nuclear capsid. When these viruses attacks the B cell, it attaches to the B cell and incorporates the DNA within the nucleus in circular forms. It expresses certain surface glycoproteins and certain nuclear proteins. The surface proteins being LMP1, which activates the NF-kappa B signaling pathway, and LMP2, which is an analog for B cell receptors. The EBV infection can be divided into 3 main stages: the primary infection or the lytic replication, the latency phase, and the lytic reactivation. So the virus will enter through the saliva, it's transmitted through the saliva, crosses the mucous membrane, and attaches to the B cell. It will activate an EBNA2 derived B cell replication. Now the naive B cells will enter a latency 3 pattern infection. Here it will express all the EBV gene expressions. From there on, it will move on to differentiate into the germinal center B cells, where now it will enter a latency 2 pattern infection. It loses some of the gene expressions. From there, it will go to the forming memory B cells, which is the latency 0 or the latency 1. And here, this is considered as the resting phase of the EBV. This is where it will stay dormant. From latency 0, now it will go into the circulation as memory B cells, and it can go into lytic reactivation when it transforms into plasma cells. Now, all this is controlled with an intact cytotoxic T cell response. And if you consider the latency 3 as the storm, latency 0, I consider it as the calm before the storm. This is what gives the pathogenicity. This is what gives the cunningness of the virus, because it goes into the host dormant, undercover, hijack the immune system, and it waits for the right time when there is a breach in the immune system where it will take the opportunity and start proliferating without control. Let's look at the latency phases closer. So as we said, there are 3 main latency patterns: latency 3, latency 3, 2, 0, and 1, and they differ with the gene expressions. Latency 3, as we said, expresses all genes. Latency 2 start losing some of the genes, and latency 0 will express only EBER. What gives the oncogenicity of the EBV virus? When the virus particles attach to B cells, they activate signaling pathways, in particular NF-kappa B pathways, JAK-STAT pathways, which are similar to any oncogenic cell stimulating signaling pathways which produce or enhance replication and decrease apoptosis. Also, the EBV stimulates cytokine release such as CXCL10, CXCL19, which gives the milieu of where the virus rests. Now, certain lymphoproliferative disorders that are associated with EBV are correlated with latency patterns. So, for example, Burkitt lymphoma, plasmablastic lymphoma are strongly correlated with latency 1, where only EBER is expressed. Let's take classical Hodgkin lymphoma. It is strongly correlated with latency 2, where LMP1 in addition to EBER is expressed. And last, let's say an immune deficiency related infectious mononucleosis like reaction or a PTLD is associated with a latency 3, where LMP1, EBER, and EBNA will be expressed. You can illustrate this in your laboratory by using some immunohistochemical and some in situ hybridization stains. So again, to reiterate, for example, if you have a latency 3 infectious mononucleosis, you can use stains, EBER, LMP1, EBNA2, all of them will be expressed. Latency 2, for example, polymorphic PTLD, only EBER and LMP1 will be expressed. And latency 1, for example, plasmablastic lymphoma, where it is no longer dependent on the EBV-derived proliferation, this will be only positive for EBER. So now that we have the virology 101 sesh out of the way, let's dive into the EBV lymphoproliferative disorders. So these are a group of disorders that can range from B cells, T cells, NK, and NK cell derived with a wide spectrum of clinical pathological features. They range from indolent, self-limiting, and localized lesions all the way to aggressive lymphomas. You can divide broadly these disorders into two main groups. Those that are associated with immune deficiency, and I'm using here the old classification, and those that are without known diagnosed underlying immune deficiency. Because EBV is strongly related to immune deficiencies, we are going to concentrate on the first group today, and I'll touch upon two of categories from the other group without known immune deficiency disorders, and perhaps if we do a decent job today, maybe Saeed will invite us again for another session and we can discuss the other group in the future, inshallah. So, but if you want to read further about the other disorders, I would like to direct you to this article. You can go ahead and scan the QR code. Scan it. تعبانة فيه وكشخانة عليكم. This article is very nice. It discusses after the ICC classification, the review of non-immune deficiency related EBV disorders. So if you look at now the old WHO classification and the ICC, they divide the immune deficiency related lymphoproliferative disorders into 4 main chapters: PTLD, HIV, primary immune deficiency, and immunogenic, and then the add-on is the immune senescence. So these are heterogeneous lesions, and even though they are heterogeneous, they have some commonalities. The commonalities being frequently involving the extranodal sites, aggressive histology, association with herpes virus, they can present with rapid clinical course, and they can pose difficulty in diagnosis. Even though they are heterogeneous, they present with a similar spectrum of morphological findings, which can range from reactive atypical lymphoproliferative disorder to a polymorphic lymphoid proliferation, and all the way to an overt lymphoma, which can be B cell, T and K cell, or classical Hodgkin lymphoma. Now, despite the overlapping morphological, immunophenotypic, and sometimes biological features, the ICC continues to divide the immune deficiency-related disorders into these main 4 categories, with the argument being the PTLD has a very significant management plan and course and needs to be remain separately. But it disregards that now with the introduction of new modalities, the list is growing and we can't keep on adding new chapters as new modalities causing immune deficiency emerge. So depending on and based on a workshop that was conducted in 2015, conducted by the Society of Hematopathology and European Association of Hematopathology, the WHO 5th edition has taken a nuanced approach to the classification. It has introduced a broader overarching framework with 3-part diagnosis. So they suggest that you should diagnose these cases with a 3-part system. The first being, give it the histological diagnosis that you see. It could be, for example, large B-cell lymphoma. It could be a follicular hyperplasia. The second part mentioned the association with the virus. Is it associated with EBV, HHV8, or negative to both of them? And the third part would be mention the clinical setting in which this disorder is occurring. So the idea for this being that this integrates the entire spectrum of the immune deficiency disorders. And now that we are being faced with and introduced with a lot of other modalities such as CAR T-cell therapy, immune modulation, PD-L1 therapy, or polychemotherapy, for example, solid tumors, and we don't know exactly how these disorders affect the immune system. So it's not only immune deficiency, we need to consider dysregulations that these new modalities are creating. So the new terminology by WHO is immune deficiency dysregulation associated lymphoproliferative disorders. So side to side, if you compare both classifications, you see the WHO 5th edition uses the histological finding as the main criteria for diagnosis, and the ICC uses the clinical setting for diagnosis. However, it has added the last EBV polymorphic lymphoproliferative disorder, acknowledging that some of cases with new immune dysregulations can present with these entities. Regardless to which classification you ascribe to, the bottom line is that I will be honing on throughout the whole lecture is all these clinical entities will present with similar morphological spectrum, ranging from reactive proliferation or atypical lymphoid proliferation to a sort of polymorphic lymphoid proliferation. It's not benign, it's not malignant, somewhere in between, and all the way to a lymphoma. So because post-transplant lymphoproliferative disorders were one of the first entities that were identified to be associated with EBV, and they form a very nice prototype for us to discuss the whole spectrum. We're going to discuss this the first and look at it in greater details. So PTLDs are a group of lymphoid or plasmacytoid proliferation that develop due to immune suppression, secondary to or for recipients in solid organ, bone marrow, or stem cell transplant. Majority of them will be EBV positive. However, the later you go into the history of the disease, you might lose EBV. So King Faisal Hospital, you might know that it is one of the major transplant centers. Our transplant program is quite old, goes back to a couple of decades. And in 2023, we crossed the 1,000 mark for organ transplant. The program consists of liver, intestine, heart, lung, kidney, and pancreas transplants. And you might have heard in the news lately the first robotic heart transplant in the world, as well as now the liver robotic transplant. What this means is that we are continuously being faced with transplant-associated lymphoproliferative disorders, and this has enhanced our experience and understanding of the disease tremendously. So what are some of the risk factors to develop PTLD? The number one would be type of organ transplanted. Some organs have a higher risk than others depending on the severity of immunosuppression that the patient will have. So for example, heart and lung transplant patients have a higher risk of developing PTLDs. So related to it is the amount and the type of immune suppression, viral status. EBV negative recipients from an EBV positive donor will have a higher risk, age, and underlying immune status in general. Let's look at the clinical features and some criteria of the three morphological spectrums of the PTLDs. So if you're using, you can see the terminology for WHO and the terminology for ICC. The non-destructive or the hyperplasia diseases clinically present majority in children, and they will present with tonsil or adenoid masses and in lymph nodes. The polymorphic lymphoproliferative disorders can be extranodal, short time after transplant, and can have an effacement of the nodal architecture. The lymphoma cases will be often late onset disease, and usually they can be nodal or extranodal. Now, treatment, your clinician will opt to use multiple modalities of therapies depending on what you tell them in your histological findings. For example, in the early or non-destructive or the hyperplastic lesions, your oncologist or clinician might try to reduce immunosuppression if possible and close follow-up. In polymorphic lymphoproliferative disorders, reduction of immune suppression, again, if possible, and then maybe rituximab and close follow-up. The monomorphic PTLD now will be treated as any other lymphoma. Of course, immunosuppression will not be in the question at that stage, and you might get away with rituximab only, rituximab with chemotherapy. Histologically, the hyperplastic or non-destructive PTLDs have a normal architecture, and the three histological patterns that you might see is a reactive follicular hyperplasia. You can see a plasmacytosis or plasmacytic proliferation, or an infectious mononucleosis-like reaction, and you will see few EBV positive cells. The polymorphic lymphoproliferative disorder will have an altered architecture. It might be effaced, necrosis is common, and many EBV positive cells. Monomorphic PTLD, you'll have effaced architecture, you'll have a full-blown lymphoma, and you use the criteria for diagnosis of your B, T, and K cell lymphomas. EBV can be positive or negative. And then the clonality for the hyperplastics are polyclonal, and then the others can be monoclonal. So let's share some examples from our files of these entities. Hyperplasia arising in immune deficiency disorder. So this is if you're using the WHO. If you're using the ICC, you'll call it non-destructive PTLD. And the morphology can range from follicular hyperplasia to plasma cell hyperplasia or proliferation to infectious mononucleosis. This is a patient who had heart transplant 2 years ago, and then he developed snoring coring and upper airway obstruction. The tonsillectomy was performed. You can see follicular hyperplasia. So if you look at it without history, you will realize this is just a follicular run-of-the-mill follicular hyperplasia of a lymph node. And if you have the index of suspicion, you perform an EBV stain and it'll show you clusters of EBV. Without EBV, you cannot call this kind of disease as a follicular hyperplasia related to post-transplant, and EBV would be a crucial stain. Now, keep in mind, just scattered EBV is not criteria to call it or bump it to a PTLD, because most of us will have EBV positive cells. You need a substantial amount of EBV, like shown in the two examples here, to call it a non-destructive or follicular hyperplasia EBV positive disease in a setting of, let's say, renal transplant. The other morphology would be plasma cell proliferation, another one of our patients showing you plasma cell proliferation. Kappa lambda show polyclonal. There is no clonality if you're lucky to send for flow or a molecular. So this is another non-destructive type. And the third one is infectious mononucleosis. So here you'll have a spectrum of maturation. You have large cells, small cells, some immunoblasts. You can even have Reed-Sternberg-like cells, and you will have EBER positive and LMP1 positive, such as this boy after post-bone marrow transplant. Let's move on to polymorphic lymphoproliferative disorders if you're using the WHO. So you can use it in any setting of IDD, or a polymorphic PTLD if you're using the ICC classification. These are a group of heterogeneous lesions. You will have a full spectrum of morphological findings. You'll have small cells, large cells, immunoblasts, RS-like cells. So you have a whole spectrum of maturation of lymphoid cells, and it can be monoclonal, oligoclonal, and it's often treated with immune therapy alone or immune therapy with chemotherapy. So this is an example of a patient, 80-year-old boy after a renal transplant, 3 years, so short term, and presented with seizures and found to have brain lesions. So this is a biopsy from the brain showing you effaced architecture, necrosis is quite common. And then the slide on your right shows a spectrum of maturation. You have small cells, large cells, immunoblasts. So there is no monotonous one population of proliferation, and EBV is strongly positive. Let's move on to lymphomas arising in a setting of immune deficiency and disorders, or if you're using the ICC in the setting of PTLD, it will be a monomorphic PTLD. So as we mentioned, these lesions should fill the criteria of your regular diagnostic workup for lymphomas. You can classify them according to your diagnostic criteria for Burkitt lymphoma, B-cell lymphoma, plasmablastic lymphoma, or T cells like, for example, peripheral T-cell lymphomas, classical Hodgkin lymphomas. They often occur late in the transplant, and they can be EBV positive and negative. The later you are in the transplant, the lesser chances of EBV being positive. So as I mentioned, you can have B-cell, your regular B-cell lymphomas, T-cell lymphomas, and classical Hodgkin lymphomas. We used to consider that most of these PTLDs monomorphic are aggressive lesions. However, now reports have emerged that you can have low-grade B-cell lymphomas in the setting of PTLD, but specifically marginal zone lymphomas. So one of the first reports was by the group of Swaldrow and his colleagues, where he reported 4 cases following solid organ transplant. They were mainly extranodal, subcutaneous. They had marked plasmacytic differentiation, so sort of like a polymorphic PTLD. However, they lacked necrosis and they didn't have the latency 2 pattern of infection. This is an example of one of their patients where you see a monocytoid, plasmacytoid appearance of proliferation, EBER is positive, and kappa restricted, lambda negative. So one of the examples of extranodal marginal zone occurring secondary to PTLD. However, later on, more reports started emerging that this extranodal marginal zone EBV positive is not just associated with PTLD. It can be seen also with other immune deficiency disorders, for example, iatrogenic due to methotrexate and rheumatoid arthritis, or immune senescence, or immune deficiency. So they reported cases, for example, this one, you can see nodular proliferation, monocytoid appearance, and then again the same morphological findings of marginal zone lymphoma, but other than PTLD setting. So far, only marginal zone lymphoma is considered the low-grade B-cell lymphoma that you can call in a setting of immune deficiency. Apart from the marginal zone, all of the other lymphomas will be one of your run-of-the-mill aggressive lymphomas. This is an example of a patient post-renal transplant presented with an abdominal extranodal mass. You can see the needle core is infiltrated with sheets of these blastoid, high-grade looking cells intersecting the skeletal muscle, and CD20 positive, Ki67 is almost 99%, MYC positive, so this, and EBV positive. So this is one of the examples of a higher grade B-cell lymphomas in a transplant setting. This is another patient with a lung transplant history 10 years back. Lymph node biopsy showed sheets of large cells, CD3 positive. I'm not going through all the immunohistochemical markers that we did. This is not the intent of the lecture, showing you examples how you can see T-cell lymphomas in the setting of PTLD, and you can see EBER positive. And then this patient was a 9-year-old history of renal transplant and the diagnosis of classical Hodgkin lymphoma or monomorphic PTLD or classical Hodgkin lymphoma, ABV positive in a setting of transplant. The question arises is, are these monomorphic PTLDs similar to your immunocompetent lymphomas? This study emerged from the group from Spain, from Elias Campo, and they studied a group of pediatric monomorphic PTLDs. They had 31 cases ranging from diffuse large B-cell lymphoma and Burkitt lymphomas. They found that their diffuse large B-cell lymphoma monomorphic PTLDs had a low genomic complexity, and their Burkitt lymphoma cases in the setting of PTLD had a mutational profile similar to the immunocompetent patients. Interestingly, these diseases or these lymphomas were treated with a low-dose chemotherapy or a very mild regimen of rituximab with lowering of chemotherapy. So they might be a different basket of worms. Another editorial accompanying the paper mentioned that because some mutations can have a more aggressive course, such as the mutation notch gene and cell cycle gene, that we need to really look into molecular biomarkers required to filter the cases and triage them according to the risk factors. A paper from Mayo looked into the event-free survival and the overall survival for the different lymphomas in PTLD. And you can see here the T-cell lymphomas across the board had a very bad prognosis. Classical Hodgkin lymphomas did very well. And interestingly, look at the red and the green, the polymorphic and the monomorphic PTLDs didn't have much difference in prognosis, which indicates that we really might need to look into them and triage them further and see what's going on in the underlying biology. Management, we've already mentioned, but your oncologist and clinician will have to have work on early detection. Screening is key, especially for patients younger than 1 year old, EBV negative, a transplant, and aggressive immune suppression. And you saw now that how the options might be reduction of immunosuppression alone or adding surgery, for example, the tonsillectomies and adenodectomies, or adding rituximab with chemotherapy. And I refer you to the NCCN guidelines where you can read at your leisure. This is the basic workup that is recommended when you are working up a case for PTLD. And then specifically, they discuss the management of post-transplant lymphoproliferative disorders, just emphasizing the ICC's point of view in keeping them as a separate entity. So you can see the non-destructive type, the polymorphic type, and the monomorphic types. A close condition that is related to the polymorphic PTLD, and Dr. Lina also shed some light on it and showed us some interesting cases, is the EBV positive mucocutaneous ulcers. So these are lesions that occur in patients with age-related or iatrogenic immune suppression, so in an immune senescence setting, or an iatrogenic due to some kind of chronic immunosuppressive therapy. They usually have indolent clinical course, so that's key, and they can have spontaneous regression. So the clinical findings and the clinical history is very important in these disorders. We're usually not very lucky to get the full thickness of the biopsy. If you are lucky, you'll see the cuffing of the lymphoid cells around the ulcer. They commonly occur in the gingival cavity or oral mucosa in an area that there was a prior ulcer. You can see them in the skin, and like Dr. Lina showed us in the GI tract. They have a waxing and waning clinical course, and you have to have a single lesion. If you have this kind of lesion with lymph nodes, then this is no longer a consideration for EBV mucocutaneous ulcer. This is an example of an elderly lady who presented to us through our consult service with a gingival mass. You can see here the non-keratinizing squamous epithelium with the ulceration of the mucosa on top, and there is some kind of infiltrate in the submucosa. A closer view shows you that you have an infiltrate of mixture of large cells, basically, which have vesicular chromatin and a polymorphic lymphoid background. Polymorphic lymphoid background. The immunohistochemical stains is alarming if you see it without a context. This shows you CD20 positive was strongly highlighting the large cells, CD30 positive, and EBV positive. So if you look at it, you'll say, is this a B-cell lymphoma? Is this a EBV positive B-cell lymphoma? Is it a Hodgkin lymphoma with CD20 positive, or is it a gray zone lymphoma? But with the clinical setting, with the waxing and waning, with the isolated lesion in an elderly gingival mass, you can make the diagnosis of EBV mucocutaneous ulcer. Another example here, which I wanted to show you that it can present with really mummified RS-like cells. The pitfall would be Hodgkin lymphoma. This case showed strong CD30 positive. But another tip would be looking at your EBV stain. The EBER stain will not highlight only the Reed-Sternberg-like cells, but if you have large cells and then in the background smaller cells also staining for EBER, then this is most likely not an Hodgkin lymphoma, and this you consider EBV mucocutaneous ulcers. Let's shift gears now. From now on, it'll be smooth sailing. Now you're primed and you know about the spectrum of diseases. We will just hit some important points. The lymphoproliferative disorders associated with HIV can present with a broad age range, usually involve lymph nodes, generalized lymphadenopathy, and typically occurs later after the infection. Again, you can have the spectrum ranging from hyperplasia to polymorphic to monomorphic lymphoid proliferation. An example of a patient who was known HIV presented with lymphadenopathy and showed follicular hyperplasia, nice, prominent, juicy follicles, and some of them are really irregular. We call them serpentine. The CD21 highlights the dumbbell appearance of the follicles. So this is an example of follicular hyperplasia and follicular lysis in HIV setting. The lymphomas now in HIV can be aggressive. They can present with bulky disease, elevated LDH, CNS lymphoma is common. However, it has decreased with heart therapy. If you compare them, the Burkitt lymphomas are one of the few lymphomas in HIV setting that the patient will not be diagnosed with AIDS and can be the presenting symptom. The plasmablastic lymphoma, CNS lymphoma, and primary effusion lymphomas will be extranodal. The CD4 count will be low, associated with EBV, and the PEL will be positive for HHV8. This is an example of a prisoner who presented with abdominal pain and inguinal lymphadenopathy. Biopsy showed this partially effaced nodal architecture with some residual lymphoid follicles and then some atypical follicular proliferation at the side. A portion of the lymph node showed spindle cell proliferation, which was positive for HHV8. So the lymph node had element of Kaposi sarcoma, and then we went back to look at it with to analyze the other lymphoid or follicular proliferation over here. You can see the CD21 highlighting follicular pattern. BCL2 is negative, but one of the areas showed a little bit of partial effacement with enlarged pattern. The proliferation consisted of monotonous, medium-sized, blasty-looking cells with tingible body macrophages, CD20 positive, Ki67 high, and EBER positive. So this was a Burkitt lymphoma with the spectrum of some follicular hyperplasia and Kaposi sarcoma. Our mentors always told us that in a background of HIV, always look for two diseases, don't stop at one. So look at your lymph node very carefully. A kind of advancement in the EBV setting is the association with advancement in the Burkitt lymphoma is the association with EBV. In the old WHO, we used to classify them or subtype them according to epidemiology into sporadic immune deficiency and endemic forms. However, now with the, we know that MYC is one of the most important genetic markers that you see in Burkitt lymphoma. However, the MYC translocation is not pathognomic, it's not specific, and it's not enough to drive oncogenesis. Along with the MYC, you can see ID3, TCF3. So these are other mutations that you see in EBV positive Burkitt lymphoma. However, now we know that EBV negative Burkitt lymphomas are different biologically. They have higher levels of somatic hypermutation, and it was found that they do not carry this TCF3 or ID3 mutations. In fact, it's quite exclusive for EBV positive cases. So depending on this now, the WHO recommends that you divide or you subtype the Burkitt lymphoma according to biological subtypes into EBV positive and EBV negative cases because it might carry implication to therapy.
5 minutes.
The second entity for plasmablastic lymphoma under HIV is plasmablastic lymphoma. These occur in the oral cavity associated with HIV or immune deficiency or in a transplant setting. Now we have reports that they can be secondary to transformation of follicular lymphoma or CLL, SLL, and some reports even secondary to CAR T cell therapy. I'll show you the examples. This is a patient, again, who was referred as a renal, as a anal mass. You can see sheets of atypical cells with blasty chromatin and a monocytoid/immunoblast-like morphology. The CD45-20 B cell markers were negative, plasma cell markers were positive, EBV and MUM1 positive, MYC positive. So this is a typical example of plasmablastic lymphoma. We recommended screening for HIV, and HIV was positive. We move on to inborn errors of immunity. This is the new terminology instead of primary immune deficiency. These are rare, mostly in children. There's more than 100 types, but 18 types are strongly related to lymphoproliferative disorders. Some of the common disorders are seen here, and you can see that most of them are associated with EBV. They commonly present with B cell lymphomas. Some of them can present with T cell lymphomas. I'll share some examples of two diseases. So first up is ALPS disorder. So autoimmune lymphoproliferative syndrome, where you can have the benign finding of CD4 negative, CD8 negative expansion of T cells in the lymph node, or the patient might present with follicular hyperplasia and PTGC, so progressive transformation of the germinal center with this big nodule in the center. You can stain it with IgD. To highlight the PTGC. Lymphomas are rare, 3 to 10%, can present with B, T, or classical Hodgkin lymphoma. This is an example of one of our patients with ALPS who presented with a T cell lymphoma, and EBV was positive. The second most common immune deficiency is common variable immune deficiency. They can have a variety of clinical features. They can be totally asymptomatic or present with autoimmune disease, granulomatous inflammation, or enteropathy, and all the way to lymphoid malignancies. This is a patient who's actually a physician who was diagnosed initially as ankylosing spondylitis, presented with aphthous ulcer and joint pain, later on developed pulmonary nodules, which were granulomatous, AFP negative. She went on to develop pericarditis and then even enteropathy findings and colitis. At the end, she was diagnosed with a very rare variant of common variable immune deficiency. I share with you our index case, Layan, who was a 3-year-old girl presented with generalized lymphadenopathy. Lymph node showed granulomatous inflammation. AFP was studied, the lymph node was studied with bacteria. So this was kind of like a BCGitis. Later on, lymph node biopsy showed a polymorphic lymphoid proliferation with a spectrum of disease. So we couldn't call it lymphoma, but it showed some large B cells, some large T cells, CD30 positive in the immunoblast. It wasn't Hodgkin, EBV was positive. So we raised the concern for lymphoproliferative disorder. Later on, she developed massive lymphadenopathy. This lymph node showed diffuse sheets of large cells now, CD20 positive, Ki67 positive, EBV positive, so large B-cell lymphoma. Iatrogenic is lymphomas that occur, or lymphoproliferative disorder secondary to prolonged therapy for methotrexate, for example, in rheumatoid arthritis, and the morphology will be the same. The last entities that we will discuss is the EBV, lymphoproliferative disorder with no known immune deficiency. So the first one will be EBV positive diffuse large B-cell lymphomas, and they usually are described in the elderly. The new classification has aborted the suffix of in the elderly. It can occur due to immune senescence, it's aggressive, and will present as a morphologically common to present as a T-cell rich B-cell lymphoma. So this is one of our patients, 85-year-old with EBV positive. Now there are reports that younger age groups can also present with EBV positive large B-cell lymphomas, no known history of EBV, and they have a better prognosis than the elderly age group. This is one of our patients, which was a child who presented with no known history of immune deficiency. And you can see the sheets of large cells, CD20 positive, EBV positive. You have to raise the concern that this might be secondary to immune deficiency, but now we know that they can be without underlying disease. The last entity is lymphomatoid granulomatosis. So this was first described by Libo, and it occurs in the lung. The main findings here, or the main tips, takeaway is you have to have lung involvement. First, we used to describe them in the brain or skin without lung involvement. So it has 100% occurrence in the lung. You have angiocentric pattern, angiodestructive pattern. This is a patient who presented with seizures and then again with lung lesions, documented to have angiocentric, angiodestructive disease. And CD20 was positive, EBV was strongly positive. So this is grade 3 lymphomatoid granulomatosis. And you can grade the lymphomatoid granulomatosis according to the large cells and the EBV positive cells per high power field. So as we conclude, we have seen that the EBV positive lymphoproliferative disorders consist of multiple clinical entities, but you have to keep in mind that the list is growing and that you have to consider other new modalities that can lead to immune deficiency. And the morphological spectrum can range from a reactive atypical to all the way to a polymorphic lymphoid proliferation and to a monomorphic BT or a classical Hodgkin lymphoma. Now, even though they are heterogeneous lesions, the EBV plays a major role. We have seen that the chemokines and LMP1 play a major role in the pathogenesis and the oncogenesis of the virus. Accurate diagnosis needs morphological, pathological, and clinical genetic findings. And it might be time for a reappraisal to look into the polymorphic versus monomorphic PTLDs. I leave you with a final thought that the EBV-related lymphoproliferative disorders are a group of hitherto maladies. Our immune system is a complex and mysterious creation. So take care of it, everybody. Thank you. Thank you.
Thank you, Dr. Shamail. We have no time for a question. It's really very comprehensive, informative presentation from Dr. Shamail. Thank you. Next speaker, Dr. غالب اليماني. أقدر أقول ختامها مسك معه. الدكتور غالب اليماني معروف للجميع. دكتور he is hematopathology. He has a PhD in hematology from Egypt and fellowship in hematology or hematopathology from Canada. He is working now as a hematopathologist at military hospital in Riyadh. He is head section of hematology. He will present another topic which is under the lymphoproliferative disease, which is Castleman disease. Dr. Ghalib, you can start, please.
Assalamu alaikum. Good evening, everyone. I know, first of all, I have to thank you, my colleague, Dr. Maher, for a nice introduction. Thank you for scientific committee, and thank you, Dr. Saeed Shiban, for invitation. And many thanks for the audience who waiting until now. I know this is the last presentation, and I know everyone ready to home or ready to fly, we will go fast as possible as I can. So today we'll discuss a rare disease, lymphoproliferative disorder, a rare lymphoproliferative disorder. This is the agenda, but don't worry, I will go quickly. Okay. So as we know, Castleman disease is a rare Okay. Castleman disease is a rare lymphoproliferative disorder, but we as hematopathologists or as pathologists, the rare disease should not be a rare diagnosis. This is very important for any pathologist. So it is a rare heterogeneous group of lymphoproliferative disorder described 1950 as a localized mediastinal mass lymph node enlargement with characteristic increased number of lymphoid follicle and germinal cell regression and the capillary proliferation. So Castleman disease can be clinically divided to unicentric or multicentric. Unicentric is localized and they carry excellent prognosis, whereas multicentric is a systemic disease usually associated with inflammatory and the symptom like lymphoma, B-cell lymphoma, and usually occur in the setting of HIV infection and usually associated with HHV8. Castleman disease, although usually have characteristic feature, is easy to confuse with other disease. And this is why he is usually misdiagnosed by a lot of pathologists because you have overlapping between the reactive and the inflammatory even and a malignant condition. If we will go quickly, as mentioned before, it can be divided to unicentric and the multicentric. Unicentric is the most commonly represented 80% of the cases, whereas multicentric represent around 20% of the cases. The majority of unicentric have hyaline vascular variant, whereas multicentric have the majority have plasma cell type, and in between there is a mixed type between both types. Multicentric is further subdivided according to the new WHO classification to Baum's associated, HHV associated, or idiopathic, which is HHV negative, and the idiopathic further divided to Tafro syndrome associated or NOS or other condition. So again, this is the classification, but if you look to the color and shadow, the color and shadow represent the most frequent histopathological finding associated with unicentric. If you look to here, unicentric is mostly hyaline vascular, and this is in low frequency in multicentric. Similarly, regressed germinal center and the follicular dendritic cell predominance and the vascularity is more common in unicentric than in otherwise. Multicentric usually have plasmacytosis and hyperplastic germinal center. This is the characteristic feature of Castleman disease. If you look to the slide number A, we will see multiple and many follicular lymphoid follicle with regressed germinal center, and by high power we will see the same increase in vascularity in the interfollicular area with multiple germinal center in the same follicle, which is called twinning. Again, here in the lower part, we'll see what's called immune skin appearance of the mantle zone, multiple centric, concentric around the germinal center, which show usually vascular proliferation and sclerosis and what's called low Bob lesion. اوكي مفيش ممكن اخد ال Okay, we'll move to the next slide. This is more this immune stain which is showing twinning of germinal center highlighted by CD23, and also increased the follicular dendritic cells as shown by CD21 or 23. The histological feature of plasma cell type, again, usually there is no a significant regression of the germinal center. There is accentuation of the mantle zone, which looks like onion skin appearance as well. But if you look to the interfollicular area, the predominant feature is massive infiltration by sheaths or aggregate of plasma cell, which is a characteristic of plasma cell type. Another slide showing diffuse infiltration by plasma cell, and also increase vascularity was highlighted by CD138. So this is a table from WHO, which is the fifth edition, showing the grading of Castleman disease based on the histological feature, which regrades germinal center, follicular dendritic vascularity, hyperplastic germinal center, and is graded from 0 to 3. And the H1, grade 0 usually representing no regressed germinal center in first one. And the grade 3, most of the germinal centers show are atrophic. Similarly, follicular dendritic cells, there is no prominence of follicular dendritic cells. And the last one, there is extensive and significant prominence of follicular dendritic cells. And similarly, in the vascularity, there is normal vascularity, and the last one, and so on. We will go a little bit fast, but all are the same. The grade 0 represent normal or no increase, and the grade 3 represent the prominent feature, and in between, the grade 2, 1 and 2 represent in between. Also, this is the last classification of WHO. It is almost like as previously discussed. It is unicentric, which is hyaline and the plasmacytic and the mixed one. And the idiopathic can be divided to NOS and or TAFRO associated. And the last category is HHV associated multicentric Castleman disease. And these are based on lymph node enlargement, number and the size and the histological feature above, and the positivity or negativity for HHV8. We will go a little bit fast. This is the characteristic major criteria required for idiopathic multicentric. I will not go in details because the time. Major criteria, and there is minor criteria, there is exclusion criteria, and also major criteria depend on a histological feature of the lymph node as mentioned in WHO. And can be in someone details. This is published in the Blood 2022 in a discussion of all these details. Again, this is the criteria to diagnose idiopathic multicentric with TAFRO associated. There is like major criteria and there is minor criteria. You have to 3 out of 5 from this criteria, and the minor at least more than 1. And the differential diagnosis, we have to wait a little bit here because it's very important for my colleague and as a pathologist to differentiate between Castleman disease and other reactive and inflammatory and the malignant disease. As we see, the histological feature, although it is characteristic for Castleman disease, but usually there is an overlapping between inflammatory and the infection and the other even malignant disease. So the unfortunately differential diagnosis is broad differential diagnosis for Castleman disease. But usually, if we go carefully to the histopathological examination with immunophenotyping, with some ancillary study, flow or molecular, in addition to the clinical and the laboratory and the radiological finding, usually we can reach the right diagnosis of Castleman disease. The most challenge differential diagnosis is HIV-related generalized lymphadenopathy, because almost have the same histological feature, plasmacytosis, vascular predominance, hyperplastic, regressive changes maybe are seen in this case. So it is sometimes very challenging to differentiate. The other issue which is important, angioimmunoblastic T-cell lymphoma, as we know, this is type of lymphoma have usually a vascular proliferation, sometimes with plasma cell infiltration, so and also maybe have even lymphoid follicle morphology like Castleman. So it is very important by careful examination, by looking for abnormal T cell, which usually CD30 or CD10 positive, we can differentiate. But from the first look, it can be mixed together. This category, although it is rare, but I have two cases as a case scenario. First diagnosis as Hodgkin lymphoma. As Dr. Said and Dr. Shamal said, not all CD30 are Hodgkin lymphoma or something like that. You have to look to the background, you have to look to the immune stain, you have to look to the clinical, you have to look to the radiology. So unfortunately, there is some case of Hodgkin lymphoma with Castleman disease like a change, which is a big challenging for pathologists. But in Castleman disease, if you look to the interfollicular areas, they will see a lot of many cells are RS-like cells with positive CD30, which is usually confused with classic Hodgkin lymphoma. But this is usually represent immunoblast, reactive immunoblast, or plasmablast in plasmablastic type. Again, we will go a little bit slow in differential diagnosis. Maybe early mantle cell lymphoma can be confused with Castleman disease due to expansion of the mantle zone. IgG4 also related disease can be one of the differential diagnosis. Other benign conditions, the lymph node, inflammation, infection, autoimmune, this is especially rheumatoid arthritis, systemic lupus, and syphilitic lymphadenitis can overlapping and has the same feature like Castleman disease. So careful examination, maybe clinical, all this is very important to reach the diagnosis. Another differential diagnosis, LBL, can be also confused with Castleman disease, especially sometimes have interfollicular plasma cell infiltration, and it will be a challenge if this plasma cell are monoclonal kappa restriction will be also one of the differential diagnosis. Of course, there is a lot of long list of Castleman disease differential diagnosis, reactive lymph node, low-grade follicular lymphoma, adult onset disease. So we'll little bit. So careful examination for pathological with immune histochemistry, clinical radiology, all are required. The clinical feature, I will go a little bit fast. Usually unicentric is asymptomatic or presented by mass or mass-related compression or pain. Multicentric, as mentioned, systemic inflammatory like B-cell symptom, fever, weight loss, anasarca, generalized lymphadenopathy, hepatomegaly, all are this similar to the, lymphoma. Multiple centric with Bombs syndrome associated with, like as we see, polyneuropathy, organomegaly, endocrinology, and so on. Tafro, again, also is thrombocytopenia, ascites, fever, and the reticulum fibrosis. And there is some, as mentioned before, there is major criteria and the minor criteria to diagnose this one. And what is the associated condition and the malignancy we can find in with Castleman disease? Hyaline vascular Castleman disease can be associated with follicular dendritic cell sarcoma. This is very important, especially in case of rare hypervascular with stroma-rich type of Castleman disease, which usually have spindle-shaped like proliferation, which is more predominant in the interfollicular area, so can be confused with follicular dendritic cell sarcoma. Also, vascular tumor can be associated. Of course, HHV8 multicentric can be associated with Kaposi sarcoma or large B-cell lymphoma or primary fusion lymphoma. Idiopathic can be associated with classic Hodgkin lymphoma, diffuse large B-cell lymphoma, mantle peripheral, and the other can be amyloid or paraneoplastic pemphigus and Bohm syndrome. The pathogenesis for Castleman disease is not clearly understood. However, there is some certain concern about certain role of interleukin-1 in unicentric, and interleukin-1 and HHV8 in multicentric has been well described, and which is due to cytokine storm. So interleukin-6 is one of the critical major factor in pathogenesis of this one. What is the cytogenetic and the molecular finding? Recently, some published article appreciate subset of cases with hyaline vascular type associated with cytogenetic abnormality like translocation 116, 122, or 78, and note that B and T cell in Castleman disease is usually polyclonal, with few exception in HIV infection, if HIV associated, but normally it is polyclonal. Monoclonal, all I said, only in HIV. And recently, there is platelet-derived growth factor receptor beta R detected in 17% of unicentric lesions. So some people say it is a reactive or benign condition. Some people say it is neoplastic. Some people say it is benign neoplastic condition. So, but until now, it is categorized as a benign condition. So we'll go quick in 4 cases. I don't know if I'm going fast. Well, it's okay. Okay. Case 1. This is a gift from Dr. Said for all audience. It is very straightforward case. 40 years old female with mediastinum lymphadenopathy. But unfortunately, Dr. Said give me this all information. I don't have what is the radiology, what is the other serology, but this is my information. So it is a classic case. It is textbook. If you look to this H&A, there is onion skin-like appearance, some atrophic German center, the interfollicular area expanded with vascular proliferation. If you look to the high powers, it is very clear now with sclerotic vessel in the German center with giving what's called lollipop lesion. The vascularity is very appreciated here. So also this is like twinning of the German center. There is vascular proliferation around. So this is a classic and textbook of histological feature of unicentric Castleman disease. The second one is 24 years old female known to have acetylcholine receptor antibody positive myasthenia gravis, which is autoimmune disease. Okay, presented by shortening of breath, oral thrush, acute myasthenia gravis exacerbation, need ICU admission. During her hospitalization and during routine radiological investigation, they found a large pelvic mass, and the mass is surgically excised. So this is a mass, pelvic mass, very huge mass by CT, and there is some other lymph node enlarged around. Okay, this is an H&E by low power. I think everyone will think about Castleman disease. Also, what is the differential diagnosis? So if we look here, there is a mini small lymphoid follicle. Some are atrophic, some are it's okay, but the majority are atrophic. There is also look to the onion skin-like appearance. Look to the interfollicular area, which is very important. There is a vascular, there is hyper proliferation of the vascular component in the interfollicular area. Also, look to the lymphoid follicle. It is bizarre looks. The majority are this irregular, and some have, as mentioned, atrophic. The majority have already atrophic German center. Again, look again to the interfollicular area. There is increased hypervascular, and there is infiltration by. If you look carefully, there is looks maybe difficult to appreciate in the low power, but we'll go by high power to see the nature. This is the nature of interfollicular area. Look, this is the majority of the interfollicular area. In addition to lymphocyte and plasma cell, we like spindle shape. So the interfollicular area is there is a lot of spindle shape, like there is proliferation of spindle shape with, of course, increased vascular proliferation.
5 minutes, please.
Okay, so if we look, also again, there is onion skin and there is vascular sclerotic blood vessels. This is the immune histochemistry. CD20, 21 is negative, only few, and the CD34 highlight vascular blood vessels. Immune histochemistry done. The German center BCL2 negative. The spindle shaped was positive partially to smooth muscle act, but negative for CD20, ST100, desmin, and the other cytokeratin and CD31 and CD34. HHV were positive. So what is the diagnosis of such a case? It is Castleman disease, but which type? This type is based on the finding in the interfollicular area. This is a stroma-rich variant of Castleman disease. Okay, this is a rare entity of hypervascular type in which there is the predominant cells in the interfollicular area is a spindle shape. This case already published by Dr. Fadel a couple of months ago. Okay, we'll go. The learning point to such a case, you have to put differential diagnosis of Castleman disease in autoimmune disorder if you have patient with autoimmune disorder. So we'll go quickly, as although Dr. Maher, my friend, but he's strict on time. Okay, we'll go quickly. Case 3, 45 years old, female, present by Gerard lymphadenopathy, and was diagnosed in other hospital as a classic Hodgkin lymphoma. Referred to my institute, Prince Sultan, as to slide review and to start treatment. Look to the lymph node. There is follicular hyperplasia, but the German center, if you look, it looks it is hyperplastic, not regressed or atrophic. Also look to the interfollicular area. There is vascular proliferation, and there is, if you look to the mantle cell, it is also there is like what's called a skin onion skin appearance, maybe not prominent, but it will be prominent in this one. And look to the vascular area, and look to the interfollicular area. There is a lot of plasma cell here infiltrating the interfollicular area with vascular proliferation. We will go a little bit fast, as Dr. Maher. Okay. Again, plasma cell, very clear infiltration here, and there is also sclerosis across the lobo lesion. Plasma cell again, plasma cell very clear now by high power. Now we see CD3, CD20 highlight B and T cell. CD138 looks to the 138. The interfollicular area is extensively infiltrated by plasma cell. And this is kappa and lambda. It is polyclonal kappa and lambda. And HHV8 was positive. Interesting, HHV8 is positive. Now, by the positivity HHV8, now it is easy to diagnose easily Castleman disease in the setting of HHV. This is high power HHV. So this case is HHV associated multicentric Castleman disease. The last case, which is 2 minutes only by okay. As mentioned before, it is diagnosed as classic Hodgkin lymphoma in other hospital based on the positivity of CD30 and the partial expression of CD15. But if you look carefully to the background again, you have to not all CD30 positive is RS cell. It looks like RS cell cell, but if you look carefully to the immune stain and other immune stain can be differentiated. Case 4, last case, 49 years old, no case of HIV, and presented by FUO, generalized lymphadenopathy, hepatosplenomegaly. BCT is increased metabolic uptake. Okay, metabolic uptake is a maximum 8.7 hepatosplenomegaly, and you go to the HNA. Look again to the HNA. We will see this regular or irregular lymphoid hyperplasia, interfollicular expansion with increased vascularity. If you look here again, maybe by high power, you will appreciate plasma cell. If plasma cell is extensively infiltrated, this is the onion-like by high power. This is very clear onion scale-like appearance. And if you look again, more clear now, it is a classic picture of Castleman plasma cell again. Look again, more and more onion-like with vascular changes. If you look to a lot of this, look, this is why this case also, by the way, this case also diagnosed outside as classic Hodgkin lymphoma based on this morphology. It is a large cells, RS-like cells with which will see again by high power. It looks like RS cells. This is why very careful examination of the histological slide need, and we'll see also by immunostains. This is CD3 and the CD20 and the CD138 and the plasma cell extensive infiltration in the interfollicular area. Look, Kappa is positive and lambda is positive, but it is done by ISH, not by classical immunohistochemistry. CD20 is negative, only highlight in the follicle. And look to the CD30 again, which is a very important issue from this presentation, to be careful about CD30 positive cell. Now, if you look to this is a classic, this is CD30 positive, CD15 is negative, which is usually we don't rely on CD15. Look this one. So any pathologist not expertise in lymphoma will see RS-like cells is positive CD13, and maybe this is why this diagnosed again as classic Hodgkin lymphoma. Again, HHV is positive and the CD31 highlighted vascular, but I didn't think this is, we are, as mentioned, this is HIV. So we are looking for it is Kaposi sarcoma or not. And I think until this level, we can say it is Kaposi sarcoma. But unfortunately, this guy, after 1 year, it is diagnosed presented by skin mass, chest mass, and diagnosed by Kaposi sarcoma. And this is my last slide. And this is my reference, and thank you so much. And maybe I'm going fast because I know everyone need to fly. And also we need to fly.
Thank you, Dr. Ghalib, for a very informative presentation. It's really challenging to diagnose Castleman. If we have time for discussion. For question. One question for... I have one question for Dr. Ghalib before we close. It's appeared to me that the Castleman diagnosis is mainly in lymph node. My question is, what is the role of bone marrow in like this condition?
Of course, bone marrow have some finding. Okay. In such a case, bone marrow can be involved by Castleman disease, but the usual presentation is presence of plasmacytosis in the bone marrow. This is the main finding in the bone marrow. In such a case, if you examine bone marrow, we usually find polyclonal plasma cell. It is a reactive plasmacytosis, which is, if diagnosed Castleman, this is the main bone marrow finding of in such a case.
Okay, thank you, Dr. Ghalib.
Maybe another, if it is like TAFRO or BOMS association, maybe we'll see bone marrow increase the bone marrow fibrosis, as it is one of the criteria in TAFRO associated Castleman disease. There is bone marrow increase the bone marrow fibrosis.
Thank you, Doctor. Dr. Said, you can close now.
Okay, Jazakallah khair. Thank you very much. for all speakers and all dear moderators. Thank you very much for all your patience and being attending with us until late time during weekend. Thank you very much and see you inshallah in another session soon inshallah. جزاكم الله خير جميعا.